That's how you know. Good morning, or thank you for joining us this morning. I would like to call to order the March 16th public hearing of the Human Services Committee. First up today, well, I guess we could see if anybody has opening remarks. No? Okay. First up today, we have a long list of people we're going to be hearing from. First up, we're going to be hearing from the Department of Social Services. Commissioner Barton Reeves is signed up to testify, but I understand she is not here. Instead, we're going to be hearing from Mr. Guy Woolston, representing the department. Good morning, sir. Is your button on?
Thank you.
Thank you very much. Could you start again, please?
Guy Woolston, Department of Social Services. I'm sorry about that. Good morning, Senator Lesser, Representative Gilchrist, Ranking Member Seminara, Ranking Member Case, and distinguished members of the Human Services Committee. My name is Guy Woolston, and I'm the Medicaid Director representing the Department of Social Services today. I'm pleased to appear before you to present testimony in several bills. I know there are a lot of people, and we have extensive written remarks. I'm going to focus on summarizing the key points, and of course, would love to answer questions that you all have. I'm going to start with Senate Bill 1202, an act concerning prescription drug affordability. Section 4 of this bill establishes a prescription drug payment evaluation committee to provide recommendations to the Office of Health Strategies on upper payment limits on at least 8 prescription drugs, using other states or foreign jurisdictions as a guide. DSS is named as a member of that committee. While DSS appreciates the intent of the bill, setting an upper payment limit is a resource-intensive process that requires economic and clinical analysis that have not been funded in the governor's budget. Additionally, since other states are just beginning the process of implementation, we would recommend we partner with other states in any initiatives once best practices have been clearly established. Moving on to Senate Bill 1203, an act concerning medical debt. The department is broadly supportive of the goals of Section 1, which is targeted at reducing the burdens of medical debt for low-income individuals. Although we support these efforts, the department wishes to better understand the proposed framework in Section 1 and explore how to achieve these goals while also maximizing opportunities to connect individuals with Medicaid coverage. DSS looks forward to continuing conversations and collaboration on how to best address these issues, while again maintaining the hospital's ability to assist patients in getting signed up for Medicaid, which is critical for them and for the hospital's finances. Moving on to Senate Bill 1205, an act concerning Medicaid reimbursement for peer recovery supports and services. This bill requires DSS to provide reimbursement to certified peer recovery support providers enrolled in Medicaid. Just for context, recovery coaches are part of the larger service delivery category. Many certified peers, including recovery coaches, are state or grant funded through our sister state agency at DMS. As part of our substance use disorder 1115 waiver approved in April 2022, Medicaid does now reimburse for services provided by certified peers, including recovery coaches, within the SUD residential treatment settings in some ambulatory settings. Additionally, peer support services are available to Medicaid members who receive supports under the mental health waiver. Given the recent expansion in coverage through the SUD waiver and the other mechanisms in place for reimbursement, DSS does not support the bill, which would require the department to amend its state plan. We want to commit to continuing to work collaboratively with our sister state agencies, DMS, the Department of Children and Families, to explore opportunities to include individuals with lived experience as part of a treatment or support plan for Medicaid members. Moving on to House Bill 6885, an act concerning Medicaid payment rates. Our testimony here is long. I'm not going to read all of it. I know time is short. I'm just going to summarize the key points and would love to answer questions. So sections 1 through 3 of the bill require rate and service coverage changes, while section 4 requires a rate study. I don't need to tell you that the DSS currently lacks a systematic approach to assess rates across our provider types. As a managed fee-for-service state, we have an obligation to set the rates, which has impacts on our members' access and availability. The current process has resulted in uneven setting of rates, where some providers, the rates are uneven and some are higher than others. The governor's recommended budget allocates $1 million of ARPA funding to enable DSS to contract with a vendor to undertake a comprehensive Medicaid rate study. This consultant will be tasked with recommending payment reform methodologies and assisting with setting rates. Because there are roughly 430 different provider types within Medicaid, this is a big undertaking that, in our view, should be done systematically rather than a piecemeal approach. We strongly, for the reasons and given the lack of funding for this bill in the governor's budget, we oppose the bill. However, we strongly encourage approval of that $1 million in the governor's budget to do that systematic rate study. In the written testimony, we provide more detailed comments. Just a quick summary. Section 1 would require us to align our rates to those in Medicare, and by fiscal year 2028 would require the rates to be equal to those in Medicare. Just 2 quick comments on that. One, many providers in Medicaid actually don't have a Medicare equivalent. Some providers do, right? A cardiologist would have something Medicare, but other providers don't. So just want to make sure the committee is aware of that. And then second, if Connecticut did set Medicare and Medicaid rates equal to one another, we would be an outlier. That's would be extremely unusual. Other states almost always have the Medicaid rates substantially lower. I'm going to skip section 2. It's important, but our written testimony touches on it. Section 3 requires DSS to increase rates for emergency medical transportation services by 10% each year until the rates equal Medicare rates, and provides for an annual rate increase thereafter. Just a little bit of history here. In 2015, there was an emergency medical transportation rate increase due to a change in DSS methodology to mirror what happens in Medicare. Again, in 2021, there was a 10% increase in the ambulance rates that impacted both emergency and non-emergency rates, and the written testimony provides some detail. There's just context on I think we collectively have made progress on the rates in this sector, and because a further rate increase is not supported until we do that more comprehensive review, and it's not in the governor's budget, we need to oppose it. And then finally, section 4 calls on us to perform a rate study for long-term acute care hospitals and methadone providers, and to provide a report back by October 1st of 2023. As I outlined at the top of the testimony, definitely think we need to look systematically across the rates, and we would urge you to do that in a comprehensive way rather than provider type by provider type. So those are my remarks, and would love to answer questions.
Thank you, Mr. Wilson, for your testimony. It's good to see you, and appreciate your comments on the full range of bills that we have here today, and look forward to working with DSS on many of those details. I'm going to just keep my remarks, my questions really focused on that last bill that we talked about, the Medicaid rate bill. Yep. First off, you mentioned that we would be an outlier in providing, if we were to move towards providing the same reimbursement rates for Medicaid as we do for Medicare. That may very well be the case. Is there a policy rationale, though, for paying Medicaid providers less than Medicare providers? Good question. States try to do that to contain the cost of the Medicaid program. I think that's the main policy rationale behind the status quo there. And just for purposes of reference, I understand that there are exceptions. There, you said 30 provider types, some large number of
Yes.
provider types.
Yeah.
So I think there's been a sort of an ad hoc piecemeal response to it.
Yes.
But in general, where are we today? What is the percentage of Medicare that Medicaid providers are paid?
Yeah, it is a bit of a patchwork quilt. And in I think our February or maybe our January MAPOC, we tried to give a bit of an overview, scanning across provider types. And I'm not gonna be able to do justice to all of that without my notes. But what I can say is that for some provider types, notably primary care, we are at Medicare rates today. For other provider types, for example, medical specialists, the bulk of them, well, there's some carve outs, but the bulk of them were at 57.5% of Medicare 2007 rates. Then I do want to make sure there are a lot of providers in Medicaid who don't have a Medicare equivalent. And that's in part because Medicaid has a richer, more complete benefit, especially for people who are disabled. And so there isn't that straight comparison. So anyway, that's why that answer is a little bit more complicated than it might first seem at first blush.
So first off, I that would be really helpful if we could actually get a list of provider types that don't have an obvious Medicare. I don't know if that's something that.
Sure, we can certainly summarize. We can
track
give you a sense of the big buckets where there's not an equivalent for sure.
Yeah, I think we're familiar with a few of those, but I think we would love to get the full list of
Happy to
provider
do that,
types
yep.
that don't have the Medicare equivalent.
Yep.
But 57.5% of 2007 rates.
That's right.
So that was 16 years ago. And there's been a lot of inflation just in the overall economy. I assume there's been higher inflation in medical costs of care. So I'm imagining that's pretty. Do you have a sense of how far off that is from what Medicare is paying today?
It's a good question. I don't know exactly. And then so just a little bit of a deep dive into how Medicare sets its rates. They've actually changed it over the last 16 years. For the beginning part of the 16-year period, they inflated the rates using something called the MEI, the Medicare Economic Index. And then separately, a RUC committee would reevaluate how complicated it was to do a procedure. So some procedures, grew faster than the MEI, some grew more slowly. So it's hard to give a comprehensive answer, but it's certainly true that across the board, the value of what Medicare paid in 2007 has eroded due to inflation between 2007 and today.
And so has the director of the state's Medicaid program, have we seen access issues for folks accessing medical specialists due to the erosion of those rates?
We have, yes.
Okay, that's helpful. Now, with regard to I'm not sure if this is the best venue to have a conversation about the $1 million that DSS is requesting in the project. I think that may be a better conversation in an appropriations context, but it would be helpful as well to have more, to hear more from the department about how you would intend to conduct that study and what parameters you would attempt to employ, what questions you'd be looking to ask, because I think depending on what questions you ask, you could get very different answers. And we're going to be hearing, I think, from a lot of providers today, both folks who are currently in the bill and other folks who are not in the bill who want to be, and they're going to have a lot of questions about what DSS intends to do here. So without going too far out of our cognizance or out of the bill that's before us, could you just give us a sense of why we should not move forward with solving the problem now, but instead punt it to you?
Sure, and very happy to have those conversations offline in whatever forum is needed. The overall rationale is there are a lot of different provider types who are paid with different methodologies, and there's been a bit of a patchwork quilt. And one concern is that providers who may be really important for the Medicaid program, but may not be as organized, or Medicaid may not represent a large fraction of their panel, but they're still important to the Medicaid program. They may not be coming forward as eloquently as other providers are, potentially. So the idea is to try to take a step back, look comprehensively across all the different providers that we have, try to benchmark to what other payers, Medicare and commercial, are paying when we can, benchmark to costs when we cannot, and then come back with a sense of, if you think about access, if you think about what other providers are paying, how are we doing across those 430 different provider types, to then give the legislature, the purse strings, the information that you would need to say, okay, obviously you'll make your choices, but at least to inform you on, here are the provider types with the biggest outliers relative to those benchmarks. The only other thing I'll say, Senator, is that as you know, Connecticut is a fee-for-service state. We don't have managed care. Most states in Medicaid program have managed care, so the managed care organizations do this. 2 states that, like us, are fee-for-service, Maine and New Mexico, have done a process like this recently. And we can share links to those reports. And we've gotten a lot of really positive feedback from their legislature, I think it's been really helpful there. So the model in my mind is basically following in the footsteps of what those states have done, and we can include links to those in our written remarks.
Thank you. That's super helpful. Just going through the bill as it is before us, and bills always change in this building. Section 1 of the bill increases Medicaid rates for fee-for-service providers. Section 2 expands Medicaid coverage, and then the subsequent sections increase Medicaid rates for medical transportation services, and Section 4 is a study on certain providers that have asked us for particular consideration. But the first part, I understand that Medicaid is complicated. I remember recently OHS Director Gifford asked me if I understood it, and I laughed at her. Like, nobody understands it. But the first part, because we're not talking about cost-based reimbursement providers and other more complicated formulas, which I understand might require a study, just simply increasing Medicaid rates for individual fee-for-service providers. Can you give us a rationale for why we ought not proceed to just true up their reimbursement rates?
Yep, no, it's a great question, Senator. If I were I'll speak if I were in your shoes, and you'll obviously make your own choices, but if I had a fixed budget to spend on changing rates for Medicaid providers, I would want to think carefully and systematically across the whole program. I wouldn't want to spend my budget, the analogy of looking for your keys underneath the street light. There's parts of the program where it's more straightforward to do that comparison. 57.5% of Medicare 2007 rates, that's very easy to understand. There are other parts of the program where it's, in part because they don't benchmark to Medicare, it's harder to make that comparison. So I think the rationale for looking comprehensively is just to make sure that if you had a fixed budget, that you're spending it in the way that most advances your goals for the program.
Great, thank you. That's all the questions I have for you at the moment, but I am sure there are other members who do. Representative Gilchrist.
Thank you, Senator. And thank you for being here and for your partnership and knowledge on Medicaid. So I'm going to focus as well on the Medicaid rates bill and just some clarifying questions on what was just being discussed. So of those roughly 430 separate provider types, those are all fee-for-service provider types.
Yes, the only reason I'm hesitating is that people use fee-for-service in slightly different terms. Those are all the providers that are enrolled in our program, and we are a fee-for-service program.
Okay.
Some of those providers, some of those 430, some are nursing homes where we pay them based on their costs. And so by some definition, that wouldn't be fee-for-service, that's cost-based. So sorry, I guess it depends a little bit on what exactly you mean by fee-for-service. Medicaid is complicated. I'm sorry, Representative.
So, well, no, it is. So, but in section 1, if what we're proposing to do is the providers who get fee-for-service, that wouldn't address the nursing home. It would address provider types other than, right, those other buckets.
Right. In my reading of the bill, and obviously I defer to you all on what the intent was, I read that to mean when there is a Medicare equivalent, you would true up for the provider types where there is like a cardiologist, a primary care doctor, things like that. I read section 1 to mean for the other provider types like nursing homes or residential care homes, section 1 would not apply, but I'm not sure if that was the intent of section 1.
Yes. Okay. Thank you. That's helpful.
And if I'm reading it wrong, obviously, sorry about that.
No, you're getting it right. So then what you said earlier, are there within that 430 provider types, are there providers who are getting above the 57% of 2007?
There are. And we can give you a full list. Over the years, the legislature, and this goes back a little bit to to the patchwork quilt approach. Over the years, the legislature has authorized rate increases for a small number of medical specialists. And then separately, primary care under Medicaid is substantially higher than that 57.5% of the Medicare 2007 rates. So we can get you, I think we have this offhand, we can either get you the full list or a very good sense of which providers are above that 57.5%, if that would be helpful.
That would be, thank you. And then another, Senator Lesser touched on it and you responded that yes. Do you have any data or feedback from providers or Medicaid recipients that they're struggling to access services? What we're hearing is that there are providers who just financially cannot afford to take Medicaid. And so they might limit to 1 Medicaid patient a month or 5 Medicaid patients a year. And so even though it looks like providers are accepting Medicaid in the state, individuals are really struggling to access.
Yeah, no, it's a great question. We do, and let me, if it's okay with you, I'd love to follow up in writing to make sure we outline the data and the information there for you.
That'd be great. Thank you. I think that's it for now. Thank you so much.
Thank you, Representative. Other questions or comments from members of the committee? Yes, Representative Dathan.
Thank you very much, Mr. Chairman, and thank you so much for your testimony today, Mr. Rolston. I'm going to also focus on the Medicaid rates. Just a quick question on the rate percentage, the 57% of 2007 rates. Is that a weighted average? Because we have a $4 billion program, or is it simply an average of all of our rates?
Great question. It's neither. It's literally 57.5% of the Medicare 2007 rate. So for a cardiologist or a dermatologist, for a given procedure code, what we pay, we look at what Medicare paid in 2007, we multiply that by 57.5%, and that's what we pay. So it's not a basket. It's literally it's what it is for all. Again, there are some providers, and I'll follow up with Representative Gilchrist where it's higher, but for the ones where we haven't, it's literally that amount.
Okay, so that's why the study of 430 separate providers might be really important, and also probably delving into some of those provider codes, because from what I'm understanding, a cardiologist might have one provider code for, let's say, a bypass surgery, or and another provider code for just doing another shunt or something like that. Is that correct?
That is. So just I won't go too deep into how Medicare does it, but it's relevant because our fee schedule is based on it. So in the Medicare program, there's something called a relative value unit, or RVU, where a committee, it's actually through the American Medical Association, it's not part of the government. They think about what it costs a typical provider to deliver a service. And that includes things like the physician, her time, her staff's time, the capital costs, malpractice insurance, all this stuff. And they then generate a rate, which would say, doing a bypass surgery is more complicated than an office visit for a well patient. So those are reflected in the relative value units. Medicare has an extensive process, the ROC, to update those, because technology changes, costs change. There are new procedure codes that come out. And so that the Medicare fee schedule is organic. It changes every year, both due to inflation, as what Senator Lesser was saying, but then also because the Medicare's view of how expensive it is to deliver something changes. And I only brought you into that detail just to give you a feeling of, while the ROC, the Medicare process, isn't perfect, people think specialists have too much power on the ROC. It is a thoughtful and constantly updated process for setting rates, and it's one that many payers, including Medicaid, look to when we're setting our rates. And that's, I think, part of the reason why way back when we linked our fee schedule to that of Medicare. It's a pretty reasonable place to link, I think.
Well,
I wasn't in my role back in 2008, but that's my
I
understanding.
think you were doing something else in
Yeah.
2008, probably. So that actually makes a lot of sense, that maybe a straight increase in rates doesn't make a lot of sense, because we would have to take into account a lot of the nuances within these our RCV codes and other sort of things to make sure that we're raising rates in a methodical way. Is that what I'm hearing?
Well, let me be clear, the department opposes this section of the bill, so I want to make that.
No. I get that.
But so I want to make that really clear, but what is written in the bill, at least as I understand, the intent of the bill would be to say, look, Medicare does their thing. They have the ROC, the relative value units, and we're going to anchor Medicaid to it, just like we do today, but we're going to just have it at a higher rate. So at least as I read section 1 of the bill, when Medicare says a bypass surgery is more complicated than in-person visit, those would be reflected in the Medicaid fee schedule as well.
Got it. Can you give an estimate on time with this proposed study in the governor's budget of $1 million for the ARPA funding? What would the timeline of that to have a delivery to the legislature so that we could potentially act on it in the January session?
It's such a fair question. Let me follow up and Ray. I think it's a totally fair question. I just want to make sure I'm not getting ahead of the team that would actually need to do the work. It's a little bit of a complicated dance because we don't know if it will be approved. So we haven't been able to contract with the vendor to do it. So I'll give you the best information I can in terms of the timeline.
Yeah, I'm just trying to ask questions that are non-appropriation related questions, because I'll save those for my next appropriations meeting in this. But in terms of process, trying to understand who's conducting that, would it be the same sort of people that conducted these studies in Maine and New Mexico?
I think so, and I'll have to double check. I think Maine, and this may be wrong. I'll follow up. I think Maine had Mercer and New Mexico had Meyer. They hired an actuarial consulting firm. But this is sort of what they do. Payers of various sorts will hire them to study their rates, think about access, things like that. And I'm sure I can't speak to particular vendors. I don't want to get ahead of the contracting process. In my mind, we would use a similar outside vendor that has experience doing this type of thing.
Got it. So it wouldn't be just your team trying to do this whole study.
It would not. I mean, there's
pretty comprehensive, it sounds like.
It's pretty comprehensive. We don't have, if I'm totally blunt, we don't have the expertise and the time. And also, I know this is time sensitive for you all. And if you'd ask me that question, Representative, of when the department, given current resources, could do that, I would say 2030 or something, really slow. So
got it. That makes a lot of sense. I mean, Medicaid is a $4 billion program in our state. And I think we need to be extremely thoughtful about how we look at how we are raising rates and make sure that when we are looking at raising rates, that we're addressing some of the things that Representative Gilchrist and Senator Lesser talked about, and making sure that access is key for folks, because we want to make sure. If you could make sure that the administrator gets those 2 studies from Maine and New Mexico, I'd appreciate it. The other question I had is, we have a certain services in our state that we're looking at doing some bundled rates, like the maternity care. How would a change in Medicaid rates affect bundled services?
Great question. And in the example of the maternity bundle, it would impact it less than it would other providers, because OBs are one of the provider types that is not at 57.5% of the Medicare rates. But maybe taking a step back from maternity, if one changed the way the rate that we paid providers, that would change the benchmark payment that providers face under a bundle. So if, just to take a really simplistic example, if there were, and again, I'm not endorsing this, if there were a 5% increase in rates, that would shift if the target for a maternity episode was $6,000 risk adjusted, clinically adjusted, that would shift that to $6,600 if there were a 10% rate increase in that example.
Yeah, because I think one of the key things that the goal of doing a bundled service is to improve patient outcomes. And one of my concerns is if we made a huge adjustment, then we wouldn't have, without reflecting those rates, we might have not as good of outcomes as we do.
Oh, I understand the question. Yeah, we would and again, being clear that
of course, yeah, no.
If there were a rate increase, we would update all relevant, it would kind of flow downhill and we would adjust the benchmark payments for all elements of the program for sure.
Okay, great. My last question really is around how this bill might work with SB 990 when we look at changing the FQHC rates. How would those two bills, in your opinion, work together or against each other?
Such a great question. And FQHCs, I know you know this, Representative, just to say, are a key part of the Medicaid program. They provide primary care service. They're the kind of attributed primary care doctor for roughly a quarter of Medicaid members. They're the backbone of the program. And our last MAPOC, we talked about the important role that they play. I think that's actually a really good example of why the department is advocating a comprehensive approach. Because just for example, section 1 of this bill, because FQHCs are paid not according to the Medicare fee schedule, they're paid according to this PPS rate. They're outside, they would not be, at least under my reading of section 1, they would not be covered under it. And just the senator's question on, make the case for why looking at it comprehensively is a good idea. I think that's actually a good example of it. You probably wouldn't want to increase the rate for a specialist without making a parallel or similar adjustment on the FQHC side. And I think it makes sense to at least have all the data to do that comprehensively across the program.
Thank you. I have two actually other questions that came to mind while we're talking. One, does CMS ever get involved if our rates fall too low that we're not able to deliver services and folks aren't getting access to care? Do they ever come in and say, hey, you guys need to change your rates?
They do. And their policy rationale is patient access. They have, the mission of the Medicaid program is to serve the people that we serve. And if rates are not sufficient, people can't get the care that they need. And for example, the existing rate study on the waiver on the DSS and DDS waivers, we are doing that because CMS required us to do so as a condition for reapproving our waivers. And more generally, Dan Tsai, who's the political appointee in charge of the Medicaid program for the federal government, he's head of CMCS. He has made clear that he's going to use his administrative authority to force, nudge, whatever verb you want to use, states to take a really careful look at their rates.
So has CMS ever contacted Connecticut and said, you guys need to rethink your rates outside of the waiver programs?
Great question. To my knowledge, no. But let me check with I can't speak for I'm still in my first year. Can't speak to before that. They've not since I joined, but let me get back to you on the broader answer.
That's great. And then just for the avoidance of doubt, any increase of rates that we have would be subject to whatever the FMAP is or the federal matching. Right now, it's different, understandably, because of the public health emergency. But once that ends, any increase in rates would be federally matched. Is that correct?
That's correct. But with everything in Medicaid, there's a tiny little asterisk. So let me give it to you, which is when we change provider rates under the state plan, similar process in the waivers, but on the state plan, we issued a CMS what's known as a state plan amendment, which is basically, hey, this is what we're planning to do. Do you, CMS, agree? And their interest in doing that is because they pay the majority of the program. If we set provider rates equal to $1 million for doing an in-office visit, they'd be like, wait a second, this is absurd. We're not going to approve it. So any rate increase that we do would be subject to CMS approval. Assuming that we got that, then we would get the same federal match that we get today.
Awesome.
There's always an asterisk.
Oh, there is always Medicaid, everything is an asterisk. So
Yeah.
Thank you so much. And I'm probably going to have additional questions, which will circulate, but that's it for today. Thank you so much. Thank you, Mr. Chairman.
Thank you so much, Representative Fortier.
Thank you. I am not going to ask about the rates per se, but I'm,
You can if you want.
no, I know, but I'm not sure I could adequately articulate that. But I am concerned about the peer recovery support services. I know when I was a council person in the city of Bristol, we started that like pre-pandemic, and these folks were getting grants, and I'm not sure if they were DEMAS or if they were just some sort of outside grant. But in other words, they were affiliated or hired by as temporary employees by, I believe, Wheeler Clinic at the time. And the program was such that they were spending most of their day in the hospital emergency room. And when folks were brought in with drug issues, we were trying to fight opioids at the time, and apparently still are, but they would be someone who had been in recovery, still in recovery, and they would communicate with them the possibility of services and, counseling, et cetera, getting into recovery. And when we talk about the whole fee for service versus something else, is that going to work? In other words, is that peer counselor going to be able to be paid for under our bill is what I'm asking, if that makes sense, because they're not seeing them at the facility. It's not once they're in recovery that this person comes and chats with them more like a social worker would. This is someone who is talking to people that just are showing up in that emergency room. And presumably if the person had Medicaid, how is that connection being made? And again, is it only when the person decides to go into recovery, which could be a small percentage of the people that person talks to?
Yeah, it's a great question. Let me try to answer it, and you tell me
Sure.
if I'm off the mark here. And again, this is
Just
yes,
hypothetically,
yeah,
I'm just.
I feel forced to say DSS does oppose this section, but I'm just saying if one were to move
We know
forward,
that.
the gold standard in Medicaid to get something covered in Medicaid in general, there are always exceptions, but it's a covered individual.
Right.
with
So we
an
have to
enrolled
assume that
provider
the
or
person.
covered service. Those three things: the provider needs to enroll, and a service needs to be covered. So for and there are exceptions, but that's the kind of the trinity.
Right.
So for it's really that second one that I'm concerned about, the enrolling the provider. So when a cardiologist or a primary care doctor, there's a process of enrolling as a provider
Right.
in the Medicaid program, there's paperwork associated with that. With a peer recovery, I'm just not sure exactly how we would operationalize it. We need to enroll, and I very much welcome the opportunity to work with you or others who care about this, as do I offline, but we would need to enroll them as providers, which has a burden, and that there are rules and regulations around that. And I think part of the reason that this is grant funded is that helps sidestep some of those administrative burden associated with covering something under Medicaid.
Thank you. Just a follow up, like if Wheeler's a provider,
Yep.
would they be covered under that, or is it each individual provider?
Yeah.
Again, just in my example,
Yeah,
I'm
no, I
not trying
understand.
to call out Wheeler.
Totally understand. Let me follow up in writing. I want to make sure I get it right. There's oftentimes it'll be a provider can operate under the supervision of someone else. I just don't
Right.
know all the details for this part of the program. So
I just think it's with the opioid crisis, we need to do
get
all
through it and
yes.
and
yeah,
if
I
it's
woke up
working
this
at
morning
all.
and I was
Great. It's a great question. So let me take that as a
all right.
follow-up.
Thank you.
And sorry, I can't provide all the details here.
Thank you. Representative Fortier, you did? Okay, great. Representative Cohen.
Thank you, Mr. Chair. Hi, how are you? Please forgive me. I am new to this committee, so it is wonky stuff, and I'm just, trying to keep up. So you mentioned when you were talking to Representative Dathan, I believe, about the data, the need for data to inform rate increases, correct?
Mhm, yes.
So I love data like the next person. I'm wondering who is tracking the data? Like, do we have a process for that? And who's going to, responsible for reporting out, and where do we hold that data?
Yeah, great question. If I'm being, and we have similar in the written testimony, if I'm being totally honest, our process for setting those provider rates, those roughly 430 types, is not systematic. It has been a patchwork quilt, and we set that standard a long time ago. Some providers have gotten increases, some haven't. it's a mess. And maybe one indication of that is even, and I'm still new in my role. So one of my first questions when I joined was like, okay, well, give me the 430 provider types. Tell me what we're paying them. How does it benchmark to Medicare where we can, like all the same questions that you're all asking. And in part because some providers are not paid based on Medicare, in part because of that patchwork quilt, it is more complicated than I would have. And I'm not trying to obstruct it's more complicated than one would realize. So the proposal for that $1 million is to take a step back to generate that data that would be helpful for you all, and then that would be a public facing report that you all would have access to, where we would tee up, here's how it works today, here's how we compare to a benchmark, here are the places where we have access issue based on member surveys and secret shopper phone calls, things like that, and here's a recommendation of what one could do, and then ultimately obviously it'd be up to you to make the decision. Does that answer?
Yes, and
Okay.
it also brings up another question. And so you want the time to collect the data. Do we have the capacity to do that? Like we could want to do it all we want, but do we have the computer, the portal, all of those sorts of bits and pieces in position, or is that going to take additional funding or some sort of other structure that we do not have in place and that will take years to get in place?
Yeah, great question. I feel really confident that we do have those IT places in place. And just for context, this is not trying to collect data that we don't have already. Something like, what is everyone's temperature when they wake up in the morning, or some data element that we don't have. This is we have it in our systems. It's in statute. It's not going to the moon. It's more collecting it in one comprehensive place, and then that benchmarking and thinking about member access. And it's not going to be a panacea, not a cure-all. Like on the member access front, for example, we have surveys of members where we ask them about access issues, and that, presumably in the study, that would be a data point when thinking about where access issues are most challenging. You probably want to go to the data and look there. It's a survey, so it doesn't include every single member, all their experience, but I'm very confident that we have the backbone of the data and the systems that we have in place.
Okay, thank you. That's it.
Thank you.
Thank you, Representative. Other questions or comments for Mr. Wilson? I have one before I let you go. We did get a question this morning about whether Section 1 of the bill would apply to Husky's dental program. I didn't know if you had data on that.
I'm sorry, Senator, which bill?
Sorry. Oh, I'm sorry. I apologize. I forgot that we're talking about more than just the Medicaid rate bill. Yes, the Medicaid rate bill.
Okay, great. And then I didn't.
So the question was whether or not Section 1 of the bill,
Yep.
In applying to independent fee for service providers, would cover Husky dental providers or not.
Good question. Let me follow up in writing. Medicare has a much more limited dental benefit than does Medicaid, but it does cover some services. And so let me follow up on what dental would be included, like under the umbrella of Section 1, what would be included and what would not.
Great. Thank you very much. And seeing no further questions, you're off the hook. Good to see you.
Okay, thank you.
Next, we are joined by Commissioner Durantis from the Department of Children and Families. Good morning, Commissioner. It is still morning, barely. I know you've been waiting a while. It's good to see you.
Always a pleasure to go after my Human Services colleagues. So good morning, Senator Lesser again, and Rep. Gilchrist, Representative Seminara, Rep. Case, and distinguished members of the Human Services Committee. My name is Vanessa Durantis. As the Commissioner of the Connecticut Department of Children and Families, I am here to thank the committee for the opportunity to testify in support of Raised Senate Bill 1204, an act concerning the Connecticut Indian Child Welfare Act. DCF has participated with our tribal partners in developing this language that codifies existing federal practices into state statutes. The Indian Child Welfare Act is a federal law enacted in 1978 in response to disproportionate number of children removed from Native American families and tribes. Its purpose is to protect the best interest of Native American children and to promote the stability and security of Native American tribes and families. DCF has worked with the federally recognized tribes in Connecticut over the years and has established a policy to direct DCF staff on proper procedures for complying with ICWA when a Native American child is the subject of an abuse or neglect allegation, with a reference in the written testimony to the DCF policy where this is found. The bill incorporates these culturally sensitive practices into state law and extends its provisions to the state recognized tribes of Connecticut, which are currently not considered under federal law. The following are key sections of the bill: notifying tribal governments of a child who is a member of a tribe that is the subject of a child welfare proceeding, allowing for the transfer of child welfare cases involving tribal members to tribal courts, the requirement of social workers to consider a child's cultural heritage, and ensuring ways in which it is preserved and that the child must, if the child must be placed off tribal lands. The application of the same burden of proof for removal and termination of parental rights proceedings involving state recognized tribal families that currently apply to federally recognized tribes, and giving preference to a tribal member when placing a child who is a tribal member in foster care or an adoptive home. DCF supports Senate Bill 1204, and as a component of our agency's ongoing commitment to equity, we ask the committee to support it as well. Thank you for the opportunity to testify.
Thank you so much, Commissioner. It's good to see you. And
Good to see you too.
just really quick, I know that this is something that we've tried to address before. I think it was Public Act 2260 attempted to reference the Federal Indian Child Welfare Act. And I know we're creating under this bill a Connecticut ICWA. What can you just bring us up to speed on what we tried before and how this is different?
So this actually we had an opportunity to work very specifically with the tribes on the adaptation of making the Connecticut language consistent with the federal recognition. The specific pieces of that, I want to make sure that I capture all of that. I can submit to you what was different. And once let me talk to Vinny on that to make sure that I know exactly what has changed.
Great. Thank you so much. Any questions from members of the committee? Yes, Representative Dathan.
Thank you so much, Mr. Chairman, and nice to see you, Commissioner,
Good to see you
today.
too.
Just wanted to double check if there was an issue with the federal ICWA, would our Connecticut ICWA be able to remain in place so that children that are part of this community have those rights that they might lose on a federal basis?
That is the exact reason why we felt that it was necessary to make sure that the Connecticut ICWA is strengthened, to make sure that we not only include the 2 federally recognized tribes, but the 5 tribes that we have here in Connecticut that wouldn't fall under that purview, to ensure that all 5 would be covered.
Great, thank you. That was my understanding as well. I know federally, we see a lot of our Native American populations are really been suffering through the opioid crisis. And I'm wondering, what do we do in our state to ensure that children who are have Native American ancestry, that come from families affected by opioids, how we are supporting those families and the family unit, and also the cultural heritage that we've talked about. Thank you.
The majority of our recognized tribes are in the southeast corner of the state, and we do recognize that that is the one of the higher concentrations of our attention and our opioid response. I co-chair the Alcohol and Drug Policy Council with our partners from DMIS, and really thinking about ways in which specific communities can respond, particularly geographically when there's a higher concentration. I can find out though what specific responses related to our Native American children and families are happening down there, and provide that to the committee.
That'd be really useful. I really appreciate it. And thank you so much for your testimony. Thank you, Madam Chair.
Thank you, Representative. Just want to thank you, Commissioner, for being here and for partnering in this work. There's such a traumatic history in our country and our state with regards to Native Americans and their children being taken. So it's really wonderful to see that the department is working together with the tribal community. Thank you.
Thank you. We don't often get time to speak about this particular population, but clearly integrated into our racial justice and equity work that we have lifted up considerable best practice on.
Wonderful. Yes, Representative Bizzuto.
Thank you, Madam Chair. Just quickly, Commissioner, being that some of these are sovereign nations, is that a problem for you to integrate whatever you deemed necessary.
So with the two federally recognized tribes have considerable more resources than all five, the reason we put considerable amount of resources into making the Connecticut ICWA include all five is for that exact same reason, because we want to recognize that there are rights and available resources to all five of our tribes.
Thank you.
Thank you, Representative. I don't see any other questions. Thank you for being here today. Next, we'll hear from Sarah Egan, Child Advocate.
Good morning to the committee. My name is Sarah Egan. I run the state's office of the Child Advocate. I'm here to testify on the rate bill 66885. You have my written testimony. I have been sitting here listening, and I just wanted to respond to some of the comments and questions that have gone by. But first, I want to say thank you to the legislature for all the work that you've been doing to address the children's behavioral health crisis, but it cannot be addressed without addressing rates and reimbursement. I mean, I just think that that's ground zero. I mean, it's just a do not pass go for our providers, our system, our workforce. And I appreciate the candor from the state's Medicaid director, who I know is new. And I'm quoting him when I say that our system for setting reimbursement rates is a mess. It's a mess. And the committee's, response to rates that were set in 2007 that don't come close to addressing the cost of delivering care. Right? That can't work. And I appreciate the questions and the director's response around, of course, we want a methodical, dynamic system and structure in place to set rates, index them where appropriate and where applicable to Medicare, but also match them up to the cost of delivering care. But I have to emphasize, I say this with all due respect, I hope you appreciate the source of this sense of urgency, but we cannot let this budget session go by without addressing rates and wait for that study. Legislature authorized and directed OHS and DSS to do a parity study that was in 5001 last year to be done and submitted a preliminary recommendations to the legislature this January. We don't have that. That's already been delayed another 6 months. Now we're in a budget year. We're sitting in a huge crisis. We have no data on rates. We have no data. We have data on network capacity, but we have no data on waiting lists, or very limited. What we do have on programs like ICAPS, right, the go-to intensive service for children and families in the state, is that right now we have more than 500 families on the waiting list for ICAPS, and multiple geographic regions of the state, New London County, Windham County, and now I'm hearing more providers where there's no access at all. These are the families that our office hears from day in, day out, right? You add problems, challenges like ASD and IDD to that. I mean, you could be waiting for months and months and months, and the question longer than that, a year. What happens to these families while they're waiting? They're hospitalized. They sit in EDs. There's no population of children that sits in EDs for longer periods of time, the children with ASD and IDD with co-occurring behavioral health challenges. And it is all about capacity, workforce, and rates. And that is a group of services, as some folks have testified and you all have asked about, that there is no Medicare equivalent. Right. Our office co-signed a letter with Disability Rights Connecticut and the Center for Children's Advocacy to legislators and to state agencies a couple of months ago, specifically focused on the inadequate rates for services for children with ASD, which are grossly lower than blended commercial insurance rates and lower than neighboring states. With waiting lists, we know where we have them, of children that wait for months, if not a year, to access services. So I know you understand that. I know you're receptive to that. I do want to underscore that for children who are eligible for Medicaid, there is a legal entitlement to prompt and reasonable access, right? And states can and have been sued under the EPSDT elements of Medicaid for not addressing these shortages. And I say that just because it is. Right. And again, I know you appreciate the sense of urgency we're bringing here, but every week, every day, just this morning, we met as a team, on intakes, right? We just can't wait anymore for these children. And And I appreciate, I think it is important to study. I think we should do that too, right? But if we're at 57% in 2007 of Medicare rates, which I'm going to guess don't cover the cost of care either, then we know we have a lot of room for improvement. And we can't go through a biennial budget year without significantly addressing that, and making sure not only that, but that we have a system in place for setting rates and a system in place for telling the state and policymakers what the capacity issues are. I can't go to, and again, with all due respect, I can't go to DSS and say, well, give me the waiting list for in-home ABA. They can tell me how many providers are in the Medicaid network, but they can't tell me how many children and families are waiting. And can you imagine having your child discharged from the emergency room to nothing? Recommended for, we just have a child up at a hospital in Eastern Connecticut with a discharge plan for last Monday to nothing. And our office got in the mix and said, you can't discharge this child. I just heard from her parents again, and they've delayed it. But how do we, and I understand why that happens, because they got to move the bed. They have another child coming from the emergency department. Right. But to be that child, to be the parent of that child, to be put on a waiting list for ICAPS, one provider in Central Connecticut said to me not too long ago that the waiting list for ICAPS was on, I quote, infinite. That is not sustainable. And so I'm really just up here, telling you what you know, but I guess insisting with all of my might that please let's do what we can, this session about it. I don't think I left anything off in my notes here. I think I've said it all, but I did put in here on page, I didn't put page numbers in my testimony, but the last page where I gave you a recent report from the Kaiser Family Foundation, which put out a report in January 2023, addressing state strategies regarding the behavioral health workforce shortages, and some of their findings of what other states have been doing over the last couple of years, including 2/3 of responding states reported making Medicaid rate increases. And I gave you some examples from Oregon and other states here just for your reference as you continue drafting the bill. So I think the bill is good. I think it's going to need some work because for some of the reasons that folks have pointed out, not all the children's behavioral providers have a corollary for Medicare. And just the very last thing I'll say, and then I'll be quiet, is, the question that the committee asked about what would be the public policy served of chronically underfunding our children's behavioral health system and not indexing rates to either Medicaid or the cost of care. And again, I appreciated the Medicare director's candor on this. There is no public policy that serves. And it is a big part of why we are in this mess. And we're not going to get out of the mess until we're out of it. And so we have to take a big step forward this session. So that's it. Thank you.
Thank you, Ms. Egan. Thank you so much. So you spoke to the behavioral health concerns, but and in addition to, this committee has been prioritizing IDD, the IDD community. And I was wondering if you could speak to the impact that the rates are having on autism and autism services in particular for children here in the state.
Yes, I can. And so as I referenced, our office co-signed a letter with Disability Rights Connecticut and the Center for Children's Advocacy a couple months ago, specifically focused on children with ASD, where our rates, our rates in Connecticut fall below the blended commercial reimbursement rates, below the reimbursement rates from other states like Rhode Island, and again, I started by saying that we don't have all the capacity data, right? Can't get that out of our systems. But what we do know, we know that we have infinite waiting lists for evaluations and in-home services, particularly in certain parts of the state. Our office was working with a family who came out of a hospital with autism, had autism, went into the hospital, came out, was recommended for PHP, partial hospitalization. They said the wait list was 7 months. That's not even real. I mean, that means you're getting discharged with no support, and whether that service ever materializes or doesn't. What we hear from providers who take insurance and Medicaid is that they hear from families all the time. They they can't take the Medicaid clients, right? And I think Representative Gilchrist, this is something you referenced in one of your earlier questions. Because the reimbursement rate is so low, it doesn't come close to covering the cost of paying the person to deliver the service, much less the overhead of keeping the lights on in the building, right? So these are families that are just getting turned away, right? And so that I don't think anybody challenges this. Nobody's challenging that, right? And so we know, again, it's something we know today that Connecticut's Medicaid rates for ASD services fall below insurance, fall below neighboring states. That is something we have to address this session, because meaningfully, children do not have prompt and reasonable access under Medicaid. Doesn't solve the issue for all the families who are commercially insured who can't access the services either. But the more we lift up the system, right, and enable providers to hire and retain, right? I mean, getting a BCBA in a private provider is like finding a unicorn, right? And the minute you get them, they leave to go to a school system. Why? Because the school system pays more money. So that's what I would say about that.
Thank you. And I recognize you were talking about ASD. I didn't know the acronym, so I apologize. Thank you. The other piece, and then I'll open it up to folks, is I really want to thank you for recognizing, and because I feel this way, that this is both a workforce issue. So thank you for setting that research as well as an access issue. And thank you for letting us know that we are potentially putting ourselves in legal jeopardy by not taking action. Not to mention, it's just not right that people can't access services, but thank you for pointing that out. Representative Dathan, followed by Representative Hughes.
Thank you so much, Madam Chair, and nice to see you, Miss Egan. I didn't see your testimony yet on the system. Have you submitted it? And maybe it just hasn't gotten uploaded yet.
I did. before
Okay,
the Tuesday
I'm looking
hearing, so it
forward
should
to
be
getting
there.
it.
Yeah.
If we don't get it, I'll have the
read it.
administrator reach out to you. But I'm looking forward to looking through some of the data there. You highlight some of the issues that children are facing in our state, particularly around mental health. You know, you hear it particularly around pediatricians in general. You know, we haven't addressed those rates. You know, we've picked specialties over the years, and pediatricians have been severely lacking in getting increases. Do you have any information about sort of general practice pediatricians in Connecticut reimbursement rates compared to other northeastern states?
I don't. That's an excellent question, and I will circle back and get that for you.
And what about other sort of specialists? I know I had a constituent reach out to me that in Fairfield County, her son needed to see, under Husky, needed to see a pediatric orthopedic and couldn't find one outside. You know, it was like 30, 40 miles away. Is there any sort of information about concentration of specialties for pediatric services in our state for Medicaid purposes?
Yeah, I think those are excellent questions on the medical subspecialty side and really important. I'll see what's out there and get that back to you.
Okay, that would be great. And thank you for bringing up the information on the IDD community. I know you were here last week testifying. It's great to see you again because I do value what you've added to the conversation. It's really appreciated.
Thank you.
So thank you for your testimony today, and thank you, Madam Chair.
Thank you, Representative Hughes.
Thank you, Madam Chair, and thank you, Advocate Egan. You referenced the study that we did put in statute and it's been delayed, but aren't we getting some preliminary information?
So the off the top of my head, the legislation had required that preliminary recommendations be submitted to the legislature by this January,
Right.
and a postponement in that was sought,
Yep.
is my understanding, for an additional 6 months because the contract had just been undertaken or was just being implemented. You know, and look, I understand that happens, right? And so my only point was, I think it's important to study. I mean, I think that the study that DSS is proposing is important to do, but we don't know how long it will take.
Well, the
Right.
timing is important because we're trying to make policy now. Like you said, for a biennial budget year, we're trying to base good policy off of the best information we can
Right.
get. So we do appreciate whatever your office, even if it's, not the empirical data that we're looking for, inform the policy and how best we can consolidate. I mean, this is all like my colleagues have said, an overlapping crisis that has been brewing long before COVID, but COVID exacerbated the workforce and provider issues. And, I've had many private providers, especially like social workers, just say they cannot take, Medicaid and Medicare because they can't administrate all the stuff. They're a single person operation, behavioral health operation. They've got to just focus on patient care. So, so we have so many barriers to that, and we want to streamline that workforce pipeline and immediacy and ease of access, almost like we tried to do with the pandemic. But a lot of that funding is drying up.
Yeah, and there's a whole category I didn't mention that I was in my notes to mention, which the committee mentioned, which are the services for family caregivers struggling with opiate use disorder.
Yeah.
Right. And which is relevant here to your rates bill. It's relevant to some vehicles moving in public health, where again, the feedback, we know we have huge barriers to timely treatment for caregivers struggling with an opioid use disorder. We come at this both from a healthcare angle, but also from a child fatality review angles. We've had 8 infants and toddlers die from fentanyl overdoses in the last 3 years, right? From exposure to fentanyl, where only trace amounts in an environment can be lethal to a child. So making sure that our caregivers get timely connected to who are almost many of these families seeking treatment are Medicaid eligible, making sure that they have same-day access to medication-assisted treatment and to childcare supports necessary to access treatment is going to be critically important. And again, rates, it starts there, right? But right now we're hearing, for example, that a family out in New London County has to go to Manchester to get medication-assisted treatment. That's crazy. Right. So I think that's just a whole category of rates that we also need to look at. And I have some providers that are sharing their information with me, and I'm happy to pass it along to the committee as well.
Thank you. I know you already shared some of this in public health with harm reduction strategies, but again, all of our committees are really looking at this intersectionality of crisis and protecting the children is our mission. So how we can work concurrently and collaboratively on those solutions, long-term, especially, and short-term. Thank you.
Thank you.
Thank you, Representative. I don't see any other hands. Thank you so much for being here.
Thank you.
Next, we will hear from Robert Bessel, who is joining us via Zoom.
Well, good morning. Well, actually, good afternoon. I want to thank Chairman Lesser, Vice Chair Dathan, and all the members of the Public Health Committee for this opportunity to testify in support of House Bill 6885. Just very quickly, this year, the Canton Board of Selectmen, I'm the first selectman in Canton, proposed a nearly 6% increase in next year's budget. About 2/3 of this increase will cover increased costs for police, fire, and emergency medical services. And I want to provide you some detail on the impact of the current reimbursement rates on the increase in Canton's EMS costs. For the past 4 years, Town of Canton has run a deficit in its EMS account. And over this period, the deficit has increased 400% from $124,000 to almost $500,000 in the year coming up. This year alone, the deficit will increase 100%, roughly half of the proposed increase in the proposed Board of Selectmen budget. Part of the cause of this deficit is a shortfall in reimbursements for ambulance services. Last year, the Town of Canton billed a total of $1,121,000 for 914 transports, and the total allowable for these transports was a little shy of $600,000, or about 53% of the amount billed. The bulk of these transports were billed to Medicare, 486 of them, which the state of Connecticut obviously does not control. But the second largest number, 129, were billed to Connecticut Medicaid. Of the $63,000 billed, only $51,000 was considered allowable, leaving the town of Canton with a shortfall of $113,000. Let me give you an example of how this policy has impacted Canton. Last year, a 25-year-old male suffered multiple traumatic injuries in a motor vehicle collision. Canton Ambulance transported the patient to a trauma center 14 miles away. Canton Ambulance was allowed to bill $1,564 for this service, but because the patient was on Connecticut Medicaid, the maximum reimbursement was $220.44 plus $5.88 per mile transported. The total we received was $302.76. Shortfalls like these have a large effect on the town of Canton. Our ambulance service cannot deny service based on reimbursement rates, and therefore we join all the towns and cities in Connecticut that are subject to these reimbursement rates, which are literally siphoning funds away from our budgets all across our state. So on behalf of all Connecticut municipalities that provide ambulance services to Medicaid patients, I ask this committee to recommend House Bill 6885 and raise these reimbursement rates. Connecticut cities and towns can no longer shoulder the burden caused by this policy. Thank you very much.
Thank you, First Selectman. Senator Seminara.
Thank you, Madam Chair. And hi, Bob. It's good to see you.
Thank you.
And I wanted to thank you so much for your testimony. Obviously, this is a huge problem for Canton, but I believe that this is a huge problem for every municipality who is providing these services. So I appreciate your numbers. I'm hopeful that you submitted your testimony in a written form as well, so that I could go over them in more detail. But if not, I will make sure that I get them from you. But please know that you are not the only municipality that is complaining of this. I think it's an issue that is across Connecticut.
Thank you. Yeah, I have submitted the testimony this morning in written form.
Terrific. Thank you so much. And thank you for everything you do for Canton. You run a great ship there.
Thank you. Thank you. You're kind.
Thank you, First Selectman. I don't see any other hands. Have a great afternoon.
Thank you.
Next, we'll hear from Rebecca Allen. You just need to push the button, please.
Is that good?
That is, go right ahead.
Thank you. Good afternoon, Chairwoman Gilchrist, ranking members, Case and Seminara, and esteemed members of the committee. My name is Rebecca Allen, and I am a homeowner and registered voter in the town of Columbia. And I'm the Director of Recovery Advocacy for the Connecticut Community for Addiction Recovery, or CCAR. I am a woman in recovery, and what that means to me is that it's been over 25 years since the last time I used heroin. I want to thank you for the opportunity to provide testimony on the proposed Senate Bill 1205, which I have some strong feelings about and I oppose. So for background, CCAR is funded by the Department of Mental Health and Addiction Services, and we provide non-clinical community-based recovery support services. We operate 5 recovery community centers: Hartford, Wyndham, Bridgeport, Waterbury, and New Haven, and provide recovery coaching to 29 hospital emergency departments, 7 correctional facilities, 5 district parole offices, and 3 municipal courthouses. In 2022, our emergency department recovery coaches responded to over 4,800 calls and have an 82% connect to care rate. Our Department of Corrections recovery coaches have supported over 400 individuals, providing a safety net and seamless transitions, especially for individuals that are on medications for opioid use disorders during the reentry process. CCAR developed a recovery coach training curriculum in 2008 that has been used to train over 85,000 coaches nationally. We directly employ over 30 recovery coaches, and we strongly believe that recovery coaching should be anchored in recovery community organizations, not as adjunct positions in treatment providers or other healthcare entities. RCOs are independent nonprofits that can hire, train, and supervise recovery coaches and can best ensure the fidelity to the role. If we move to make recovery coaching a billable service under Medicaid, it will make it extremely difficult for small community-based organizations to provide this service. The cost of having to bill Medicaid combined with the low reimbursement rate will make it impossible for recovery coaching to be a standalone service. In addition to the financial, in addition to the financial burden, the restrictions that Medicaid would impose around education and training requirements, billable units per client, et cetera, would place an undue burden on the recovery coach and change the nature of the coaching relationship. I've talked to hundreds of recovery coaches around the nation over the last 5-10 years, many whom are integrated into the treatment system solely because it's a billable service in their state. They share that their supervisors and their coworkers not only don't understand their role or respect that role, but that they're often relegated to chauffeurs and gophers. I don't want that for Connecticut, and I'm asking this committee to ensure that we continue to have flexible funding for recovery coaching services and to not advance this bill out of committee as is. I'm happy to answer any questions.
Thank you so much, Ms. Allen. And first, thank you for sharing your experience in order to help others and for the work you do. I'm a little confused, so just want to better understand how are recovery coaches currently paid for through your organization, and is it well paid, or could they be receiving more? And I suppose, how does making that service billable under Medicaid? I mean, you explained a little bit, but I think some of us are at a loss. Like, how would it damage the service, do you think?
Right. Well, like I stated, so our recovery coaches are funded through the Department of Mental Health and Addiction Services. And I believe it is through their SOAR funding that they're getting from SAMHSA. You know, our coaches are well paid because we are good stewards of the funding. So we took some time when we put this program together to make sure that our coaches are well paid and that they can have everything that they need to do their job. If we move this to a solely billable service under Medicaid, the reimbursement rate would be so low that we would not be able to employ our coaches, at least not to the level that they are right now. Many coaches that are working under the treatment system where they are being billed through Medicaid, they are making not much more than minimum wage. We are able to pay our coaches. We start our coaches at $24 an hour, which is a good, which is a good rate. But by no means, is it enough? We would love to even pay them more.
Thank you. I'll go to Representative Case, followed by Representative Fortier.
Thank you, Madam Chair. So I guess my confusion is just as much as my good chair. So reading this, and this is basic language from the bill, but so are you disputing that being certified under a program overseen by Department of Mental Health and Addiction Services and being certified in order for them to apply for reimbursement, or it would be you that would be applying for reimbursement?
If if this was solely a billable service, so what I'm asking for is to continue to have flexible funding for recovery coaching services.
Well, I understand that, and I think that it's a very amendable thing that you guys do as far as the coaching, and I think it's very effective. And you're right, by billing this under Medicaid, it would probably change the rate that you guys would be making. But from what I'm seeing with this budget that's coming forward, is they're looking for anything that they can bill so that we can get a reimbursement from the federal government. And that's where DEMIS is probably going to be coming from in their budget when the budget comes out of the House and the Senate, because the governor's budget is one thing, the legislator's budget is a different thing. And if legislators can find monies that are reimbursable, that's what I believe they're going to end up going for. My concern is, so you're saying you're funded under DEMIS, correct?
Correct.
And it's under DEMIS, so DEMIS isn't applying for any reimbursable funds, correct?
I don't know the answer to that. I do know that I believe that most of the funding that we receive from DEMIS is being from the federal government under the SOAR grant.
So under the SOAR grant, I understand that. Would there be more dollars available to DEMIS if they did a reimbursement through, if we move this so that DEMIS did the reimbursement and you as the peer coach facility didn't do the reimbursement, would that be more amenable to you if it didn't change your rate?
I really don't have an answer for that. That's not really something that I'm well versed on.
Right now, it's basically you're trying to work to save the people who come to you for the counseling, the people who come to you for the need. And if it was moved to you having to bill Medicaid, it would greatly depreciate what you would be able to afford as an agency, correct?
Absolutely. Yep.
So that's the bottom line. So I think that's something that we have to look at and work with DEMIS and see, because somehow this came up because it's a bill. And it's in front of us, and somebody's trying to garner the most money they can on a reimbursement level, which we deal a lot with in this committee with reimbursement levels. So I guess we'll take a deeper dive, but appreciate you coming forward. But your bottom line is to help the ones that come to you for services.
Absolutely. And to continue to have the flexible funding that allows us to do the work that we do.
Correct. And funding's very difficult these days after. So appreciate you coming forward. I'm sure we'll work on it and go further.
Thank you.
Thank you, Representative Fortier.
Thank you. So again, I'm not an expert on how you get paid now. And I don't know if you were here and heard my questions to DSS, but if it were possible to allow you to continue to be funded the way you are, but for this bill to provide additional recovery coaches, to other organizations like, and again, I'm going to use Wheeler Clinic because that's what I mentioned before. But in other words, a place that is doing other services and they want to add that to their, kinds of providers they have there. Would that be a problem for you if it was almost like two different tracks, two different kinds of payment systems for recovery coaches?
Sure. So from my understanding from DSS, this is already a reimbursable service. So I was a little confused about the bill
Okay.
to begin with.
All right.
Like I stated in my testimony, I do believe that recovery coaching should be anchored in recovery community organizations and not as
Okay.
adjunct services.
I understand. Okay. I think for some of us, it's let's get as many as we can. You know what I mean? And again, we're not experts. We try to deal with the information that we get. But again, I know in my community, we don't have an agency such as yours. So if we can add some recovery coaches to other programs and service providers, I'd be all for that. Do I want them making minimum wage? No. But again, if it's a start and if it's the only way we can get more, you know what I mean? Like we're just trying.
I do. And Representative Fortier, we do serve Bristol Hospital. So we do
Oh,
have
okay.
recovery, we do have recovery coaches that respond to Bristol Hospital.
Okay, and where's their office or where would they be? Because when you named the communities.
Yeah, so our coaching program is statewide. Like I stated, we are in 29 hospital emergency departments and they operate as a dispatch model.
Okay.
So I do have a colleague that is going to testify a little bit later on that is the program manager. So
Okay, thank you.
Representative Bugby, followed by Representative Comey.
Thank you, Madam Chair, and thank you for your testimony. I'm friends with several coaches and people that put the work in and can't speak highly enough of the work that's done through the organization and the individuals. I think it's critical that you came up here to speak on this. So I want to thank you for that. Curious how this would work with, we're talking this year about expanding the Peer Navigator program as well across the state. I don't know how familiar you are with that program as well, but how the coaches tie into that program.
I am somewhat familiar with that. So I believe the peer navigators are working with our, police, first responders, EMS services, correct?
Yes, and then within other populations within each community as well. Like, for example, I'm in New Milford. We have a great program we launched there. New London launched a very similar program to what we did. That was the basis, the foundation for what the state moved forward with on that program. And it really is working with individuals one-on-one, not a, hey, here's a phone number, give this number a call and see if you can get some help. It's literally individuals working one-on-one, excuse me, with those with addiction services needs. And I think it's through that program, we've convinced others to work through as a coach as well, to assist with the program. So I'm curious, as we look to grow that this year, we expanded it through legislation, more dollars for it previously, and we're looking to do that better this year as well. So I think that tie-in with the coaches you have, I think would be outstanding.
I agree. And again, working in this space for the last 10 years and, our national presence around training coaches, I do know that coaching is best anchored in recovery community organizations. And as long as that coach is working for an organization such as that, it does give that flexibility for, that coach to be working with their local police department or EMS service or things like that. But what really gives that coach, in my experience, they're able to be independent. So a lot of coaches that unfortunately are tied to treatment, they're not as independent as I would prefer. If I'm working with a coach, I want that coach to be able to discuss all of the different resources and all of the different options, not just the ones that are within their provider that they're working for.
Exactly what I was hoping you were going to say too. I think that's the critical part of what a lot of people, we don't get a lot of that in this committee, right? We don't have as much discussion on this topic in this committee. And I think it's a critical piece moving forward. Again, I can't thank you enough for coming here in person today to speak with us from the heart, and congratulations on your recovery as well.
Thank you.
Thank you. Thank you, Mr. Chair.
Thank you, Representative. Okay. So I have a question and I apologize. I was out of the room for the beginning part of your testimony. If we were to offer Medicaid reimbursement, would that interfere in any way with the SAMHSA grant that you currently receive?
I don't think it would. I think that my concern is that if, because, grants will go away eventually. And, if this is solely going to be billed under Medicaid, that's where my concern is. So as it is right now, I don't see it being an issue for our organization. But again, my concern is that if this service does move to solely a Medicaid reimbursable service, that it will impact what we're able to do.
So you're worried that this is the nose under the camel tent for cuts elsewhere in the state budget? Is that the? I don't want to put words in your mouth. I just want to make sure I understand your argument. Is it?
Yes.
Yeah, okay.
Yes. Mhm.
Okay. All right. There are other questions from members of the committee. Representative Cohen.
Thank you so much. So I'm digging around in the SOAR grant and, like you just said, that grants are never, predictable in the sense that you don't know if they're going to come year for year for year. Are you a direct recipient or are you a sub, do you have a grant that's given to someone, statewide organization, and then they sub grant it to you?
No, so our funding does come directly from Demas, and that's who is getting the SOAR funding from SAMHSA.
Okay. Thank you. I'll keep looking.
Thank you very much. Seeing no further questions, thank you for being here this afternoon.
Thank you.
Next, we have Bruce Baxter, followed by Jordan Fairchild. Good afternoon, Mr. Baxter.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Samara, and Representative Case, distinguished members of the committee. My name is Bruce Baxter. I am the president of the Connecticut EMS Chiefs Association and the CEO of New Britain Emergency Medical Services. Connecticut EMS Chiefs Association strongly supports Section 3 of House Bill 6885. Additionally, we would urge the committee to compress the implementation timeline to get EMS services in the state of Connecticut to 100% of the Medicare rate. Connecticut EMS system is in a crisis. There was a report recently released entitled "The Report of the Emergency Medical Services Working Group to the Commissioner of Public Health and the Commissioner of Social Services," dated February 1st, 2023. In summary, that report identifies 3 significant risks that are eroding the reliability of the current EMS system operating in Connecticut's communities. Those risks include increased demand for services, labor recruitment and retention issues, and a lack of adequate financial resources to keep paces with wages, benefits, and operational expenses. The primary initial recommendation to remedy the risks, or to begin to remedy the risks, includes adjusting the Medicaid reimbursement rate to mirror 100% of the Connecticut Medicare reimbursement rates for EMS organizations. This would provide each ambulance service in the state with an immediate cash infusion to begin addressing other co-related challenges. And this increase is essential for the EMS ambulance services providing 911 services in municipalities with a disproportionate share of patients who are primary Medicaid beneficiaries. As being the CEO of one of those agencies in the city that services the city of New Britain, nearly 50% of the population that I serve are Medicaid beneficiaries, primary Medicaid beneficiaries. Over the past 3 years, operational expenses for our association members have dramatically increased. Labor costs have increased 25%, fuel costs have doubled, medication costs have increased 40%, disposable medical supplies 35%, and the acquisition costs of ambulances and biomedical equipment has increased 50%. In comparison to the current Medicare ambulance fee schedule allowable charges for Connecticut, Medicaid reimbursement only covers 4 of the charges covered by Medicare and is 37% less than Medicare. Additionally, Connecticut is one of 4 states that sets the retail rates that ambulance services can charge. They did that and have done that for the last 40 years in order to protect the consumer. When you compare what we receive from Medicaid to our allowed charges, which are already about 50% less than other states, Medicaid is off the mark by 69% to 84%. Of the Department of Health's Office of EMS maximum retail rate schedule that is established for each service in the state. It is key that we act.
Sir?
Yes.
Can you please summarize?
I'm doing that right now.
Right.
It is essential that EMS remain financially viable to continue serving the needs of the state. We urge you to support the bill. Thank you.
Thank you so much, Mr. Baxter. Now, were you here earlier for Mr. Woolston's testimony from the Department of Social Services?
I was.
Okay, now he said, and I, again, I'm doing something that I ought not to do, which is put words in people's mouths, but I understood him to say, we've done an awful lot for EMS rates in the past few years, and he listed times when we've adjusted them. Did you, I'm sure he wasn't
I will
wrong. I just wanted to know if you could sort of summarize how we
Sure.
got different, because we're so much lower than others.
Sure. So he is correct. There have been a couple of rate adjustments in the last couple of years. In the last 5 to 7 years, there have been a couple of rate adjustments that brought us from really prehistoric levels of reimbursement up to where we are today. And certainly we appreciate those rate adjustments. But the reality, sir, is that in this community where the average cost of providing a unit of ambulance service to a Medicaid beneficiary averages just slightly less than $500 a transport, and I'm receiving an average of $296 for basic life support transport and something that's costing $500, or $349 for a patient that is an ALS case, I'm losing money every time I move a patient. And the reality is that with the escalation in costs that our industry is exposed to over the last 3 years, we're burning equity in order to turn around and continue servicing communities. And I think you're going to hear the same argument from the rest of the folks that are going to testify. We need help. The industry is in crisis. And, we certainly appreciate what you've done in the past, but we need help today.
Great. And I'm a new chair of this committee, so I cannot take credit for the good work this committee has done in the past. So, but other folks do deserve credit. Are there questions from members of the committee? Representative Case.
Thank you. And thank you, Bruce, for coming forward. So my question, or maybe a comment, but majority of your increases to the emergency medical is being felt across the state. And that's not only because of the reimbursement, but it's because of the running of the facilities and the rolling of the rigs. Is that correct?
Absolutely.
So this bill, it says services and costs by 10% by fiscal year ending 2024. But right now we're in a crisis. I know I come from a community where we have 3 rigs, and at any given time we're only running 1 rig, and the others are being run on mutual aid because we can't fill the seats in the rig. Is that what's happening across the state also?
I think that labor, we've identified that labor is an issue. There are 28,000 licensed EMS providers, and 25% of those providers are actively engaged in providing care on ambulances today. In the city of New Britain, we do 17,000 responses a year. We're a career organization, and we're doing that with 4 ambulances at peak when I need 6 ambulances at peak. We don't turn around and have the revenue to staff an additional 2 ambulances, and B, the labor force. We're in a competitive phase for labor right now. EMS post-COVID has sort of dropped off the desirable career profession. People can turn around and get paid more to do other less stressful, intense jobs. So the labor market is tough for all of us.
No, and I thank you for coming forward, because when you talk about the labor market, you also talk about fuel. You talk about the average rig these days is about $130,000 to $140,000 when you're going out to purchase them. And the state of Connecticut and other states also require you to keep those rigs at a certain caliber, and they're strictly inspected on a yearly basis. I hear you. We're going to do what we can and work on it, but you are our life savings, and we depend on our EMS and our first responders, and I appreciate you coming forward today. Thank you, Mr. Chair.
Thank you.
Thank you, Representative. Other questions or comments from members of the committee? Seeing none, thank you for being with us today.
Thank you.
Next, we have Jordan Fairchild, followed by Olivia Rinks. Hello, Jordan.
Good afternoon, Senator Lesser, Representative Gilchrist, Representative Case, and distinguished members of the Human Services Committee. My name is Jordan Fairchild. I am the coordinator and community organizer for Keep the Promise Coalition, which is a grassroots group of Connecticut advocates with lived experience of mental health conditions and co-occurring substance use disorders and disabilities. I'm here today to testify in support of SB 1205, which would make peer support services reimbursable by Medicaid. You have my written testimony, so it will suffice to say that Connecticut is falling behind most other US states on reimbursing peer support services through Medicaid, and the majority of the states that do so through a state plan amendment. Just a couple of notes on this bill. I noticed that the bill language makes specific reference to reimbursement for recovery coaches, but it seemed a little fuzzy whether or not it also intended to reimburse for recovery support specialists, which is the designation for people who have lived experience of mental health conditions as opposed to just addiction. So I think that both should be included in this bill to account for possible future designations, including like peer supervisors. If that's something that the state pursues later on, I think you should kind of keep it open-ended to reimburse for peer support services for mental health and addiction services. I also just want to note that it specifies that providers who are eligible for reimbursement should be certified under a program overseen by DMIS. This conflicts with SB 976, which was heard in the Insurance Committee last month and would require DPH to handle the certification. This would allow for DMIS to contract with a private entity to do so. I think it doesn't make sense to do that when this is an established function of DPH. They already handle certification for community health workers. And then I just wanted to respond to some of the testimony earlier as well. And I'll start with the DSS Medicaid director. He mentioned that the peer services are reimbursed in Connecticut through waiver programs, but I just want to note that these waiver programs really only apply in very specific cases. As far as the mental health waiver is concerned, this is specifically for people who are at risk of institutionalization or placement in a nursing home, which is a very high standard. Neither waiver program is going to provide the coverage for all Medicaid enrollees, which I believe is what the purpose of this bill is. And just to address some of the other concerns of advocates about, quantifying peer supports and the, flexible spending. Well, I will wrap up. As far as the flexible spending goes, we in Connecticut have, I think, 3 recovery community organizations. I know CCAR, and I have a lot of respect for them. They're all around the state. The other 2, Advocacy Unlimited and New Life 2, are focused in really the central Connecticut area. So this is not about eliminating other types of funding. This is not about eliminating grant funding, which we support grant funding in as many places as possible. This is about opening up opportunities for funding elsewhere and expanding peer support services.
Thank you so much, Jordan, for your testimony. Are there questions from members of the committee? I just had one. I mean, you referenced an insurance bill, and I serve on that committee, and I believe that bill is not with us anymore. But their concerns were more that you liked the approach that the committee was considering at that point.
Yeah, and this is really just a matter of, we have a state agency, which one of their established functions, being DPH, is to certify and provide licensure for various health professionals. They do so for community health workers. I don't see why, and what, it seems that DMIS is looking at doing right now is contracting with a private entity. I think as far as staying power, having this state mandate for DPH to exist and giving them this task to certify peer support specialists, that makes a lot more sense to me, as well as quite a few of the other folks in the recovery community that I've spoken with, but I can't speak for the whole peer community.
So the issue that I think we've been up against in the past is, and I don't, maybe you could update us on where DPH is, but I feel like we've been waiting for DPH to flesh this out for some time and haven't seen that happen yet. I haven't followed it as closely as other folks have.
I am not familiar with DPH having previously been tasked with doing this, and that could be because I've only been in my role for about 2 years now. But I think that this would make sense to go there. They've done so for community health workers. And, you know, if this was done in consultation with the folks from DEMIS and, you know, peer support specialists, I think that we could move this along.
Okay, and I'm sorry, does DEMIS currently certify
So
folks or not?
people will disagree on whether it's officially a certification. What I'll tell you is there are two designations, recovery support specialists and recovery coaches. Recovery coaches, I believe, because of the way that they are certified, is a legally defensible designation. On the other hand, some folks will say that recovery support specialists are not. And the purpose of all of this talk around certification is to make sure that there is something that's legally defensible, I think, which would encourage and just ease the process of Medicaid reimbursement.
And do you know when DPH is likely to have a licensure process up and running?
I do not know.
Okay. Are there questions or comments from members of the committee? Representative Gilchrist.
Thank you, Mr. Chair, and thank you for being here. This is helpful. So with these two designations, and if you don't know, that's totally fine, but is there a national organization that accredits these roles? Do you know, the recovery coaches and a recovery support specialist?
I would have to brush up. I believe recovery coaches, I'm not sure as familiar with recovery coaches. I believe as far as recovery support specialists, I think that is a Connecticut specific designation. Although what I do believe I've heard about is there is a national effort to create a certification for peer support specialists.
Okay.
I'm not sure that is completed yet, so I'll have to get back to you.
Okay, and having worked on a few of these, I would just flag, because now this is starting to make sense. So I'll certainly follow up to see where DPH is in this process. But usually this begins with a scope of practice review through DPH, which I'm happy to follow up with the advocates to let you know how that process works. And we'd need that before we can do the Medicaid. So it really is a two-step process.
Yeah, I agree that the certification is probably going to be an important building block for the reimbursement. It has been a long time coming in Connecticut. We're behind a lot of our neighbors as far as actually reimbursing. And I will say, I believe DEMIS has done quite a lot of work, including, really well fleshed out with a lot of recovery support specialists and I believe recovery coaches, just peer support in general. As far as previous, I'm thinking back to, I've seen documents from 2018, 2015, I believe, that flesh out the scope of work. Okay. So a lot of this has been done. I can't speak for how everyone feels about it or whether they think it should be updated, but it's certainly a starting place.
Okay, thank you.
Thank you, Representative. Are there comments or questions from members of the committee? If not, thank you for being here this afternoon.
Thank you.
Next, we have Olivia Rinks, followed by Frank Vesey. Is Olivia on? No, Olivia. Is Frank on? Yes, he is.
Yes, I am. Good afternoon.
Good afternoon.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. My name is Dr. Francis Vesey. I'm a chiropractic physician who has practiced in New Britain for nearly 30 years. In the past, I have served as president of the Connecticut Chiropractic Association and am representing our membership today to comment in support of House Bill 6885, an act concerning Medicaid payment rates. Thank you very much for pursuing this issue during the 2023 session. House Bill 6885 will phase in Medicaid reimbursement increases over a 5-year period to get them to 100% of the federal Medicare rate in fiscal 2028. This is an important goal that would be reached in a responsible manner. As a chiropractic physician, I have had the opportunity to treat a variety of patients who have a variety of health insurance benefits. It's become increasingly evident that treatment of a patient with Medicaid as their only insurance carrier is woefully under-reimbursed as compared to a patient covered under Medicare. So let me give you an example. When I perform a spinal manipulation in 1 or 2 areas of the spine, Medicaid reimburses $15.12. When I do 3 or 4 areas of the spine, the reimbursement is $20.72. The Medicare rates for these 2 different codes are higher, $23.14 and $35.60 respectively. Because of the low reimbursements, many chiropractic physicians opt not to accept any new Medicaid patients or fail to enroll in the program altogether. Enacting House Bill 6885 will put the reimbursements on a path that can reverse those disincentives and increase access to our services by low-income patients, many of whom desperately need help with their pain. Chiropractic helps patients deal with their pain without resorting to narcotics or pain medication, painkillers. We are a cost-effective modality with documented positive outcomes. With this in mind, I would strongly encourage you to support House Bill 6885. It's a win-win situation for everyone. Thank you.
Thank you, Dr. for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you.
Okay, thank you.
Next, we have Melanie Wild Lane, followed by Aisha Clark.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. I am Melanie Wild Lane. I'm the Executive Director of the Connecticut Association of School-Based Health Centers, and thank you for the opportunity to testify in support of HB 6885. I'm going to go off script for my written testimony because I've been before you multiple times in multiple venues testifying about the importance and the impact of school-based health centers. I feel like I'm preaching to the choir. So as it pertains to HB 6885, I think it's important to have an understanding of why this bill is such a huge step in the right direction for school-based health centers. Our staff spend a tremendous amount of time providing what we call case management services. Those are non-reimbursable services such as nutrition and physical activity counseling, preventative counseling, risk assessments by our medical providers for suicide, depression, anxiety, etc. We're able to do these things and spend this case management time with our students because we're co-located in the school. And so we have access to them for 6.5 hours of the day. Believe it or not, visit types like nutrition and physical activity counseling occur very frequently. In fact, DPH requires that our DPH funded sites report how often these visits occur and that our medical staff are required to offer nutrition and physical activity counseling to any student seen with a medical visit that fall with a BMI greater than the 85th percentile. So meaning that they fall into the obesity category. So some data in 2021-22, our medical providers saw 15,604 students and conducted a BMI on each one of those. And 6,288 students fell within the greater than the 85th percentile in their BMI scores. So these are for DPH funded sites only. Over 5,000 of those students accepted and received physical activity and nutrition counseling. And as a previous school-based health center director, I can tell you that's not a one-off. That's not one visit, that's multiple visits over the course of a few months, over the course of a school year. It includes groups, it includes parents, and those are all non-reimbursable services, not even for an office visit. If that same student was to go to their primary care doctor, they wouldn't get the same level of counseling. But that primary care doctor could bill for that office visit and be reimbursed for providing that counseling service. So I ask that you move this bill forward. It will help in the financial sustainability of school-based health centers, in being able to sustain and expand our staffing as we move forward. And I ask that you vote yes and move it forward. And I'll take any questions.
Thank you so much, Melanie. Are there questions from members of the committee? Seeing none, it's good to see you again. You are a frequent flyer before us.
I am definitely. Have a great day.
You take care. All right. So next up, we have Aisha Clark, followed by Dr. Brian Lynch.
Good afternoon, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Service Committee. My name is Aisha Clark, and I serve as the Interim Executive Director for Health Equity Solutions, a nonprofit organization with a statewide focus on advancing health equity through anti-racist policies and practices. Thank you for hearing my testimony today in support of HB 1203. People go to hospitals in their worst moments, seeking care after a car accident and/or for cancer treatment. Are some examples. These costs are not predictable because we don't know when we are going or when we are going to become ill or injured. And because when hospital prices are not publicly available, we don't know where to go. The out-of-pocket costs of patients are not new. No one should discover in the days or months after a hospital visit that the bill far exceeds their savings and be unaware of hospital programs designed to help. Yet, even though non-hospitals are required to provide financial assistance, extensive reporting exists or struggle to access them. Medical debt is a growing problem and one that disproportionately burdens Black and Latino families in our state. We submitted detailed written testimony about the link between structural racism and medical debt, and our work with grassroots partners to identify the proposals in the bill are a key priority. HES also conducted a policy scan of hospital financial assistance policies across the U.S. to ensure any proposal would be feasible for the state and hospital systems. Senate Bill 1203 would increase awareness of hospital financial assistance programs, streamline the application process, and add transparency and accountability to ensure all hospitals are held to the same standards and patients have recourse when something goes awry. Each of these policies has been tested in other states. HES and other coalition partners strongly support that these measures and tools are able to stop unnecessary medical debt from occurring and move towards equity and access to health care. SB 1203 and also House Bill 6740 complement each other healthcare affordability proposals raised in the legislative session, including proposals to ease medical debt, increasing eligibility to Husky programs and covered CT, and address drug pricing and excessive hospital charges. We strongly urge the committee to align the language of this bill than that of the HB 6740, retaining the additional cost reporting requirements and tasking CHA with drafting the universal application for approval by OHS. I will also note that HES has submitted testimony in support of other bills being heard today. Thank you for this opportunity to testify in support of SB 1203. I'm happy to take any questions.
Yes, thank you, Ms. Clark. It's good to see you, and I'm particularly interested in the differences between this bill and the bill you referenced that's in front of I think it's still in front of the Public Health Committee, because it sounds like we don't have stuff that they do have, but then also I think there's a section, I think section 7 of this bill is not there, and can you just sort of walk us through that?
Oh, sorry. Will help if I come off mute. So yeah, so some of there is a complement to what you just shared. It's the affordability proposal raised in this legislative session. And this is the part to erase the medical debt. And this is the part for eligibility of the Husky programs, and then adjust the drug price and excessive hospital changes. And so those are and then retaining, that's what's in 6740 is retaining the additional cost reporting requirement. That's in 6740, that's not in the 1203. Additionally, that last part of just making sure that there's a universal application that is designed by CHA, but then approved by OHS. So not OHS having the responsibility to do it.
Okay, you're talking fast and furious, so I'm trying to
Oh,
keep.
I'm sorry.
Okay. And I know you're steeped in this, and some of us are more generalists. So just a quick question about section 7 of 1203. And I don't believe that's in the public health bill. That's about hospital price transparency, and that's in our committee's bill. That says that hospitals that violate the provisions of the federal hospital price transparency bill are limited in their ability to recover medical debts. Is that something that you have an opinion on one way or the other?
Yes, and my apologies, like you said, I was talking pretty fast. I conflated the two. It's language that's in the 1203 that's not in 6740. And so we are in a space of, you are correct, we do want that information to stay in that particular bill. So we are supportive of that language.
Okay, great. Are there questions from members of the committee? Seeing none, thank you for your work, your advocacy, and we look forward to working with you.
Thank you so much.
Take care. Next up, Dr. Brian Lynch, followed by Dr. Jonathan Craig Allen. The name may be, apologies if the name is configured incorrectly. Dr. Lynch.
Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. I'm Dr. Brian T. Lynch. I'm an optometrist practicing in Brantford, Connecticut. I also serve as the legislative chair for the Connecticut Association of Optometrists. We appreciate your discussion on House Bill 6885, an act concerning Medicaid payment rates. We are very supportive of the proposal. Optometrists have served for years as the primary eye care provider for the Medicaid population. Our Medicaid patients have grown to depend upon us to meet both their vision care as well as medical eye care needs. Approximately 70% of all the eye care delivered to the Medicaid population has been delivered by optometrists, both on a national level as well as on a statewide level. A 5-year phase-in of the Medicare rates to comparable Medicaid rates to comparable Medicare rates as provided in HB 685 would make care more accessible by encouraging many providers to get into the Medicaid provider panel. Below, you'll find that in my testimony, I included some examples of commonly used fees, both procedure fees, procedure codes, as well as diagnosis codes that we use on a regular basis, and the difference between the Medicaid fees as well as the Medicare fees. We also hope, if this bill moves forward, that you'll consider eliminating the disparity that exists between the reimbursement rates between optometry and ophthalmology. Optometrists as non-MD providers are paid 10% less than our medical colleagues. This is not the case within the Medicare program. Medicare pays all providers equally based upon the procedure code. Again, I thank you very much for considering this, and happy to take any questions with regard to optometry.
Thank you so much, Dr. Lynch. And I did not know that last part. We were surprised to hear that. And so as we look to Medicare as a possible example, that's certainly instructive. And are you just for edification, are you like most providers pegged at 57.5% of 2007 rates? Is that where you are right now?
That is correct. Yes. Go ahead.
Yeah, I'm sorry. I didn't.
The Medicare population, as I say, the Medicare fees are basically the same for pretty much all of us.
Okay. Are there questions from members of the committee? Yes, Representative Comey.
Hi, Dr. Lynch.
How are you, Robin? Nice to see you. I like the glasses too.
Thanks. No, I just appreciate you coming out here every year and trying-
Representative, I'm sorry. Dr. Lynch, I understand you say that to all legislators.
I do.
Thank you. Please
No,
proceed.
I just want to thank you. I just want to thank you for coming out and every year, you know, you represent the society, your organization, and your colleagues so well across the state. And I'm hoping that, you know, this is the first year that I'm on Human Services, so I'm just glad to see you here. And we're hoping that we can get move some of the reimbursements forward this year. So just wanted to say thanks, and thanks for what you do for Branford and for
Thank you. Thank you very much. It was good to see you again, and hopefully we will move forward on this.
Thank you, Representative. Thank you, Doctor. Are there questions or comments from members of the committee? Seeing none, thank you for being with us this afternoon.
Thank you so much again, Senator.
Next, we're going to hear from Dr. Jonathan Craig Allen, followed by Mark Schaefer.
Thank you, Representative Gilchrist, Senator Lesser, Representative Case, Senator Seminara, distinguished members of the Human Services Committee. I am, that is my name, Jonathan Craig Allen. I was given 3 first names, which helps with bill collectors, but can be confusing otherwise. I'm the medical director at Rushford Behavioral Health. I'm a child and adolescent psychiatrist, adult psychiatrist, and addiction medicine doctor. And I work here in Meriden, Connecticut. I want to thank you for the opportunity to testify in support of SB 1205. Workforce shortages are a problem all across healthcare, and anything we can do to shore up these deficits will play an important role towards improving the lives of citizens here in Connecticut. Incorporating people with lived experience and specialized training in the treatment paradigm addresses this person power deficit while providing treatment teams with members who understand the culture, environment, social, and economic factors and prejudice often faced by those seeking care. Peer recovery support services help break down barriers while supporting, motivating, and navigating patients towards better and coordinated healthcare. In addition to the above benefits, a resourced peer recovery support service affords a sustainable path to meaningful work for those in recovery. Peer recovery support services are already an important part of the treatment continuum. However, currently these resources are primarily tied to grants or awards of a finite duration, making it challenging to build and plan systems focused on the future. Today, with a greater understanding of addiction, the complex ways that people are influenced and motivated, and of the process of change itself, we can engage more effectively by including trained peers in the work. By listening to our patients without bias, stigma, or discrimination, we can reduce their shame and help make our healthcare system a sanctuary of hope. Through collaboration and compassion, we can provide patient-centered services, meeting patients where they are at and offering meaningful and caring treatment while creating an environment of hope and healing. I want to thank you for the opportunity, and I strongly encourage you to vote in support of SB 1205. Earlier, just to comment, I heard Jordan talking, and there were a number of questions around certification and training. And I think it's going to be essential that there is a certain level of training. But just as an example, at the Recovery Leadership Academy, that's one of the peer training programs in the state. There's 80 hours of training, which typically spans over 3 months. And that training is how to work in a medical system, how to work with medical and addiction providers. And it's essential that there's a certain level of training as well as a level of supervision for these providers. The names can change from state to state. Recovery coaches in the state of Connecticut from CCAR, they do an excellent job. They're primarily focused on substance use disorders, whereas recovery support specialists out of the program, the RLA program, may focus both on mental health and substance use disorders. Happy to take any questions you guys might have.
Thank you so much, Doctor, and thanks for the clarification. Apologies for the confusion about, well, actually, we weren't confused about your name.
No, you had it right.
So just to drill in on the last part that you were talking about, there seems to be a difference of opinion about how best to proceed. So the bill that we have contemplates DMIS certification versus the comments we heard from Jordan Fairchild were that we should wait for DPH licensure. Obviously, either way, we need some sort of supervision, but I'm just curious if you have thoughts on that or how we should be thinking about.
I don't want to wait. I think that the training programs that we have in place, and I've worked with CCAR's recovery support, recovery coaches in the emergency rooms across Hartford Healthcare and in our facility over here in Meriden, and they do an excellent job. I've worked with recovery support specialists who come out of the Recovery Leadership Academy, and they do an excellent job working with patients with both mental health and substance use problems. So we need that help, and we need that support, and we need it now. Whether it's DEMAS providing oversight or DPH, I'm not sure what the advantages would be.
Okay, I think one of the things we need to really suss out, though, is whether or not we can get Medicaid reimbursement until DPH licensure is in place. If we can, great. If we can't, then that's going to be, really instructive.
Yeah.
But obviously, I think everybody wants to move forward. The question is how best to do that. Are there questions or comments from members of the committee? Representative Gilchrist.
Thank you, Mr. Chair, and thank you so much for being here, Dr. Allen. My question, and I don't know if you know the answer, but it was mentioned earlier, and I believe you mentioned it, that other states do have Medicaid reimbursement for recovery coaches and or recovery support specialists. Do you know how many states? Do our surrounding states?
I don't know how many states. I believe that New Jersey does. I'm not sure about New York. They may as well. But I don't know the number, but there are states on our borders. Now, Jersey isn't one of our borders, but near our borders that do have Medicaid reimbursement.
Okay, thank you.
Yeah.
Connecticut does not have borders with New Jersey currently, but one day we might. Thank you very much for your testimony this afternoon. Next up, we have Mark Schaefer, followed by William Schittinger, followed by Greg Shangold. Good afternoon.
Good afternoon, Senator Lesser, Representative Gilchrist, Senator Seminara, and Representative Case, and members of the committee. I'm pleased to be here to testify in support of House Bill 6885 with modifications. I'd like to step back from a focus narrowly on rates to talking generally about Connecticut's longstanding underinvestment in the Medicaid program. So low rates to pay to providers are starving the care delivery system of essential resources. There are three important consequences of chronic underinvestment in Medicaid reimbursement. One is that Medicaid beneficiaries have poorer access to specialty services than their commercial counterparts, and they suffer from poorer health and healthcare outcomes and preventable health disparities. Two, Medicaid providers lack the resources they need to invest in continuous improvement, to recruit and retain staff, and data analytics and that sort of thing. But thirdly, and importantly, commercial health insurers pay higher rates to make up for Medicaid underinvestment. This, in effect, acts as a hidden tax on employers and employees who ultimately bear the cost of these higher rates. So let's talk a little bit about Medicaid underinvestment. In a recent presentation to the Medical Assistance Oversight Council, the Department of Social Services highlighted the extent of this underinvestment. In 2022, using data from the National Association of State Budget Officers, the department reported that Connecticut spent 27% less than other states as a percent of their state expenditures on Medicaid services. And that's compared to the peer states, northeastern peer states, including all of New England, New York, and New Jersey. If Connecticut committed to a comparable level of investment, it would need to increase its Medicaid spend annually by more than $2.5 billion. By consistently underspending during the period 2017 to 2022, they left more than $7.5 billion of federal matching revenue on the table. So Combined with the state share, what Connecticut could have put in, that's revenue that could have strengthened the care delivery system. It could have driven better health outcomes for Medicaid beneficiaries, and it could have reduced pressure on commercial prices and contributed to the broader economy. So when DSS reports that they're among the lowest growth Medicaid programs in the nation at an annual rate of only 0.4% per year from 2016 to 2022, we should be asking ourselves at what cost? As you might expect, Connecticut's reimbursement for hospital services is also among the lowest in the nation. Every year, DSS has to do a demonstration looking at how hospital reimbursement compares to what Medicare would pay. After accounting for the taxes that hospitals pay, the net reimbursement they receive is 54% of what Medicare would pay. With regard to taxes, the hospitals are the 5th largest source of tax revenue. They pay enough in taxes, $850 million a year currently, to subsidize the entire cost of Medicaid hospital coverage in Connecticut when combined with the federal share. So the chronic underfunding of Medicaid in general and hospital services in particular drives higher commercial prices, and it robs us of an opportunity to focus on driving improvements in health and access for Medicaid beneficiaries. I'm happy also in the question period to talk about rates for physician specialists, which we see featured in Section 1, and we heartily concur that, like hospitals, they should receive reimbursement on par with Medicare. I was responsible for setting those rates in 2007. I'm embarrassed to say, because at the time that we set them in 2007, we really didn't dream that they would not be changed except around the edges for about 15 years. So thank you. Happy to answer any questions you have.
Well, thank you, Mr. Shaver. Obviously, you did a good job, which is why we've kept your rates in stone for the rest of time. But thank you for your testimony. It's very helpful. I was going to ask a question specific to the Hospital Association, but since you threw that last bit in, can you just sort of take us back to those heady days in 2007 and just tell us how you did it?
It was very much consistent with what Guy Woolston described this morning, which is Medicare is really, while not perfect, it's really the gold standard reference for a thoughtful process for setting price. And all we could afford to do in most specialty areas, obstetrics, behavioral health, a few others, primary care notwithstanding, was 57% of Medicaid. The state basically, because at the time it was in Medicaid managed care, and a lot of the specialist services were funded through Medicaid managed care where rates could be negotiated. So it didn't have as significant an impact to underpay on the Medicaid fee-for-service side, because you actually had a way for specialists to negotiate more. When we took apart the Medicaid managed care program in 2012, we didn't put into place any mechanism to provide for ongoing increases in physician reimbursement and other reimbursement, including hospitals, that used to exist when you could negotiate rates. And without a policy that affirmatively makes a decision to invest, you essentially get a situation where the rates are hard coded, and there's often not the will to spend the additional dollars.
So I assume the major impediment to directly increasing hospital rates is, well, you said $2.5 billion. How much would we need to?
Well, the $2.5 billion is how much more Connecticut should be spending on Medicaid generally, not for hospitals in particular, but physician specialty and behavioral health services and the like. $2.5 billion a year to spend as much as a percent of our state budget as, say, Massachusetts does, or the peer state average. For hospitals, according to this analysis, it would take another $900 million to $1 billion in spend for hospitals to resolve the underpayment. But the state would only have to pay a third of that, because for every dollar they pay for hospital services anyway, there's $2 that are drawn down from the feds.
Okay, that is helpful, but it's still all of the bills that we hear in this committee, we have to then, or almost all of them, we have to go take to our friends in the Appropriations Committee and make a case. And I imagine we would have a fair amount of pushback. And so helping us think through that, obviously your members are not all similarly situated with payment mix. There are some that are on shakier financial footing than others. There are some that serve, critical rural areas that may not have other options. There are others that, so I'm just trying to think through how else we could go in and ask for $300 million from appropriations, and they will tell us whatever they want to tell us. But I'm just trying to think through ways that we can bring it, sort of focus on critical areas of need, or, make a case that we are better able or best able to sell.
So, so a couple of things. Hospitals generally are facing a great degree of financial pressure, and the ones that are having the most difficulty currently cut in, in unusual ways. It's not necessarily large versus smaller independent hospitals. I think that also all of the, as you know, from some of the other bills that have been proposed, there's pressure on hospitals to not negotiate as high, to continue the same trend of negotiating commercial rates. And with that pressure under the cost growth benchmark to try to manage cost growth on the commercial side, I think we need to think about hospitals and providers generally, but hospitals across the board, however they may be faring currently in terms of Medicaid reimbursement. To your question about the long game, my sense, I was in state government for 20 years. I started at DSS in 2000. I think what we've lacked is a 10-year strategy for where we want to go with Medicaid. You have to build out to that. There are many states that have done structural reforms to the Medicaid program that are bringing a great deal of flexibility to bear in terms of how Medicaid dollars are spent to drive improvements. When I was at the Office of Health Strategy, we did a study that showed if Medicaid structured itself to put a greater emphasis on prevention, it could drive $1.2 to $1.8 billion in prevention-related Medicaid savings over 10 years. So for me, foremost, the policy challenge is how do we combine an investment in the care delivery system with expectations around the kind of performance we want to see from the Medicaid program, both with regard to chronic care outcomes, but also with regard to prevention outcomes.
At the risk of asking you to testify against part of our bill, we do provide, as I understand, a much higher reimbursement rate for primary care folks than for specialists right now. So by increasing the specialists in this bill, are we undoing the work that's already been done to try to incentivize prevention over?
Well, I think that prevention extends far beyond primary care to the root cause drivers that contribute to these enormous disparities that you see geographically in Connecticut and for different race ethnic groups and that sort of thing. So I don't think we should pull back from our investment in primary care and from some of the ideas that DSS is considering on how to build out stronger primary care teams with community health workers and that sort of thing. At the same time, folks need access and ought to have access to specialty services like they do other services. I think that's all part of taking better care of people who have health conditions. But at the same time, I think we should enlist, I think that hospitals have the ability to play a role in driving improvements in the conditions that drive poor outcomes, going beyond what happens in primary care and specialty. And that could be a parallel strategy. So I would hope we wouldn't have to make a choice between these things, but we invest adequately in hospitals, adequately in primary care, and adequately in specialty services, and adopt a strategy for growing the Medicaid program that works from a budget perspective, because I totally get what you can reasonably expect from appropriations. But we really do need to be thinking about that long game if we're going to take on challenges like the cost growth benchmark and take on challenges like the epidemic increase in severe obesity and cardiovascular risk, hypertension, and diabetes that is driving a significant part of the cost of care in both the commercial and the Medicaid sectors.
So one additional question, the other thing that's hanging over us is the hospital settlement. And I know that that's expiring some point in the next, the next 2 years,
In
right?
2026.
Okay. Anything that we should, is there anything in there that limits, I think there are provisions there that limit what we can do in terms of Medicaid, but could you just bring us up to speed?
So the settlement doesn't limit how much. It limits the state's ability to pull back from the rate increases that were established in the settlement and the supplemental payments that are part of that arrangement. It doesn't prevent the state from making additional investments over time. And it also prevents the state from imposing a downside risk value-based payment model or that sort of thing in the near term. I think that we do need to be thinking about how the overall structure of taxes and payments and reimbursement fit together to both drive the outcomes we need and also the financial strength of hospitals and also the affordability goals that we have in commercial. It's not too soon to begin that conversation with 2026 effectively around the corner.
Okay, and I assume with the consent of all parties, I don't know that we would ever get there, but I assume that the terms of the hospital settlement, to the extent that they conflict with anything that we, agree on, could be modified. I'm speaking hypothetically, not asking you to commit to negotiate with the state right here.
So it would be, it's not career advancing for me to suggest we should, no, that's said with a great deal of humor. I don't think the settlement is, I think it is the right sort of foundational structure for the next 2 years. I don't think it's reasonable to take apart the settlement, but rather to begin to talk about what a more ambitious strategy for Medicaid could be, one that basically addresses these multiple points of interest. So you would have to tamper with the settlement in order to pay hospitals less. It doesn't make sense to pay hospitals less over the next between now and 2026. You would not need to tamper with the settlement to put into place some provisions for paying hospitals more. And it doesn't need to be necessarily where you want to get to, over the long game. So,
great, thank you. Yes, Representative Gilchrist, and followed by Representative Pluto.
Thank you, Mr. Chair. Thank you, Mr. Schaefer, for being here and for your testimony. I just wanted a clarifying question. So in hospital settings, the individual providers get the fee for service, but then is there a different methodology from which the hospitals are paid through Medicaid? And if so, can you explain that piece?
Sure. So hospitals are also paid a type of fee for service, which is they get paid for every admission to the hospital or visit to the emergency department or outpatient service rendered. And so it's effectively a fee for service system. And it's using a methodology that Medicare developed, which is basing a payment on the condition for which somebody was admitted, if it was an appendectomy or that sort of thing. But it's in effect a fee for service model.
And then the providers themselves in the hospital are also
the physicians and other practitioners who render services in hospital settings, they bill for the professional services separately, and then the hospitals bill for basically the costs of providing the inpatient and outpatient services that enable those practitioners to render the services that they do.
Thank you. So back to your first answer, those hospital-based fees would be included in Section 1, or do you not see them as included in Section 1 of this bill?
So I would have I think that that's a question for the drafters of the bill. Individual healthcare providers is vague. I think that I would like to interpret the intent of that as inclusive of acute care hospitals, but you'll notice they don't include methadone maintenance providers in there necessarily. That's a fee-for-service program. Chronic disease hospitals are subject to a special study. So it wasn't clear to me from the reading of section 1 that it would include every provider of every fee-for-service participant in the Medicaid provider network.
Thank you very much.
Thank you, Representative Pizzuto.
Thank you, Mr. Chairman. Mr. Schaefer, just quickly, I noticed in my areas, there's a lot of boutique docs starting to set up shops whereby they put an undue burden on the general practitioners, the behavioral health docs. The private practices are kicking those patients to the hospital, and they're just taking the patients that can pay. And so it's putting a disproportionate amount, and I'm on the Waterbury Hospital Board, where they're coming in, and obviously they're not getting the same fee, but they're actually giving up patients to the ones that can pay versus using Medicare, Medicaid, and so forth. And do you see that happening elsewhere?
Well, I think you're pointing out a very important consequence of under reimbursing specialty services, which is that a lot of folks who could be served by specialists in the community may not get access to those services, and they may end up getting services downstream when their conditions get to the point where they need hospital care, and hospitals, of course, provide services regardless of ability to pay. That's not as good for Medicaid beneficiaries as ensuring that we're reimbursing providers enough to afford access early on, the kind of access we would all want when we first become aware of symptoms or a condition so that we can get timely treatment. And sometimes that timely treatment really requires the involvement of a specialist in addition to the primary care.
Thank you. Thank you, Mr. Chairman.
Thank you, Representative. Senator Seminar.
Thank you, Mr. Chair, and thank you so much for your testimony. I'm really just asking two clarification questions because I want to make sure that I heard you correctly.
Sure.
So you said, or it's your estimation that in order to bring the Medicaid system back to where it should be, it's 2.5 billion with a B.
That's right. That's a point of reference. So when you look at other northeastern states, that's how much more they're spending on average, or that's to match the same point, that same reference point, 2.5 billion. To match that same percent spend, you would have to spend $2.5 billion.
Okay,
more.
and then my other question, maybe I have three, sorry. My other question was, in your estimation again, was it an additional 900 to 1 million or $1 billion to put hospitals back on track?
To make
Was
up,
it additional?
it was an additional 900 million to $1 billion,
Okay,
of which the state would have to cover about a third of the cost.
okay. And then for the long game, which again, your estimation in the 10-year strategy, if we were to do some type of 10-year strategy, it was 1.2 to 1.8 million in prevention. It would help us.
So surprising as it might seem, the actuary that worked on this model for the Office of Health Strategy estimated after an extensive federally funded planning process that there was an opportunity worth about 1.2 to 1.8 billion dollars
Billion with a B.
in savings.
Okay.
That's
Okay.
right.
Sorry, I just needed to get clarification on all those numbers. Thank you.
No problem. One point just about that the state has to put in a third for the hospital reimbursement. As you may know from testimony from Guy Woolston or from other presentations they've done, generally speaking, so there's differences in the match rate for different parts of the Medicaid, different people in the Medicaid program, right? Husky D is matched at a different rate as others. When you mix all those together, the match rate is around 60% for the Medicaid program overall. For hospital services, because they see a different mix of beneficiaries, the effective match rate, that sort of blended match rate, is closer to about 66 or 7% of the cost. So I just want to reconcile that if it seems like it doesn't fit with some of the other things you see.
Okay, thank you. Thank you for clarifying.
You're welcome.
Thank you, Senator. Representative Cook.
Thank you, Mr. Chairman. And hi, Mark. It's great
Hi.
to see you. I think we've been down this road now for 15 years.
Yes.
So I want to go back to something that you said. I'm intrigued by the statement that you made about the 7.5 billion that was left on the table or off the table, depending on how we're looking at that. So where does that come into play? And we can't go backwards, but are we doing everything that we can currently moving forward to ensure that that doesn't happen again?
No, I'd say apart from those baby steps in this bill, we're not doing the things that we need to do to take full advantage of federal match, to strengthen the Medicaid program, and to also reduce the extent to which commercial employers and employees have to subsidize the cost of the healthcare delivery system. So we're not doing what we can, and in my view, should be doing to maximize those federal dollars.
So those recommendations, and so obviously your testimony is not under Mark Schaefer because it would be so much easier if I looked at it that way, but I know what it's under. Is your recommendations called out in any of the submitted pieces of testimony, or is that something that you can offer us offline to kind of help us in the direction, since you obviously know what part of the process we're in this legislative world?
So we could, so we don't go further in the testimony beyond saying that the target should be to get to 100% reimbursement on par with Medicare for hospitals. I think that how you get there would be something that would require some planning to put together a strategy. Because right now, I think, to go back to Senator Lesser, Representative Gilchrist's questions, there's one other limitation that prevents that from happening immediately, even with the Appropriations Committee were on board. And that is that there is, based on the way the Medicaid program is currently structured, an upper payment limit, which is set at Medicare, and the taxes and associated payments occupy space that could otherwise be Medicare reimbursement. And that means that one would need to figure out a way, if you want to preserve the provider tax. It's also possible one could get rid of the provider tax or shrink the provider tax. But if you preserve the provider tax, it would mean, if we want to improve our funding for hospitals, that we have to address this upper payment limit rule. And there are ways from a policy perspective that one could do that, but it requires that you actually, it would require some action on DSS's part to take advantage of the opportunities that exist federally to do that.
So I see Senator Lesser's wheels spinning, so I think he's probably going to want a further conversation on that. And then my second, and I do think that that's, so we can talk about that offline. I'm intrigued by that. I think that that's important. And I do believe that there's no better guru than you when it comes to this. I've seen some of the things that you've done, and we've worked together extensively over the years, creating a lot of things, trying to make it better here. Which goes to my second question regarding a statement that you made about some of the coverages that were kind of left out that might be to the betterment. So would you like to go a little bit more into that?
So I think that, sure. I think the main area where we see other states have recognized that and actually hospitals have recognized this as well in Connecticut, is that you need to address some of the barriers to being able to effectively engage in your healthcare, say chronic condition management of diabetes. You need to resolve transportation barriers around housing stability. You need to eat well, right? You need to have access to nutritious food and that sort of thing. And we've done some things at CHA and with the hospitals to set up for screening and referral to identify those barriers. But as you have folks identifying those social drivers, those barriers, you don't have a way to grow the capacity of community organizations to actually meet those needs. And so what some states are doing now is they are using federal waiver authority to make it possible to reimburse for supports that address those barriers. And so in the near term, if we want to get better chronic care outcomes, and I would say that this isn't sort of widely known, but diabetes poor control among the low-income populations, say served by FQHCs, is about a third. So the folks who have trouble managing their diabetes today because of nutrition and housing problems and that sort of thing end up on a road toward devastating health consequences, kidney disease and failure and retinopathy and a variety of other things. So what these other states are doing in recognition of the fact that it's critically important to address those social needs in order to affect certain healthcare outcomes is they've provided for Medicaid coverage of those services up to a certain limit for certain populations. I think that's half of what we need to be doing. The other half is I think we need to figure out why there's such a pipeline of need and figure out whether there's a way that the Medicaid program can be used to actually support investments in the root cause drivers, the lack of affordable housing, for example, or the lack of food deserts and swamps and that sort of thing. I think that there's a way to do both with the Medicaid program if we're thinking about what we would do with an additional investment, however large that investment turns out to be.
Thank you. Thank you so much for your expertise and your willingness to have the conversation. Thank you, Mr. Chairman.
Thank you, Representative. And yes, my wheels are spinning. Are there other questions or comments from members of the committee? If not, thank you for being with us.
Thank you so much.
Next, we have William Schittinger, followed by Greg Shangold, followed by Matthew Menegia.
Good afternoon, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is William Schittinger, and I'm the Regional Director of American Medical Response of Connecticut, which is the largest EMS provider in the state of Connecticut and is a critical safety net in the state's EMS system. I also currently sit as the chairperson for the Connecticut EMS Advisory Board. I'd like to thank you for the opportunity to testify and raise Bill 6885, an act concerning Medicaid payment rates. I'd like to be very clear. Our EMS system is facing unprecedented challenges that, if not addressed immediately, will immeasurably harm the quality of EMS that residents of the state have come to expect. Ambulance companies are now closing their doors because they can't afford to operate. The entire EMS system is reeling from a dire shortage of EMS personnel. Coverage gaps, increased response times, and delays in transports of patients from hospitals are the inevitable consequences of continued staffing shortages. As a member of the recent EMS Legislative Working Group, we submitted a report to the commissioners of DPH and DSS outlining these challenges that the Connecticut EMS system is facing. The report notes that these challenges are negatively impacting the way the EMS system functions, placing the system in crisis. Without the recommendations of the EMS Working Group being implemented, most importantly, an increase to the Medicaid reimbursement rates to mirror the Medicare rates, the system will not be sustainable. Ambulance providers are being squeezed by staggering increase in costs and stagnant revenues. 4 line items that have increased 10% or more over the last 4 years for AMR include payroll and benefits, risk insurance, vehicle operating costs, and medical supplies. The increase alone in these 4 items total a little over $13.6 million to AMR Connecticut. Section 3 of Raise Bill 6885 proposes to increase Connecticut's Medicaid reimbursement rates for emergency medical transportation by 10% for the fiscal year ending on June 30th, 2024, in each year thereafter, until the rates are aligned with Medicare reimbursement. I would like to recommend modifying the bill to condense the timeline, as well as to include non-emergency ambulance transportation, as well as paramedic intercepts. An increase of the Medicaid rates to Medicare for the services will require nominal additional state investment due to the fact the state will be reimbursed by the federal government approximately 70% of the total additional investment. This is a small price to keep our quality EMS system from imploding. In conclusion, over the years, ambulance organizations in conjunction with the state have built a quality EMS system that has saved lives and improved outcomes. Each of us expects the same level of service will continue into the future. These existing challenges, if not addressed immediately, will seriously harm ambulance providers' ability to respond quickly, efficiently, and professionally in your time of need. Increasing the Medicaid reimbursement rates and mileage rates for ambulance transports to the level of Medicare rates will be an important first step. I respectfully urge you to approve Section 3 of Raise Bill 6885 as amended by the revisions I have suggested. Thank you.
Thank you for your testimony. You said approximate Medicaid reimbursement rate will be about 70% back. Is that true across the board? If we were to expand the bill in the way that you suggested, would non-emergency also be covered in that way?
That's my understanding, that the federal government will reimburse up to about 70%.
Okay, great. Thank you. Are there questions from members of the committee? Representative David.
Thank you very much, Mr. Chair, and thank you for your testimony, William. Could you please let me know about what percentage of your sort of members are Medicaid transports and what are private insurance and what part are self-paying?
Sure. Thanks for the question, Representative. For AMR in Connecticut, we're about 30% Medicaid. We're about 50% Medicare, and the remaining are private insurance and uninsured. And that varies across state depending on the provider. I know Bruce Baxter from New Britain, I believe his Medicaid population was about 50% of his business.
So your different members have different risk percentages based on their sort of patient makeup. That's what you're saying?
Correct. AMR, we cover the 4 major cities in Connecticut. So we cover Bridgeport, New Haven, Hartford, and Waterbury. So those areas have the higher Medicaid population. We also cover smaller municipalities, Fairfield, East Haven, West Hartford. It's a smaller Medicaid population. So it really depends on the area that you're covering and the service.
Got it. And can you just make sure I'm on the same page? What's the difference in the rates between Medicare and Medicaid for the transport?
So my understanding is Medicaid is about I think it's 63% of the Medicare rates currently.
Got it. And are you familiar with other states in what percentages our neighbors in New England have as a percentage of Medicare rates?
So there are a couple of states, Maine, New Hampshire, Pennsylvania are underway, I believe, to get Medicaid up to Medicare. And there are other states around the country that have actually already brought Medicaid up to Medicare.
Got it. That's very helpful. Thank you so much for your testimony. Thank you, Madam Chair.
Thank you, Representative. Any other questions? All right, not seeing any. Thank you so much for your testimony and your time today.
Thank you.
Next, we'll hear from Greg Schengold. Go right ahead, Doctor.
Hi, good afternoon, Representative Gilchrist, and I see Senator Lesser is walking back in there. So good afternoon, and other distinguished members of the committee. On behalf of the Connecticut State Medical Society, thank you for the opportunity to testify on why DSS must increase Medicaid physician rates. I'm a residency trained board certified emergency physician practicing in Connecticut for over 20 years. I'm the past president of CSMS as well as the Connecticut College of Emergency Physicians and a managing partner for Northeast Emergency Medicine Specialists. Connecticut's Medicaid physician network is not adequate to provide acceptable care. Wait times to see specialists are long, primary care is scarce, and mental health care is nearly impossible to obtain. Many physician specialists have not seen an increase in Medicaid payment rates in over a decade. Current Medicaid payment rates are significantly less than the cost of providing care. During each emergency department shift, I care for patients who have let symptoms linger because they cannot find a physician accepting Medicaid. Increasing the rates will absolutely positively impact access to healthcare. Providing Connecticut's Medicaid population with coverage does not guarantee that they have access. Various studies, which are highlighted in our written testimony, show that increasing Medicaid rates will in fact increase access to care. When patients have access to care, chronic disease is managed. On the other hand, unmanaged disease leads to severe complications and delayed diagnoses, resulting in higher healthcare costs. Medicaid rates are often compared to Medicare. DSS reports Connecticut specialists are funded at 57% of Medicare, which in a 2019 Kaiser Family Foundation study ranks as 47th nationally. In emergency medicine, the fee schedule was implemented in 2011 and has not been increased. Yet from 2011 to 2022, inflation was 34.8%. What other crucial government service that is critically necessary for 27% of Connecticut's population has been flat for 13 years? House Bill 6885's 5-year escalation plan is a good start to address the past few decades of inadequate attention to this problem. Medicare is a good starting point, but the reality is that Medicare does not keep up with inflation. And in 2023, there was actually a 2% reduction for physicians. The Connecticut Medicaid fee schedule should be insulated from future Medicare reductions. For the purpose of this bill, CSMS believes 2022 Medicare should be the benchmark, as it's not specified in the bill. In addition to 2022 Medicare, a rate increase should be tied to the Consumer Price Index. Medicaid is as important as Social Security, and Social Security's cost of living adjustment is based on a formula that incorporates the CPI. There's no reason we cannot do the same for Medicaid. No current physician rate should be reduced by House Bill 6885, as primary care and OBGYN services are currently higher than that 57% that was quoted. Connecticut cannot wait for study results to increase Medicaid payment rates. If we don't raise rates now, then when will it happen? In 15 years? In 20 years? The status quo cannot remain. We are not opposed to a study, but concurrently, we must raise rates so Medicaid patients can get access to care. Medicaid patients have trouble every day accessing community health care. By increasing Medicaid rates, Medicaid patients would have much better access to health care, and the emergency department would be strengthened as an adequate safety net for all of Connecticut. Thank you very much, and of course, I'm available to answer any questions.
Thank you, Dr. Shangold, for your testimony. I was not aware of that. Was it 2003 you said?
Which thing? The emergency medicine?
When was the Medicare cut that you discussed?
Oh, this year, 2023, all physicians went down by 2%.
Okay.
I had, if in my written testimony, you can see some graphs because physicians have been not having the pay increases by Medicare as other aspects of healthcare.
And was that because it was the MEI negative this year, or was that some other factor?
There's multiple factors that go into it, but the way they budget it, there were some sequestration issues that came about and other reductions. There was a bump that had originally come in 2020 due to COVID that was taken away this year. But I do have in my written testimony a graph, and you see the downturn that happened. And if you go back over the past, I believe, 20 years, there's been a 53% reduction when comparing Medicare rates to inflation.
I hear you, doctor. I guess I think we're in a frying pan fryer situation, and right now you're getting 57.5%. You're pegged to Medicare, but you're getting 57.5% of what Medicare paid in 2007, and we're talking about rebasing you to moving you up to 100% of what Medicare pays today. And I understand the problems with Medicare, and that's not necessarily the place that you would inevitably want to be, but it seems like it's a far shot better than what you got now, unless I'm missing something.
Yeah, no, as I said, it's a good start, but it'd be nice to develop a formula that uses CPI, when I still have employees to pay for, we have other costs of business. We pay for our own health insurance. You have a lot of other aspects of running a medical business. And when you don't do this, as Dr. Schaefer said, the cost shift is there, it goes to commercials, or you get more consolidation, which I know we've talked a lot about this session as well. Private doctors just no longer can do it, and they start to join these big groups. And I know consolidation is one of the legislature's concerns this session.
All right. Thank you, Doctor. Are there questions from members of the committee? If not, thanks for being here this afternoon.
All right, thank you very much.
Next up, we have Matthew Minigia. Apologies to everyone whose names I'm mispronouncing. Followed by Miriam Hakeem Zargar, Dr. Hakeem Zargar.
Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. My name is Matt Managia. I'm a licensed acupuncturist and owner of Connecticut Family Acupuncture, and we have offices in Glastonbury, South Windsor, and Tolland. I also serve on the board of directors and chair the insurance committee for the Connecticut Society of Acupuncturists. I'm representing the society today in support of House Bill 6885, an act concerning Medicaid payment rates. I'd first like to thank the committee for adding acupuncture as a covered benefit under Medicaid. Since October of 2021, acupuncturists across Connecticut have been happily providing service to a community of patients who have been previously underserved and unable to pay out of pocket for non-pharmaceutical interventions like acupuncture to treat their chronic pain and other health conditions. At my practice alone, we've seen many inspirational transformations take place in our population of Medicaid patients. These are some of our most committed patients, and the gratitude they demonstrate for having access to this medicine is heartwarming, to say the least. For many of these patients, acupuncture is the only intervention that provides relief. And as I'm sure you're all aware, acupuncture is now firmly entrenched within the conventional medical community. It's been a joy for me personally to watch that transformation firsthand through my 16 years in practice. Every day now, acupuncturists across Connecticut receive countless referrals from MDs who are trying to help their patients manage chronic pain and other health conditions without the use of potentially dangerous and addictive drugs. With this explosion in acceptance and utilization of acupuncture, it's often very difficult for our relatively small number of licensed acupuncturists to keep up with demand. A great majority of private and commercial health insurers now cover acupuncture, and most acupuncturists participate in those insurance networks where it is financially feasible to participate. Unfortunately, the low reimbursement rates currently provided by Medicaid are preventing a large number of acupuncturists from participating in the program. This, of course, makes access to care difficult for those in the Medicaid population who often have to travel unreasonable distances to utilize their acupuncture benefits or wait weeks to get an appointment with an in-network provider. Currently, Medicaid rates for acupuncture are set at approximately 55% of those set by CMS for Medicare. To illustrate, an average hour-long acupuncture appointment is paid at roughly $56 by Medicaid, while Medicare reimbursement for the same session would be around $103. As such, it's easy to see why so many acupuncturists cannot make it work financially to participate with Medicaid. HB 6885 would phase in Medicare rates for licensed acupuncturists under Medicaid over the next 5 years. We welcome this as a modest and reasonable request that will greatly expand access to safe, highly effective, non-pharmaceutical care, and indeed quite affordable treatment options for the Medicaid population. So in closing, the Connecticut Society of Acupuncturists would greatly appreciate your support for House Bill 6885, as it will increase access to healthcare for low-income citizens and families throughout the state. Thank you.
Thank you so much for your testimony. Are there questions from members of the committee? Yes, Representative Dathan.
Thank you very much, Mr. Chairman, and thank you for your testimony. I have been a patient of acupuncturist, and I really think it's wonderful, and I'm glad to hear that so many people are taking advantage of it. Do you have any idea of the CT Society of Acupuncturists, what percentage of those members take Medicaid patients?
I don't know off the top of my head. My guess is roughly 15 to 20% at this point.
Okay. I always worry about access. So, I don't want you to not be able to get acupuncture treatment if you're living in the northwest corner, for example. We want to make sure they are all over. What do you have any sort of data about what percentage of the acupuncturists that do take Medicaid are represented in each of the I'd say counties, but the geographical locations in our state?
So I would say that our society is somewhat overrepresented by Fairfield County. It's just where historically acupuncture not being covered by insurance. I think most patients were paying out of pocket. So a lot of acupuncturists set up shop, in an area that was more likely to have people able to pay out of pocket. So did that answer your question?
That makes sense.
Yeah.
Do you know in the Northeast in New England states, what other states have Medicaid coverage over acupuncture?
So Connecticut is a leader in providing acupuncture benefits under Medicaid. I believe currently there's only 5 or 6 other states, Washington, Oregon, California. So especially in the Northeast, I believe Massachusetts and New York currently. But don't quote me on that. I'm not 100% sure.
That's all right. Thank you so much. I appreciate your testimony. I hope you have a good day. Thank you, Mr. Chair.
Thank you, Representative. Any other questions or comments from members of the committee? If not, thank you for being here this afternoon.
Thank you so much.
Next up, we have Dr. Hakeem Zargar, followed by Verna Little.
Hi, good afternoon. Thank you so much, Representative Gilchrist and Senator Lesser and esteemed members of the Human Service Committee for allowing me to give this public testimony on behalf of all 270 of us orthopedic surgeons in the state of Connecticut. And specifically, thank you, Senator Lesser, for introducing this very, very timely and so important bill. My name is Maryam Hakeem Zargar. I'm a past president of the Connecticut Orthopedic Society, and I'm a practicing orthopedic surgeon in Torrington. I've been in private practice here since 2007. In Connecticut, the Connecticut Orthopedic Society has already submitted written testimony. I'm basically here to expand on it, give you some examples, give some context, and answer any questions that you might have directly and specifically about orthopedics or medicine in general. As you're aware, healthcare delivery in our state is in crisis. Medscape has consistently voted Connecticut in the top 5 worst states in the country for physicians for the past 15 plus years. A big part of this problem is the economics of medicine in our state. Connecticut's the richest state in the union, yet 1/3 of our population's on Medicaid. Then this severely underpays physicians for their services. So it's very hard to attract doctors with those statistics and recruit and retain them, for which I'm on another 9-month study to help the state understand why that is. But here we are. This is a timely way to address that big issue. When our accountants look at my finances, they say your office slot costs $80. Medicaid's paying you $40 for it. Market rate is about $120. With Medicare, you're getting about $80, which is breaking even. So it's not financially feasible to see too many of these patients. As a matter of charity, when I see a patient that has Medicaid, I'm doing about $80 of charity work for which I get no tax credit, no other credit, and it's just I have to eat that cost. So as the cost of delivering healthcare is going up, and with the recent inflation, this has become more and more and more difficult. So by fixing the fee schedule, the state can help facilitate timely, appropriate orthopedic care that is in fact overall cost saving. Orthopedic surgeons are the primary care physicians of the musculoskeletal system. If Medicaid paid a fair rate for office visits, patients could get appropriate timely appointments and even bypass the ER. We all have X-ray in our offices and can not only to X-ray and diagnose, but also provide the definitive care for these patients. Right now, patients can't get a timely appointment, so they go to the ER in hopes of getting a referral to a doctor on call. They're just using the ER as a referral service. This referral is costing the taxpayer 10 times the cost of an office visit. At minimum, an ER visit will run about $1,200. That pays 10 times for that. That'll pay basically for 10 outpatient office visits. Timely outpatient orthopedic care is cost saving and gets patients back to work quickly. Our workers' comp commissioner already has extensive data on that they can share with you. Most Medicaid patients work 2 to 3 jobs and they live paycheck to paycheck. Let's just say a patient falls and hurts their hand in New Britain. If the local doctor there can't or won't see the patient for $40, the state will pay for a $100 cab ride each way back and forth to Torrington so they can pay me $40 to see that patient to a $200 tab to the taxpayer. This is not
Doctor?
efficient use. Mhm.
Can you please summarize?
Yes. So another big, huge hurdle that we have in orthopedics is the cost of implants. Implants, surgeries done in surgery centers require implants. These run about $1,200 to $2,400, for example, for a wrist fracture. Medicaid reimburses $600 for that. It makes it inefficient to do these cases at surgery centers, which overall costs less to the system than when they're done at a hospital. A hospital, same procedure at the hospital costs the taxpayer a lot more money. So we think that there's a multi-pronged approach. And as Mark Schaefer pointed out, there are a lot of different ways that we can try to develop,
Doctor?
provide primary care. Yes,
I'm sorry, your time has,
no problem. I'm happy to answer any questions. So
and it's challenging because we're learning a lot, but we are trying to keep folks to a 3-minute time.
Agreed.
So just to bring us up to speed, so you mentioned the need to provide adequate reimbursement rates, as Section 1 of the bill does for fee-for-service providers. But there's also a question of what Medicaid does or does not cover. Is that alone enough to ensure that we're addressing in a serious way access for Medicaid patients to orthopedists?
No, definitely not. I think the fee schedule is also very, very important because I see patients all day, every day. 95% of them don't need surgery. They just need musculoskeletal care that I'm providing. So when it comes to surgery, the cost of implants is not at all reimbursed by the Medicaid system. So this is a big problem. Those surgery centers can't afford, if it's a $2,400 implant and Medicaid only pays $600 to cover the entire cost of facility, and the implant alone is $2,400, you can see why it's cost prohibitive. The hand surgeon who's trying to book the case has to now find time at a hospital that they never go to because they do all their surgeries at the surgery center. But for this one Medicaid patient, they have to go to the hospital, and getting time is very difficult. So you could have put that patient on your OR case in 2 days, get them done, get it fixed, get it taken care of. Now you have to beg the hospital for time, and they're going to give you time maybe in a week, 10 days. They'll give you a little slot of time to take care of this patient. So this patient's going to get delayed care. It's going to affect their quality of care. They may not have as good of an outcome because they're basically overall getting delayed care. And this is if they manage to make it through the ER to the doctor's office to begin with, because the fee schedule is prohibitive in that way.
Got it. Thank you. Are there questions or comments from members of the committee? Seeing none, thank you for being here this afternoon.
All right. Thank you for this opportunity.
Next up, we have Verna Little, followed by Nicole Hampton, followed by Kevin Schuler.
Great. Thank you for the opportunity to provide testimony today. I really appreciate your time in support of House Bill 6885 and Act concerning the Medicaid payment rates. My name is Verna Little. I'm a psychologist and a social worker, as well as the co-founder for Concert Health. And I submitted written testimony, but I'm also here in support of House Bill 6885 and a request an amendment. In 2022, House Bill 5001, PA 22-47 was passed to support the addition of the collaborative care model codes. The Connecticut Department of Social Services has yet to implement the collaborative care model despite the law, and during this has delayed care to children who are now going without mental health treatment. We are requesting these codes be added as an amendment to Bill 6855. This would bring Connecticut in line with 22 other states that have passed the codes onto their Medicaid fee schedules. CMS passed the collaborative care codes in 2017. Commercial payers nationally and in Connecticut are providing coverage for collaborative care, but the Medicaid program still does not. Most individuals seek behavioral health treatment first with their trusted primary care provider. More prescriptions for depression and anxiety meds are written by primary care providers than specialty mental health. And most patients who die by suicide saw their primary care provider within the month of death. Collaborative care is an evidence-based model that creates access to evidence-based behavioral health treatment alongside an individual's trusted healthcare provider. Collaborative care brings a behavioral health clinician and a psychiatric consultant onto the primary care team, assisting them with both the identification and treatment of common mental health disorders such as depression and anxiety. Collaborative care is treat to target, which means tools are used to measure symptoms, looking for a reduction of half of the symptoms within the first few months of treatment. Collaborative care is a monthly case rate, which means that it's truly patient-centered, sometimes speaking with and caring for patients on a daily basis versus just weekly. As a clinician, I've seen patients get better with collaborative care for more than 20 years. Collaborative care is not only shown to be clinically effective, it's been shown to save healthcare dollars. The monthly case rate is often the cost of one therapy visit, and most patients would receive 4 therapy visits in a month in addition to a potential psychiatric visit. Research has shown that for every dollar spent on collaborative care, there is a $6.50 return on investment. States like Texas considered collaborative care so beneficial, they zeroed down the Medicaid spend when the codes were passed for the state. Treatment for depression and anxiety has been shown to increase productivity, decrease days lost from work, improve chronic illness outcomes for diseases such as diabetes, decrease service utilization, such as readmissions. Since 10 to 14% of our primary care providers panel is affected by behavioral health conditions, the ability to have access to immediate treatment would greatly support primary care providers at a time when they are overwhelmed with patient volume and acuity.
Thank you. Oh, Ms. Little, your time has expired. If you could wrap up, that would be great.
No worry, I kindly request your support for this amendment, and I'm glad to answer any questions.
Yeah, thank you for your testimony. And I will admit I have not followed that particular provision of 5001 of last year's 5001 super closely. Have we heard from DSS about why they haven't made the funding available?
No, we have not.
Okay. Are there questions from members of the committee? Seeing none. Thanks for being with us today.
Thank you.
Next, we have Nicole Hampton, followed by Kevin Schuler.
Good afternoon, distinguished members of the Human Services Committee. My name is Nicole Hampton, and I am a registered voter in the city of Norwalk. I'm also a woman in recovery from both mental health and addiction. I've worked in the recovery field for the past 7 years, and I am a certified peer recovery specialist who is a strong advocate for my local prevention council. I am submitting testimony today in support of SB number 1205, an act concerning Medicaid reimbursement for peer recovery support services. Peer support is recognized by the Centers of Medicare and Medicaid Services as an evidence-based practice and is Medicaid reimbursable in over 41 states for certified peers, including Connecticut's bordering states of New York, Massachusetts, and Rhode Island. As a certified peer, I possess a basic familiarity with the entire range of 4 performance domains: advocacy, mentoring and education, recovery or wellness support, and ethical responsibility. My state certification is administered through the Connecticut Certification Board, and they follow specific standards of responsibility, validity, and legal defensibility to protect the population I serve. Yes, certified peers are Medicaid reimbursed in Connecticut, but only for inpatient rehab facilities and some ambulatory settings. And that's only through the 1115 waiver, which was just approved by CMS in April of 2022. Once this bill goes through, DSS would then have to go back and amend that waiver. As far as the peers in Connecticut's workforce who have their designation versus certification, they will also have the opportunity to be grandfathered into the new certification that DEMIS, Yale Perch, and the Connecticut Certification Board are currently working on. SB 1205 would create job opportunities for over 2,000 designated or certified peers looking to enter the workforce in Connecticut. Just like social workers can work for an agency or independently, peers would be afforded the same opportunity. What is more equitable and inclusive than that? I would suggest changing the language of the bill regarding the certification being administered and not handled. The credential currently being developed is the property of DEMIS and contractually administered by the Connecticut Certification Board, who are experts with over 40 years in competency-based credentialing. DPH would not be the best administration as that would make the competencies and requirements statutory to oversight. Meaning, as the role grows and develops, the only way to make changes would be to change the legislation. Whereas if the certification was administered by the CCB, then these changes would be made in real time. Also, the implementation of 15-minute increments is highly effective, being that some need less or more time than others, and you could accurately bill for the services provided. I worked almost 5 years as a certified peer in a hospital setting, in the community with and without law enforcement, as well as our local judicial branch. I've also worked as a certified peer in a pilot program for Anthem, Aetna, and Optum right here in Connecticut. When I provided 45-minute sessions, I could bill for 45 minutes instead of an hour. I applaud CCAR for starting their recovery coaches out at $24 an hour, but the reality is that we have agencies in Connecticut who start their coaches at $17 an hour. So I'm humbly asking for you to please support SB 1205 and help Connecticut take critical steps towards improving our system of care through essential mental health and addiction peer support services becoming Medicaid reimbursable. Thank you.
Thank you, Nicole, for your testimony. I know Representative Dathan has some questions for you.
Thank you very much, Mr. Chairman, and nice to see you, Nicole. I appreciate all your advocacy over the years. It's really important, and you know how much of a supporter I am of this. I'm wondering if you had an opportunity to have a look at CCAR's testimony on the bill that we're talking about today.
I actually have, and just like in our neighboring state of Massachusetts, once they made peer services reimbursable through Medicaid, their grants still exist. Like, I think CCAR will be just fine because that's a different avenue. That's they're in the hospitals providing these services. This is, just like social workers, like I mentioned earlier, this is like, you could go out independently or you could work for an agency. It depends on what that certified peer would want to do.
Yeah. Could you give the committee a little bit of explanation what a recovery community organization is? Because I think in trying to read what they're saying, I'm kind of a little bit at a loss, and you're more of an expert than I am, and just kind of curious how they fit in to help folks in recovery.
Well, it's not my expertise, the recovery community organizations. However, I'm a big fan of CCAR. I grew up in the CCAR family, and I know that their recovery centers are an intricate part of the recovery field in Connecticut. However, they're not the only place that certified peers could, flourish.
Got it. And do you have any comment on the last paragraph where they talk about that some of they feel that their roles are not respected because they're relegated to chauffeurs and gophers? I was a bit sort of taken back by that, and just wanted your opinion. Thank you.
Absolutely. And I appreciate that question, because nowadays you do see that, because this role is not regulated or administered by any certain, state agency. So I think that this becoming reimbursable through Medicaid is like a huge milestone. I mean, Connecticut is so far ahead of the curve when it comes to recovery than a lot of states. However, in this particular section of recovery, right, we're very far behind. There's already 41 other states that are doing this, including all the states around us. So yes, right now, unfortunately, there are agencies hiring peers, to be a chauffeur or gopher, right? And, they think that's the role of the peer. However, it is not. And again, that's the education that agencies need once this bill does go through.
Thank you. I mean, we all see that, having these recovery coaches, when you are kind of living and breathing in the community and working in the community, are going to prevent future hospitalizations or future trauma that a lot of folks might be experiencing as a result of their addiction. And I just wanted to say thank you again for your advocacy, and thank you for taking the time to testify in front of the committee. Thank you, Mr. Chair.
Thank you, Representative.
Absolutely.
Other comments or questions from members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Next, we have Kevin Schuler, followed by Betsy Guerra, followed by Margaret Watt.
Good afternoon, Representative Gilchrist, Senator Lesser, Senator Seminara, Representative Case, and esteemed members of the Human Services Committee. My name is Kevin Schuler. I'm a registered voter in the town of Cromwell. Most importantly, I'm a person in recovery. I've also served as a recovery coach, and today I manage a program of recovery coaches who serve in 29 hospitals, 365 days a year. This program is grant funded and operated by the nonprofit organization CCAR. Thank you for the opportunity to provide testimony on the proposed Senate Bill number 1205 and that concerning Medicaid reimbursement for peer recovery support services, which I do oppose. Although I do see the value in the expansion of the role of recovery coach in other arenas where they aren't currently being utilized, I have serious concerns around the mandate of Medicaid reimbursement. I'm also unclear on the purpose of this bill with analogous language being used in the 1115 waiver, although we have received some clarity on that today, as well as those Medicaid members who do receive support under the mental health waiver. The program I am privileged to support is one that is built and successful around our ability to mobilize rapidly and support effectively and efficiently. We receive roughly 450 to 500 referrals a month aggregately. Those individuals are met with bedside. The lived experience of a recovery coach enables a space for vulnerable conversations and connectiveness that many times may transcend that of clinical assessments. We stay connected with these individuals within the community and continue to support for as long as an individual subjectively decides is appropriate. We believe recovery is self-directed, and we are agnostic towards which specific treatment provider an individual receives the help they need from. Medicaid reimbursement would drastically impact the key areas of our program that has had a multitude of positive outcomes since its inception 6 years ago. Our coaches are viewed as detached from the greater system, and their only vested interest is in that of the people they serve. We are able to serve as advocates when care is reported to be inadequate at freestanding facilities, and are consistently working towards the building of a person's internal and external resources that will further their recovery. Our coaches' main value is their lived experience, and this bill may have unintended negative consequences that could prevent an individual the ability to be identified as a Medicaid provider. I think we heard about the challenges that people have enrolling as Medicaid providers. Programs like ours are best sustained financially through grant funding. The potential restrictive parameters imposed by Medicaid would drastically affect our ability to consistently mobilize and do the right thing by the people we serve. We provide services, support, and resources to an individual regardless of previous episodes and/or insurance types. I can give you some data on the insurance types of the people we serve. The work that we do bedside, coordination of care, advocating, supporting family members, hours and hours of phone support through the stabilization stage of recovery can never be condensed and/or quantified in 15-minute billing units. And it would create more barriers in a fight that we're clearly already losing. Please consider these points in your committee discussions. Thank you.
Thank you so much, Kevin. It's good to hear from you, and always good to see Cromwell constituent here. I know Representative Gilchrist has some questions, and I will as well.
Thank you for your service, Senator Lesser.
Thank you so much for being here
Absolutely.
and again, for using your experience to help others. I really appreciate that. To your knowledge, is there anything preventing, if we were to move in this direction, where you could braid the funding? So let's say you're meeting with someone for an hour, you could do the 15-minute increments, charge that to Medicaid, but then also wrap in other funds that would cover the full breadth of services that aren't included in the Medicaid reimbursement.
Great question. And I think it's one that there clearly is an answer to right now. And also 85% of the individuals that we see are either Medicaid or Medicare members. That other block of 15% of individuals either have commercial insurance or undocumented or uninsured. The amount of time it would take to really triage what code a person has before we actually go and serve them would really minimize our response times and our ability to just really get in front of an individual, share our lived experience, share the power of recovery, coordinate services. That's when we'll determine the insurance type for quick coordination of care. But as far as billing, it's just another barrier that may prevent us from really doing the right thing for an individual. So as far as that hypothetical, could we braid in Medicaid reimbursement with the existing grant funding? Potentially. There's also a potentiality of DEMIS or SOAR saying, hey, listen, you can now be reimbursed by Medicaid. We're no longer going to disperse this grant funding. Obviously, we want this program to be sustainable in whatever capacity. If it was an ultimatum of, okay, you're losing your grant funding, now you can get Medicaid reimbursement. then it would change the conversation. But as it exists right now, I think Medicaid reimbursement for a program like mine could be potentially catastrophic.
Thank you. And that brings up another. So do you all currently not take insurance?
We don't bill anybody for any of the services that we provide as CCAR at all. So there's a multitude of recovery support services. We have recovery coaches in the DOC justice system. We have recovery coaches in our community centers and obviously in the hospitals. And there is no billing. There's no kind of impropriety. There's no kind of ulterior motive to keep people engaged or retained in our specific treatment program. And so it really allows us to show our true motives of wanting to support a person for who they are and the potential of recovery.
Thank you. This has helped make sense of what's going on. Thank you so much.
Like Representative Gilchrist, I'm also trying to get my head around this. And one, Medicaid works in a few different ways. There are fee for service, 15-minute billable increments providers. There are also very different ways that Medicaid can pay for a program. They can have a cost-based reimbursement for a whole program, or it can provide grant funding in some cases.
Sure.
I assume you're not against Medicaid funding in general, but you have concerns about the fee-for-service model. Is that right?
Well, that's true. And sitting here, I have real concerns about the rates reimbursement for Medicaid as a whole as well. And so like that, the comment about some coaches making $17 an hour, that may not even be the case if Medicaid reimbursement were kind of mandated as a policy forward. So we do see Medicaid reimbursement in the 1115 waiver, which of course only applies to treatment centers and some ambulatory services. And those rates are already $17 an hour for a coach. If you were to mandate Medicaid reimbursement, it may be less than that. So it may actually be less. And so CCAR obviously is able to offer a living wage to the people that work for us. And we're very blessed and privileged to do so. But yeah, it could potentially be a challenge. So.
And so that that 1150, that a current 1115 waiver has a $17 an hour.
No, not necessarily, but it's a Medicaid reimbursement rate. So that's how treatment centers are getting paid, through that reimbursement rate of the 1115 waiver that allows Medicaid to reimburse for peer services. So if that applied to other arenas, other organizations may only be able to pay their, as we spoke about, recovery coaches or recovery support specialists minimum wage. And now would minimum wage recovery support specialists be better than what we're having now? Of course, I would make the argument that yes, it would. But at what effect, right? At what cost?
Okay. Is part of the problem also that I know you're concerned about losing your existing grant funding. The bill as is, there's a question about whether or not the correct agency was the certification by DEMIS versus licensure by DPH. Do you have a position on whether or not we should be leaning on DPH more? Is part of the problem that we're referencing, the DEMIS programs currently, that's sort of nodding to maybe we're going after the existing funding streams?
Yeah, I don't think it's really too germane to my position on this specific stance. I do believe that we have some phenomenal organizations conducting trainings right now for their peers. I am very familiar with the Connecticut Certification Board as a third-party body that's going to kind of be the convener of these different organizations and really be able to assess whether or not a person meets criteria and has the competencies to perform the task. I think that that's a good direction to go into. As far as pushing on DPH, I'll leave that to you all.
Maybe our public health colleagues could do that.
Yeah.
Representative Cook, and then I think Representative Davis.
Thank you, Mr. Chairman. Hi, it's great to see you, and
Good to
thank
see
you
you.
first for what you guys do. And you've always been willing to come to the table and help us navigate what you all need to provide the great services that you provide. And then the other thing I want to say before I get into my questioning is thank you for saying livable wage.
Yes.
Because I think that is so vitally important when we have a conversation about how we ensure folks can, manage on their own. A livable wage is much more
Absolutely.
important than the minimum wage
I
conversation.
agree.
So to my question, with certifications and DEMIS and as the good chairman was asking some questions, if there was an option, not that you would have to take it,
Sure.
but if we said you have the opportunity to bill this way, with that, as opposed to making a mandate, but making it an option, Would that make a difference for this conversation?
So who would be the Medicaid provider in this situation, in this bill? That's my question, because there is language surrounding Demas around being the Medicaid provider. And would we also have to enroll as Medicaid providers would probably be my pushback question. And if the answer were yes, then I know that the challenges that are that many different providers are experiencing just dealing with Medicaid as a whole. So if it was given an option as a both and, my personal opinion would be we could try, but I know I just really suspect there would be a lot of challenges that may be too much to overcome for an organization such as the one I work with.
And I know that there's been other organizations that are hesitant because they're afraid of what the process might look like. And we're always afraid of the unknown as opposed to the known, and
Right.
and the way that you all are working on things work, but we do know that there's other folks that might need
Right.
to have coverages.
Absolutely. So I'll give you an example. So it's very difficult to quantify. So part of the program that we have that's very successful is our ability to stay connected with folks through their recovery, because we know that recovery is not an event, it's a process, right? So that acute period that we meet somebody is just a very small portion of what we do. So a lot of the work is done extensively on the back end through a telephone recovery support platform or through meeting in the community. So to be able to bill for those specific instances, and as much as they occur, I have probably 700 to 800 and currently actively enrolled participants in the program. And maybe even a little bit more than that, I'd have to check. So it would be very difficult to get the adequate billing to keep us sustaining. As my previous colleague stated, the flexibility that we currently have is ideal. If that were to go away and we had to go to something else, of course, we would have to try to adapt. We still want to continue to do this work. How sustainable would it be? How effective would it be? Are we increasing the solution, or are we really just detracting from it? Or is there, I think this bill was probably created in a way and proposed that that peer support services are vital and we want to make sure that they're sustained. So let's give an opportunity for them to be sustained. And I agree with that. With the Medicaid reimbursement, the way that we're doing it is probably, I have real legitimate concerns. Maybe tabling the bill, see what happens with Medicaid rates, maybe is more appropriate, more kind of prudent stance or process moving forward, but this is my position currently.
Or the potential of possibly piloting something to see if it worked before we actually threw something out full blown. And see if people would be interested in it. I don't know if it's something that we can do. I have no idea if it's something that we can do. But I think that upsetting an apple cart, I hear what you're saying. And I think that, again, the work that you all do is so vitally important. But I also think to what you were just saying, as someone, if you have somebody that's in recovery, you don't walk in the door like you would an appendicitis and fix them and then they leave.
Right.
This is a lifelong treatment.
Right.
And some days are good and some days are bad, and you just don't know where that's at.
Definitely.
So being able to help you all not struggle for financial, and as you said, you are all, there's a lot of grant-based funding or insurance funding, depending on what it looks like. How does that give you the sustainability to continue to go forward, to not worry about what if that grant dried out?
Right.
But at the same time, how do we navigate you into the different type of wraparound treatment that you do as a sort of like a one-time and done kind of a deal?
I
understand what you're
great
saying.
question and a challenge as well. I think one of the things that gives us a lot of value is we do not come in there and propose to be clinicians or something that we're not, right? And so we don't come in there, we have to take an assessment of where a person is to fulfill our billing requirements, right? So we're really able to have those vulnerable, organic conversations. And that's what has given us so many multiple outcomes that I can cite over the past 6 years. So as a pilot, recovery has given me the ability to be open-minded. Of course, it's something that I think I would like to see or look at, but of course, I think there's other concerns and considerations as well, primarily with rate reimbursement. So yeah, that's my stance.
Thank you. I
Thank you.
appreciate your time. Thank you so much.
Thank you, Representative Dathan.
Thank you very much, Mr. Chairman, and thank you so much for your testimony and all the work that you do. This is so important. Just a quick question. You may be able to answer this and you may not. Of your $3.8 million in government grants in 2022, what percent came from Connecticut? And what percent came from the feds?
Great question. I do not have the answer to that. I do
Okay.
have the
I can ask
Yes,
Rebecca. Hopefully I
yes.
have missed her. I've been in and out of other meetings.
Yeah.
Okay.
I do know what we've received as a program on a yearly basis from Demas. I don't know if you want that. To sustain. It's a 1.7.
So yeah, so we do have about 1.1 million in service fees. I was going to ask, is that
Right.
from Demas or is that insurance reimbursements?
It's not insurance reimbursements.
Okay.
That I know.
What line item in your financials is the insurance reimbursements?
I would have to We'd have to circle back to
find
you. I'm
out
sorry,
that
I don't
later.
have. I'm not
No,
privy to
that's
that
all right.
information.
That's right. So I guess maybe going to a more philosophical question is, we talk a lot in MAPOC about, bundled services.
Right.
Or,
Yep.
sort of a value-based payment.
Mhm.
And I think as we all know here, recovery isn't something that you can say has a start and finish time.
Right.
And so when you are only getting services when someone is in crisis in a hospital and not living their sort of daily lives, would you say that that person's maybe not getting the services they need if they're not able to access one of your coaches to help them through the sort of bumps in the road that they may face?
Right. So I think there is a multitude of issues right now with access to care. I think we've heard some testimonies speaking to that. I do believe that an individual that's in an acute crisis that has the ability to be identified with in a non-judgmental way is paramount to them really having the confidence to continue to move forward in their recovery, regardless of the barrier that we might experience in that time with connection to care. So one of the main pieces of the program is, although we may not be able to connect to the appropriate level of care, we're in real time right there. There's an individual that this person's been paired with that can help them navigate the system moving forward. And hence they're medically cleared from the hospital, they're discharged from the hospital, they're working with a recovery coach to access care home. So, and the inability to even receive that would be a travesty in my mind.
Does CCAR receive any incentive-based payments for keeping their clients out of hospitals and things like that?
I have the answer to that question. The answer is no.
Okay, great. And I think just to make sure I got this right, you had said 85% of your patients are Medicaid currently?
Medicaid, a combination of Medicaid, Medicare members. I
Okay.
would probably say it's 73% straight Medicaid. So the overwhelming majority.
And is the remainder 15% insurance, or what percentage is self-paying?
So there is no self-pay because there's no pay for our services. So these are just people that we see that we're trying to connect to other services. So what gives us value of being a recovery community organization is we don't provide treatment, clinical services at all. We're helping individuals navigate the system and providing support to them. So we have their insurance types for connection to care purposes. And so the percentage of commercial care patients that we see is probably about 10%. And then that remaining 5% block would probably be uninsured or undocumented. And because a person's uninsured, they still have the right to meet with the individual with recovery. We shouldn't put conditions on recovery and how many episodes. And there's also other restrictive parameters with Medicaid, musts and can'ts. You must perform this, you can't do this. If we saw a person we've seen some people 6-7 times in a month, that's just reality. Right. And so for us to say, hey, this is the 5th time we've seen him, we can't come out and see him. Now that person's denied services and this might be the time that they finally change their lives. But because of the restrictive parameters based on billing, we can't see them. It would really disrupt what the intent was behind this program, to provide recovery to every person with dignity and respect that we are encountering.
So with your insurance paid the 10%, how do you bill those services? Is it based on just when the insured is in, like Medicaid, you only get really paid when the person's in the hospital?
Sorry
Or
if
do
I
you?
wasn't clear. We don't get paid for any services by any patients. So all our sole source of revenue is from Department of Mental Health and Addiction Services.
Oh, got it. I was confused, thinking that you got insurance reimbursement for some
Nothing,
of your services.
No,
Okay,
no. And that allows us to really operate with flexibility.
I see. Okay, thank you so much. Thank you, Mr. Chair.
Thank you, Representative. Representative Buckby.
Thank you, Mr. Chair. And I just want to reiterate, how are you?
Good to see you.
I think you too. Really happy again that you've come up here to give testimony. I think one of the critical things that we don't always hear, we hear a lot of, hey, this is a good idea. Hey, this is good legislation. Hey, we should do this. And not knowing how that can negatively impact the organizations that we're trying to help. What I would love to see is, and again, I'm not trying not to speak out of turns. I'm not a chair or ranking on this committee, but I would love to see your ability to work with our chairs in redrafting what might work best to best support what you're doing and to maintain the work that you're doing.
Absolutely.
We've said many times on the House floor, truly, this is one of the most overlooked areas that we should be doing more for as far as the legislature. And this is arguably some of the most important work that can be done across the state. So the last thing that we should be doing as a legislature is getting in your way or causing issues with good intent. I agree, the intent is fantastic for what this bill is trying to do. But I think, looking to you to help us write this properly might be in our best interest as far as the committee goes, if you guys would be interested in doing so. I guess that's my question for you. Do you have the proper solutions that you could lay out for us if this were to be able to go forward in another
We
form?
would love to have input in the process. Absolutely.
I think that's critical. We're a part-time legislature, and while many of us have wonderful careers outside of here and different things that we enjoy and different soapboxes that we stand on, and this is certainly a soapbox I'm happy to stand upon and help in any way I certainly can. I don't think there's anyone in the room that doesn't have family or friend that's been fighting in some capacity.
Absolutely.
So I think the point I'm trying to get to is that we kind of need to make sure we're out of our own way sometimes. And I think we need that guidance from the people who are day-to-day boots on the ground that know exactly what they're dealing with. And this may not be by anyone's favorite choice to work with as far as financing goes. So I truly want to mention again, I truly appreciate your organization's input and hope we hear more from you.
Thank you, Representative Buckby.
Thank you very much. Thank you, Mr. Chair.
Thank you, Representative. And since the only chair or ranking member who's not in the room is Representative Case, I think we're going to volunteer him to work with you on that. Thank you. Thank you so much. Other comments or questions from members of the committee? If not, thank you so much for being here today. Next, we have Betsy Guerra, followed by Margaret Watt, followed by Paul Kidwell. Betsy, are you with us?
Muted myself. Thank you, Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, if you're there. My name is Betsy, members of the committee. My name is Betsy Guerra. I'm the executive director of the Connecticut Council of Small Towns. We represent 118 smaller communities throughout the state. And I'm here today to lend our strong support to Section 3 of House Bill 6885, which would increase the Medicaid reimbursement rate for ambulance services. This has become a very big issue for costs. It has actually emerged as one of our top priorities this legislative session. We are very concerned that our towns are struggling to continue to fund the delivery of emergency medical care. And our towns are really facing some very difficult options. They can either cut back on other services or programs. They can increase their budgets, which triggers an increase in property taxes, which may or may not be approved by the voters. But we do feel that the one single most important thing that the legislature can do to help towns in addressing emergency medical care is to increase the Medicaid reimbursement rate as called for in Section 3. We feel that this would be an appropriate mechanism for assisting towns as well as leveraging federal dollars and making sure, again, that we can meet the public health and emergency medical care needs of our residents. We do support the recommended revisions that have been suggested by the Connecticut Association of Ambulance Providers, and we've been working with them to highlight the need for this issue. So I urge your support, and if you have any questions, I'd be happy to answer them. I think this is one of the few times I've ever been before the Human Services Committee, and certainly in listening to the testimony today, I have great appreciation for the work that you're doing and know that it's a very complex issue. So thank you for that.
Well, thank you, Betsy. You may be not super familiar with the Human Services Committee, but you know this building pretty well. So I will turn it over to any members of the committee who have questions. If not, thank you for your testimony today.
Thank you, Senator.
Next up, we have Margaret Watt, followed by Paul Kidwell.
Good afternoon, Senator Lesser, Rep. Gilchrist, and distinguished members of the committee. My name is Margaret Watt, and I'm here as the NAMI Connecticut Public Policy Chair to testify on 1205 regarding peer support services. I want to first thank you for raising this bill, and particularly thanks to Rep. Dathan, who's previously been active in this area on insurance. As you know, many behavioral health advocates have been looking to make credentialed peer support services reimbursable by both public and commercial insurance for a number of years. The question is not whether this service is valuable, effective, and cost-effective, because we know that it is. It's whether Connecticut is at last ready to join 39 other states in expanding access to it. So a couple of things I want to comment on. First, you've already heard that it's important for the language to be clearly inclusive of the mental health peers who in Connecticut are called recovery support specialists. Second, you've heard some concerns from folks who work in grant-funded organizations like CCAR, who are worried that Medicaid reimbursement would affect their service model. There's really no reason this has to be an either or situation. We need both and. In CCAR's own language, we would call that multiple pathways to recovery. We already have a behavioral health system in which treatment can be funded through private insurance, public insurance, or grants, depending on multiple factors. In Massachusetts, the grant-funded organizations, peer organizations exist side by side with insurance coverage. But in Connecticut, peer support is different. It's really almost exclusively available to individuals who are connected with a DEMAS grant-funded program. That's way less than 20% of our population. And even then, they may not receive peer support because peer support isn't available within every DEMAS-funded program. And even then, it's primarily available on the substance use side, not the mental health side. So there's an equity thing here that's related to the grant funding that I believe Medicaid insurance would really help to regulate, because it would make it accessible to anyone, on Medicaid. If you look at one of the most successful models of peer support in the state at present, it's the hospitals that have a recovery coach on call when individuals with a substance use disorder come into the ED. That service has not been around that long. It only came about when DEMAS grant funded it. The need was there beforehand. The recovery coaches existed. There just wasn't a funding model to support it. There hasn't been a similar model to provide peer support to people going to the ED in a mental health crisis, even though there are many trained recovery support specialists available. Last year, the legislature did provide funding to pilot that, to have RSSs on call for the EDs, but I'm not aware of any place that this has started at this point. But bottom line is, if it's not funded by DEMAS through a grant right now, it pretty much doesn't exist and people can't access it. From a sustainability perspective, DEMAS's funding goes up and down. I believe it was a few years ago, CCAR had a big cut in funding. So Medicaid provides some sustainability. It would expand care to more people. It would provide employment to peers. I totally understand this concern that Medicaid would do things like quantify the peer support in ways that may not feel consistent with the model. I think it's extreme to assume it would have to be 15-minute increments, because Medicaid, as Senator Lesser pointed out, has many funding mechanisms. Behavioral health is not always quantified in 15 minutes in any sphere. Rep. Dathan mentioned bundled services. It's certainly something other states have worked out. I would also state that 2 sessions ago, the General Assembly passed a law to enact a task force that would have consisted of multiple stakeholder groups, including CCAR, AU, et cetera, that would have worked out recommendations around exactly this. And it never got fully appointed, but we know the people, we know the issues, we can make this happen. So to sum up, a state plan amendment is complicated, it's arduous, but it's the right thing to do. So how much longer do we have to wait? Thank you.
Thank you for your testimony. I have a hunch that Representative Dathan has some questions for you. But can you walk us through it? I'm looking at the bill before us, which just talks about Medicaid reimbursement. So it doesn't specify the method of reimbursement, and I think we heard some concerns about the fee-for-service model, and I don't know if that's I'm just wondering if there's an alternate model that you're pushing or think that it should be specified.
No, I think that would probably have to get worked out if there was the amendment, right? But the concern about the Medicaid reimbursement rate that I heard Kevin Schuler talking about, that obviously matters tremendously, right? We want people to be paid a livable wage no matter how they're funded. But I think that the bill language doesn't say anything like, pay them on 15-minute increments or anything like that. It's just saying, let's make them reimbursable. So obviously that would have to get negotiated, what that would look like. Again, all these other states have done it.
And the other question that I have here is, and I think you've responded in part to the CCAR issues, but the question that I have is also about the pointing to the current certification by Demas. Is that the right way to go? We've had the ongoing issues about DPH licensure. Can you just walk us through your thoughts there?
That has certainly become sort of a political issue, right? I think a couple things are happening. One is that the Connecticut Certification Board has been in existence for a while, administers certification tests that have primarily been around substance use related issues and or, you know, it's like you administer a test to test for competency, et cetera. So they've been in place to do that. They do have a certification test that is an international peer certification test. It's still, my understanding is it's a little more looking at the substance use versus the mental health side of things. So I think what was happening when work was happening before the task force was enacted was the mental health and substance use peers were all looking at this and saying, is this the right test for our people, right? And so Demas is now working with CCB to look at that issue. DPH, I believe last time this issue came up before the legislature, I remember DPH writing testimony and saying they did not want to be involved in licensing peers. DPH is typically licensing people with, you know, clinical treatment type backgrounds. I don't know what their position is on this right now. I do feel like it's just a choice. I think we can make it work either way, honestly. You know, I think having a test for competency is important because there are different training programs and maybe ultimately, you know, if you pass a competency test, you can also work in other states with that, right? That's also a help for the peer.
Thank you. Questions from members of the committee? Representative Dathan.
Thank you very much, Mr. Chairman. And thank you, Margaret, for your testimony today. It's lovely seeing you and appreciate your advocacy on this topic over the years. And I hear your concerns in wanting to make sure that we cover equally addiction and substance recovery as well as mental health recovery, because the peer support play an equally important role in both. I think one of the things that I really just wanted to focus in on is access, and something that you had mentioned, and I just wanted to make sure I got it right, was the number of folks and the percentage of our state that has access to Demas related services that might be falling through the cracks here. Could you just remind us of the numbers that you discussed?
So don't hold me to like the specific number, right? My understanding is, so to be Demas eligible, you have to be, you know, like Medicaid eligible. So that's 20% of the population is the number that everyone always sort of uses as a general guideline. So that'd be 20% of the population. So it's based on income at that point. And not all of them are going to use Demas services. Not all of them are going to live near a recovery community organization, although they, you know, like CCAR, they might be using the telephone recovery service. And again, you know, even if you are in a Demas funded program, they do not all have peers. And I would say probably there's less likelihood of accessing a mental health peer, a recovery support specialist. So there's a lot of people out there who could benefit from peer support. And there are, of course, like completely valid peer support models, like having a sponsor in a 12-step program where no one's funding it at all. But just, you know, Medicaid reimbursement would expand, you know, the number of programs who could bring a peer on staff, would make it accessible to, it would employ the peers, and it would make it accessible to so many more individuals in the state. And I also think that validly, some people don't, you know, really are nervous about like, what does the treatment model do to the peer support model? And that's why we always have room for an organization like CCAR, Advocacy Unlimited. Again, both and, not either or.
Yes, I agree. Our state could always do with more support here rather than less. And I am hopeful that we get this bill over the finish line, because I do think it'll help so many people and really ensure that people have access to services. And, I do have concerns when dealing with sort of mental health and addiction services that if we get to that sort of value-based payment where it's, I hate to use the word capitation, but you have a kind of a limitation on how much is going to be per person, that not everybody is going to have the same recovery story and the same recovery timeline. And we don't want people to be shortchanged when it comes to this, and be able to access the services within their community, within their lives, so that they can thrive. Thank you so much, Margaret, and I hope we get to work getting this bill over the finish line. Thank you so much. Thank you, Mr. Chair.
Thank you, Representative. Are there questions from members of the committee? Seeing none, thank you for your testimony this afternoon. Next, we have Paul Kidwell, followed by Kim Rowe, followed by Brian McManus.
Good afternoon, Senator Lesser and members of the committee. My name is Paul Kidwell with the Connecticut Hospital Association. You heard from my colleague, Mark Schaefer, Dr. Mark Schaefer, a bit earlier today related to Medicaid payments. I would like to—
Mr. Kidwell, we want to hear from you, but there was some speculation earlier as to whether you and Mr. Schaefer flipped a coin on good cop, bad cop, but we'll ask you whether or not that happened. We're just—
Dr. Schaefer always gets to be the good cop. Appreciate that, Senator Lesser. I'm going to confine my comments to SB 1203 today, which is legislation related to hospital financial assistance policies. As you know, the SB 1203 amends the statute to extend current hospital financial assistance for uninsured individuals to those individuals who are underinsured, which is defined by the bill as any person liable for one or more hospital charges that exceed 2% annual household income after insurance. The bill limits what hospitals are permitted to collect from such underinsured patients. Our objections to this provision of the bill include the following. One, nearly all Connecticut hospitals go well beyond statutory obligations by extending their current financial assistance policies to those who are underinsured. Those policies, however, are based directly on federal poverty level thresholds, in all cases extending discounts to individuals and households at 400% of federal poverty, and in some cases higher. In contrast, this bill requires the extension of those policies for any insured individual, regardless of income. By requiring hospitals to subsidize the cost of care in this way, the bill is undermining the basic expectation of health insurance products that are the foundation for individual and employer-sponsored coverage. Moreover, it encourages the sale of flawed insurance plans that don't cover basic medical need and that promote medical debt. If insurance products are routinely offered by health carriers that, by design, include annual deductible and out-of-pocket maximums that exceed 2% of household income, then the products themselves should be adjusted to fall within the parameters proposed in this legislation. An attempt to shift those financial obligations to another party, in this case hospitals, will undermine the health insurance market and actuarial principles on which those products are supported. If the bill's focus is on the burden of medical debt, we should consider the combined costs across multiple services such as pharmacy, physician services, home care, ambulance, and ambulatory surgery. The proposed bill's focus on hospital liability is overly narrow. You have our insurance. We will continue to focus on making our financial assistance programs as easy to access and navigate as possible, raise awareness about these programs with our patients, and ensure that our staff remain well prepared and trained to articulate these policies to our patients. We're open to additional conversations about how to make these policies more accessible to patients. Beyond the financial assistance provisions in this bill, we also have concerns with sections 6 and 7. Section 6 would prevent 340B covered entity from attempting to collect payment for medical debt associated with the 340B acquired drug that was billed to the individual for more than its acquisition cost. The section fundamentally misunderstands how the 340B program operates. The purpose of the program is for covered entities, in this case hospitals, to use the program broadly to reach more eligible patients and offer more comprehensive services.
Mr. Kidwell, your time has expired.
Oh.
I'm going to ask you to,
Sure.
because I'm actually really interested in this. Can you just detail your concerns with section 6 and section 7.
Sure. 7. So 340B is not a patient level discount. And that's how it would be applied under section 6. Section 7, our concern is related to presumed state enforcement of the federal transparency regulation. I think the as currently constructed, the legislation doesn't specify what entity would be required to judge compliance. And there are already tremendous penalties up to $2 million for non-compliance with the transparency regulations. And happy to answer certainly Senator and any member of the committee questions related to that provision.
Let's start with that, actually. That
Sure.
would be hugely helpful. So there has been some reporting that Connecticut hospitals are generally not in compliance with the hospital transparency reporting requirements. Is that wrong, or?
There's been reporting from outside organizations. There's been certainly no estimation or reporting from the Center for Medicare and Medicaid Services, the federal government agency that is tasked with actually certifying compliance.
Okay, but what is CHA? Is CHA going to represent that Connecticut hospitals are in compliance with federal hospital transparency rules?
Our members certainly are. We have not audited all members for compliance, but based on the CMS standard, we know that our hospitals certainly seek to be in compliance and are taking efforts to be in compliance, including offering cost estimator tools. All of our hospitals offer those tools to ensure people can go onto the website and determine what their costs may be.
And you're right, Section 7 does not have an enforcer in it. Is there one that you think we should consider?
We think that the Center for Medicare and Medicaid Services, because they're the regulatory body which promulgated the regulations and is the appropriate entity to actually certify compliance. And we don't think the program, the section is frankly necessary. There are compliance penalties for being out of compliance.
Okay. My sense is that, and I'm just relying on the third party here because you haven't done an audit and I haven't done an audit, is that generally Connecticut hospitals are not in compliance. In fact, I saw a report that suggested that no Connecticut hospital was in compliance. Obviously, if that's not the case, that would be, important information for us to consider. But, trying to figure out how are we going to get information about hospital prices out to consumers, and I think that's directly tied to this issue of medical debt. If you go to a hospital and you don't know what the prices are, it's hard to be mad at the patient for going into debt as a result.
So, Senator, if I could just respond. So what's required by the federal law is, one, that the hospital charge master be posted on the hospital's website in a machine readable form. I think some of the third party organizations that have tested compliance find some pretty esoteric issues with compliance. That said, the other important consumer related provision of the transparency law is to provide information related to shoppable services. So those things that a consumer may be able to shop for from hospital to hospital. CMS allows a hospital to use a price estimator tool to comply with that provision. And our hospitals have those estimator tools on their website, which allow you to, one, put your insurance information in, or two, look for those estimates without any insurance coverage.
So what explains the vastly different policies that your members have with respect to financial assistance and pursuing medical debt? I think one hospital in the state, I saw the last time it's been a couple of years since I looked at it closely, but I think one hospital in the state, and I'm not going to single them out, but I think they're located in the city of Danbury, was responsible for was responsible for like an overwhelming percentage of foreclosures, for example, collecting on medical debt.
Yeah.
And I didn't know if there's a reason for the discrepancy. Obviously, there's different payment mix, there's different local environments, but it doesn't seem like hospital policies really track with that in any way that's easy for us to follow.
Yeah, I think that one, I don't think that hospital financial assistance policies are that vastly different. I think Connecticut has, based on the legislative activity, strong protections for individuals in financial assistance policies. And as my testimony showed, most of our hospitals extend financial assistance above 400% of poverty. I think we're always looking for ways to make sure patients are aware of those policies and have assistance to apply for them. Can't speak to any one hospital or system related to that work, but that's something that we strive for universally.
Okay, I may have more questions. That's all I have for the moment. We'll love to see if there are any members who have questions.
Appreciate your questions.
Does not look like there are, though.
It looks like maybe Representative.
Oh,
Johnson has
Representative
their hand up.
Johnson
I'm
has
sorry.
questions. Hello, Representative Johnson.
And I think the representative's on mute. Representative Johnson, I think you're on mute.
Representative Johnson.
I found it. Sorry. Thank you so much for your testimony. And I just, this is a question that's bothered me for some time. And this is kind of on topic with the fact that back in the day, we had something called Hill-Burton. Are you familiar with the Hill-Burton program?
I am not, ma'am.
Okay. So back in the day, we had money that was allocated to hospitals through the federal government, and they would be used for whatever repairs a hospital needed, whatever building structures were needed. And the hospital would take these, and based on that money that they received, what would happen is they would be required to provide so much free care. And that way there would be an exchange, and the debt for the hospital and the uncompensated care funds would be lower, and the lawsuits would be limited. That was ended near the end around 2000 or 1998, somewhere in there. And now I see where we're having a real problem. And I'm wondering if the state were to create its own state type Hill-Burton program. Would this help the hospitals, instead of like just handing money over to the hospitals, have the hospitals be able to do whatever repairs they need, do these kinds of things? And this is a question for maybe a bill that we could maybe do later on. But I have a lot of information on that. And I'm just asking you if you think that that would be one way to address the problems that you're having with people who don't have the right kind of insurance. So they're an unregulated plan, for example. They have high deductibles and they can't possibly meet these costs because of the unregulated insurance plans. And then also people who are uninsured altogether. So I just wondered if that is something, if you want to go back and look and get back to me on an answer with that, I would appreciate it because I have a whole analysis that I've done, and I can provide you with that as well, and to the committee. But I think it's something that we need to start thinking about.
Thanks, Representative. We're happy to review that information and happy to do some additional research and have a conversation with you related.
Okay, great. Thank you so much. Thank you, Mr. Chair.
Thank you, Representative. Other questions or comments from members of the committee? If not, thank you for playing the role of bad cop and being with us this afternoon.
Thank you, Senator.
Next up, we have Kim Aro, followed by Brian McManus.
Good afternoon, Senator Lesser and Representative Gilchrist, Cook, and distinguished members of the Human Service Committee. My name is Kim Aro. I am the president of both Aetna Ambulance and Ambulance Service of Manchester. I am also the treasurer of the Association of Connecticut Ambulance Providers and the president of North Central EMS. I'm here today to testify in strong support of HB 6885 and precisely support the language raising emergency medical service rates to equal Medicare. We would encourage the committee to increase the rates to 100% over the next 2 years. The aftermath of COVID-19 and the continuing inflation have stressed emergency services throughout our state. The providers' expenditures have increased significantly while our staff members have declined and Medicaid reimbursements have remained flat. As it stands, our current rates significantly underfund the cost of care. A perfect example of that is when we respond to cardiac arrests, which is almost a daily occurrence between our two companies. The supplies on these types of calls range from $250 to $450 per call. That includes the cost for the IO needles, the cardiac monitor pads, and significant amounts of other medications administered. On top of that, as our two companies always send a second ambulance staffed with two employees, usually an EMT and another paramedic. And sometimes we have a third truck with another paramedic. due to these calls being so challenging. So combine the cost of the two trucks, staffed with 4 people, sometimes the third truck, plus the supplies, the reimbursement that we get from Medicaid is $349. As you can tell, that barely, covers the cost of the supplies it's alone. Unfortunately, we're not able to itemize the medical supplies like hospitals can. So, nevertheless, our frontline responders continue to show up and provide critically important services to Connecticut residents. Many calls that require responses do not allow us to receive reimbursement. Examples of those are patients that refuse care upon arrival, or if we provide a second vehicle for a complicated call like I just described, or a bariatric patient, or patients that just don't have insurance. In some towns, these no-pay responses are about 10 to 30% of our total call volume. So recognizing the high cost of providing 24-hour emergency coverage for these situations is very imperative. As EMS organizations, we have required staffing levels dependent on our service and the need of call volume to support the staffing costs ready for emergency responses. This is a losing proposition when 25 to 30% of our responses are for Medicaid patients, and we are only getting paid 63% of Medicare rates. Our rate structure is very straightforward. We only have 7 billing codes, and that is including 1 for mileage. I'm happy to share a spreadsheet that summarizes the current DSS rates and the comparison to Medicare if you would like. Lastly, I just want to personally say thank you to all EMS providers for the outstanding response that they did during the pandemic. They worked tirelessly during a very scary time in our life, and hopefully we never have it repeated. However, right now, our providers are seriously struggling, and we need your help. We want to be able to continue to provide the excellent level of
Ms.
care.
Arrow, could you please summarize them?
Yep, last sentence. We want to continue to be able to provide the level of care that we are to the towns we serve. And unfortunately, we do not feel we have the time to wait for a study to be completed. We urge you to support all emergency services and increase Medicaid rates for EMS providers and bring them in line with Medicare. Thank you so much for your time today.
Thank you for your testimony today. Are there questions or comments from members of the committee? Seeing none, thank you for your testimony.
Thank you.
Next, Brian McManus, followed by Dr. Witold Wyberski.
Good afternoon. And first, I'd like to thank the chairs, the members of the committee. My name is Brian McManus. I am a resident of Fairfield and a registered voter. Most importantly, sitting here today, I am a person in long-term recovery. For me, that means I have not had a drink or a substance since November 19th, 2010. I also serve as the program manager for the Connecticut Community for Addiction Recovery's Department of Corrections Recovery Coaching Program, our DMIS Jail Diversion Recovery Coaching Program, and I also oversee a program that we do with the City of Manchester with their police department and their emergency services. You have heard, as you can probably assume from the testimony of my colleagues, I am here in opposition to SB 1205. And I won't get into all the discussions that no need to beat a dead horse at this point. But I wanted to talk about some realistic concerns and some historic concerns that have followed peers in the treatment system over the years. During the 60s and 70s, we saw a trend from informal addiction treatment to more formalized addiction treatment. Basically, much of that came because of the coverage of insurance companies, the inclusion of addiction treatment in medical coverage. And what we saw was a real growing importance on the process of treatment, the documentation, the billing, things of that nature, and a step away from the goal-oriented the service goal-oriented focus of treatment on recovery. And I think we're at a critical point in the use, and I'm speaking in terms of recovery coaches. We're at a critical point in the development of the profession of recovery coaches. Where was that 3 minutes already?
It was. Yeah.
I will summarize completely. I apologize. I will summarize quickly. I'm concerned about the over requirements of documentation. I have a concern about the professionalization, forcing credentialing upon peers, looking to educational requirements versus lived experience requirements. And I know many people who make excellent recovery coaches who may not meet educational requirements. So we're at a very difficult point. We're at a very interesting point in the development of the profession of recovery coaching, where implementation of Medicare funding can limit the use of coaches in the community, where limit the use, and we meet people out in the community. We meet people where they are. And sometimes that's very difficult to quantify in billing codes, billing statements. So
We've given you a fair amount.
I know, I do.
latitude,
I
but,
apologize.
okay. Just to thank you for your testimony and for your work. Just a question: do you feel that the recovery coach capacity in Connecticut currently meets the demand?
That's a great question. I believe there are enough people trained as recovery coaches. There are many people who are quote unquote hired as recovery coaches who are not fulfilling the true role of recovery coaching. They're not being used for their lived experience. And I have concerns over the over clinicalizing, if that's a word, of the peer role.
So I got the last part. That is important, but obviously we are still in the middle of an epidemic. We have an enormous amount of need out there.
Absolutely.
And but you think that I understand that you're worried about over clinicalization. I'm using your word.
Yeah. Not sure if it is a word.
Yeah, no, it is today. And I understand all of that and some of the other concerns you have and some of the other folks who are not being used appropriately. But do you believe that everybody who is in recovery who wants a recovery coach has access to one? And if not, how do we get there?
I can speak as to our organization. We do provide recovery coaching services, volunteer recovery coaches in our 5 recovery community centers across the state. They're strategically located, covering the eastern, central, western parts of the state. People can come to our centers to receive free recovery coaching services if they want to. I know through our programs in the hospitals, Department of Corrections, and through the court system, that there are recovery coaches that are available to serve the community.
But you know, you get a grant and the grant is to provide a certain amount of services. Is that sufficient?
There's never enough money right now as you said, we're in the middle of an epidemic. I'm not sure if we can quantify a number which would provide significant enough support statewide.
But I guess what I'm trying to get my head around is, are you providing free services, supports to folks? Are you turning people away? Are you able to provide care to everybody who comes in the door?
We don't turn people away. We will work with people, as many people as will come to us. It goes to the nature of our staffing and the recovery coaches that work with us.
Oh, okay. No, I appreciate that. I'm just trying to get my head around, because normally when we're in funding conversations, we do a lot of those. We hear folks from saying, oh, we have resource constraints, we can't meet the need. And I'm hearing you saying the opposite. Oh, we are meeting the need. Obviously, we'd like more money, but we can meet the need.
Well, you know, we are doing everything we can. We are meeting the need that comes to us, but there are pockets across the state where there are not significant resources. There is a great need for resources. And I believe your question was, are we turning people away? We're not, but I'm not sure we're reaching everyone who is in need of our services.
Certainly, like one recovery coach cannot coach 1,000 people, right? There's no way you could do that. So there's a limit to how much any one person can do.
Exactly.
Okay. Can you quantify that for us? How many people does one of your coaches
currently? I can speak to our Department of Corrections program. Our coaches coach anywhere from probably 30 to 40 individuals at any given time.
Okay. Thank you for that. Any Representative Gilchrist?
Thank you so much for your testimony and for, like I've said to others, using your experience to help others. What is the fear, or if the state were to move forward in this direction and have Medicaid cover recovery coaches, could your organization, based on the model you have of not charging, which I am understanding now, could you just not accept the Medicaid? Well, what's the fear there? Like, how would this change your model? Couldn't you just not get the Medicaid?
The restrictions.
Okay.
We've all have sat in a doctor's office that, oh, it's not covered by insurance or a billing code. I have a coach tomorrow morning who is picking up a woman in New London who recently got out of DOC custody, driving her to Hartford so she can be inducted into her methadone program. During that time, the coach will use that transportation time for conversation, to engage, to develop a relationship with that individual. So how do you build that? How do you quantify that? And those are the difficulties I foresee.
But I guess my follow-up though is, so don't do it. You don't accept the Medicaid. How's that going to impact your model?
Again, it will go to, will we receive the grant funding?
Okay.
And what will that do to grant funding? What will it do to recovery coaching overall? Not just my program, but the profession of recovery coaching. Will a coach be limited by those parameters which are set out by Medicaid for their services? You know, it may not be 15-minute increments, but it may be you can only see someone, you know, once in the course of 10 days. And that just goes against the nature of recovery coaching, because our role is to be there, to meet the individual in the community, to really support support them in those moments of crisis. So how can you quantify that? How can you say, oh, I met you yesterday, I can't talk to you today? And that's what it really goes to, the concern I have about being tied to Medicaid funding, not only for our organization, but for recovery coaching in general.
Thank you. Thank you very much. Thank you, Mr. Chair.
Thank you, Representative. Other comments or questions from the committee? Seeing none, thank you for your testimony.
Thank you very much.
Next, we have Dr. Witold Wyberski, followed by Sheldon Taupin.
Yes, hello. I just want to make sure my speaker works. My microphone works. Okay.
We can hear you loud and clear, sir.
Okay, thank you. Honorable co-chairs of the Human Services Committee, Senator Lesser, Representative Gilchrist, vice chairs, and distinguished ranking members. I am proud to speak to you today in support of HB 6885, which is an act concerning Medicaid payment rates. My name is Witold Wyberski, and I am an anesthesiologist and chairman of anesthesiology for Hartford Hospital. I am a Hartford resident, and I am employed by Integrated Anesthesia Associates. Integrated Anesthesia Associates is the largest provider of anesthesia services in Connecticut, and we have been a proud provider of quality and affordable healthcare services for patients across the state for many years. We currently provide services in a number of underserved communities, including Hartford, Bridgeport, New Britain, Meriden, and Derby, and for several of the largest hospitals, including Hartford Hospital, UConn Health, Hospital of Central Connecticut, St. Vincent's Medical Center in Bridgeport, Mid-State Medical Center in Meriden, and Griffin Hospital in Derby. Anesthesiologists provide a critical service to the healthcare system, ensuring that patients are safe and comfortable during surgical procedures. However, the cost of providing anesthesia services can be high, as it requires specialized training and equipment. The cost of anesthesia drugs, medical supplies, and especially personnel can also be significant. The Medicaid reimbursement rate for anesthesia services is often lower than the cost of providing the service, which means that anesthesiologists may lose money on every Medicaid patient they treat. This can make it difficult for anesthesiologists to provide care to Medicaid patients, especially in areas where Medicaid is the primary source of insurance coverage. Because Medicaid is funded by the government, reimbursement rates for medical services are set by the government. Furthermore, because Medicaid reimbursement rates are often lower than those of private insurers, anesthesiologists may have to charge higher rates to private insurers in order to cover their costs. This can lead to a situation where private insurers end up subsidizing the cost of Medicaid patients, which is seen as unfair by many in the healthcare industry. Overall, the Medicaid reimbursement rate for anesthesiologists is seen as unfair by many in healthcare, in the healthcare industry, because it does not adequately cover the cost of providing the service, which can make it difficult for anesthesiologists to provide care to these patients and can lead to higher costs for private insurers. Anesthesiologists at Integrated Anesthesia Associates and at anesthesia practices in Connecticut work in collaboration with healthcare systems to provide care to patient communities, irrespective of insurance status or ability to pay for healthcare services. Our providers play a critical role in addressing global healthcare challenges, such as improving access to care in underserved areas, addressing healthcare disparities, and responding to pandemics and other public emergencies. In spite of the commitment from our personal and professional community to provide equitable access to anesthesia care in Connecticut, progressive and consistent underfunding of Connecticut Medicaid has been associated with cost shifting to hospitals in order to maintain sufficient anesthesia staffing to provide these needed healthcare services. Hospitals in Connecticut are already financially strained, and in addition, there have been national shortages in the supply of anesthesia providers.
Doctor?
In summary, the combination of these staffing shortages and state-level reimbursement structures that do not meet the cost to provide care creates tremendous challenges in our statewide ability to promote equity and timely access to quality health care for vulnerable patient communities. I am asking that you please support this bill, and I thank you for the excess time and opportunity to submit this testimony.
Thank you, Doctor. And compared to some of the folks today, you didn't use that much excess time. So, thank you for your testimony and the information as well. Certainly appreciate it. Are there questions or comments from members of the committee? Seeing none, thank you. And really appreciate you being before us this afternoon.
Thank you very much.
Next up, we have Sheldon Taubman. After Mr. Taubman, we have Dr.
Good afternoon, Senator Lesser, Representative Gilchrist, other members of the Human Services Committee. My name is Sheldon Taubman. I'm the litigation director, litigation attorney at Disability Rights Connecticut. I'm here to testify about the impact of 3 bills on people with disabilities. You have my written testimony. I'll just touch on a couple of them and then talk mostly about the third. SB 1173 would involve a study of DSS's needs and the gaps. This is so urgently needed for people with disabilities and others. As you know, the offices and the call centers are closed on Wednesdays, and in addition, on other days, can you hear me? I'm just wasn't sure. I can't hear you. I can't hear you, and I'm guessing you can't hear me.
Can you hear me now?
Now I can hear you.
Excellent. We could hear you throughout though. So
okay.
and don't worry, you didn't lose your 3 minutes.
Okay, thank you. The DSS offices and the call centers close on Wednesdays, and it often closes early on various days, and that's it, other besides Wednesday. And there just is not enough staff. The commissioners acknowledge that. I think everybody's acknowledged that. But the thing I want to emphasize is that this is a long-term problem. This has been going on for forever since the whole system was created. It was never adequately staffed. So there really has to be that kind of a study. And I would urge that the legislation make clear they have to study whether the staff is adequate, not just the allocation of staff. SB 1205, there's already been a lot of testimony on that. People with disabilities, with mental health disabilities, will significantly benefit if there's greater access to peer support, and it does appear that a state plan amendment would make that possible. Mostly, I want to talk about HB 6885, and this is about the provider rates. And everybody knows, you heard today, it's 57.5% of Medicare as of 2007. I don't think anybody could legitimately defend that or suggest that that's producing adequate coverage under the Medicaid program. But it's also been noted that some things in Medicare are not covered. There's no analogy in Medicare. So if we're looking at Medicaid rates, what do we do? And the area specifically in my written testimony, and I've testified before about it, is ASD, Autism Services. Last year, I testified, I think twice, before Representative Gilchrist on the same thing, the same boring testimony. We need to raise the rates for ASD services. And the result of that was there was a 5001 last year that was supposed to be this big report that's going to, by January 1st, tell us a comparison between Medicaid rates and commercial rates. And then OHS said, no, we can't really do it. We're going to have a contractor. Maybe we'll get it done by July 1st. And now the commissioner is saying, we should do a study. Give us a chance to do a study. Well, we already ordered that last year and it didn't happen in time. And some of these things we know have to be addressed. In my testimony and from others, you heard that we are paying $12.17 for 15 minutes for the techs for ASD services. Massachusetts is $16.37, Rhode Island $16. We can just raise that now at least to the $16. And for the BCBAs, we could raise it to Rhode Island's $28 versus Massachusetts $30.73. But I think a bigger question, apart from my written testimony, is maybe we need a hybrid approach here. Maybe we need to do the study and really make it happen this time, put the resources into doing it. But we also need a down payment. We need to address rates today. So I'd urge you to think about doing that as a solution, both today and looking for the long term. Thank you very much. Happy to answer any questions.
Yeah, thank you, and want to ask you about that last suggestion because we've been sort of mulling over this question. There's certainly things that we can do now. And the question is, how do we, is there something more that we can do other than ask DSS to conduct a study that shows some level of seriousness? If we were to park funding in the budget for rate increases, have the study, but required DSS to come up with a plan to spend it and then come back to this committee appropriations for approval. Does that give you some comfort? What would be helpful to sort of because, we heard earlier from Mr. Wolston that, this is a little bit of a zero-sum game. So if we fund one area, we might inadvertently be leaving another behind.
Yeah, I heard Mr. Wilson's testimony, and I want to say, by the way, that I think we're very fortunate to have him join the team because I think he's a very thoughtful person. The zero-sum game, of course, is assuming the governor's budget partly, and that's why we have a separate branch. But I do recognize the importance of doing the thorough kind of study he's talking about. One approach is you raise the rates now. We're at 57.5% of 2007. I'm sure none of the doctors in this hearing would suggest, oh yeah, that's okay. We'll take that. I mean, of course, it's the reason why there's such a serious access problem we're hearing all the time. So one approach would be to just come up with a figure now. So in terms of where there's a Medicare analogy, just go up to a figure. I don't know what it is, but perhaps it's 70%, 75% now. That's the down payment while the study goes on. You do have the issue of like the ASD services where there isn't the analog. In the ASD, it's well documented. We have all the rates. You can just do it right now. Take whatever Massachusetts and Rhode Island are doing. I would suggest that would be the right answer. If you're only going up to 70 or 75, I don't think you have to worry that you're overpaying somebody. We're not. That's not a danger. That would be a great down payment, and then yes, have them come back with the study. I am worried about delays. I mean, what happened last time was that 5001 was supposed to be, as originally written, was going to be a study by DSS and the Department of Insurance, which made sense because it was a comparison of Medicaid rates with private rates. But OHS came in and, well, frankly, demanded that they be in control of it, and then they said, "Oh, actually, we can't do it in a timely way." So I would probably feel a lot better if it were under the control of DSS with Mr. Wolston, and if as long as there's some tight reins on when it's actually done and it's adequately resourced, I think that would be fine when added to a down payment.
And with regard to parking unprogrammed funding in the budget, was that I don't know, is that a good idea or a bad idea?
I don't really, in all honesty, I don't understand that well enough to state that. I just don't know how that works.
Well, if we were to say, that's right, we're going to be passing a 2-year budget this year. We could put in funding in next year's budget, an unspecified Medicaid rate increase, require DSS to study where the greatest needs are and come up with recommendations, and then we would approve it. And then that's, but rather than, the question is, we want to we know that Medicaid is underfunded, right? We know that that's a consensus. The question is, how do we best program the funding? And so, I'm looking for guidance for us to go and make our ask of appropriations in the way that makes the most sense. Recognizing that, that there is a certain amount of analysis, particularly for more complicated funding places like ASD.
What you're saying, as I understand what you're suggesting, is there'd be a fixed amount that we set aside. This is how much we're going to go up total. And then you do the study to allocate how to do that.
And then we would have to sign off on the allocation.
Right.
But
I mean,
let's say we've decided, we heard earlier from the Hospital Association that we need $2.5 billion put into the Medicaid program. Let's say we get an amount, maybe a tad less than that, but some amount of funding, but we don't know yet exactly how to allocate it, since the need is inherently going to be bigger than the demand.
Yeah, I mean, I think that's
bigger than our ability to pay.
That's reasonable, except of course, what if it's really not enough? And then you are limited too small a pie, and if we're going to create the problem again. So I suppose one approach is, you do park the money there, but everybody has to understand that may be inadequate, and it may need an adjustment in the second year.
Okay. Thank you. Question, Representative Hughes has a question.
Thank you, Mr. Chair. Thank you, Sheldon. Since you sit on MAPOC as well, the Oversight Committee, would you suggest that what did you call it, undesignated budget allocation towards Medicaid reimbursement rates, say 75%, go through MAPOC to be approved, and then the study analysis from DSS come through that or to the general legislature?
Well, you all decide how you do your business, but anything that involves appropriations obviously is for the Appropriations Committee. It could go through MAPOC, but the timing is you'd want people to review it. What I was suggesting is that that you all on this committee, as well as the probes, can determine what is an obvious minimum increase we'd want to see for all providers where there's the Medicare analog, and just do that. I don't think it's unlikely people on MAPOC would disagree with that, because I think they'd say, well, it's inadequate, but at least we could get it started.
Well, I was thinking because we do meet throughout the year and then we would have that oversight.
Oh, I see, for later. But I was talking about what I'm suggesting is a down payment. If you do that now. You agree to-
No, the down payment now, but also since we're expecting the results of the analysis in July, that continue on in an active way, in real time, I suppose.
Yes. Yeah. No, I see what you're saying. Yes, I agree completely. You'd want to have MAPOC have oversight of that and have input on it. Sure.
Okay, thank you.
Thank you.
Thank you, Representative. Other questions from members of the committee? Seeing none, thank you for being here this afternoon.
Okay. Thank you very much.
Next up, we have Dr. Ken Stone, followed by Dr. Adam Sachs, followed by Dr. Kristen Winters, followed by Dr. Daniel Fries. We've got a lot of doctors here today.
Thank you. Senator Lesser, Representative Gilchrist, Vice Chairs and Ranking Members. My name is Kenneth Stone. I'm an anesthesiologist and a member of the Connecticut State Society of Anesthesiologists. Let me also say, having listened to most of this committee hearing today, I have a new respect and appreciation for the work of our elected representatives. It's quite a job that you do. I'm speaking in support of the legislation. I submitted written testimony. There's also a slide there if you can refer to it. On behalf of my fellow anesthesiologists and professional colleagues in other specialties, we appreciate the attention to this issue and the committee's proposal to address the disparities in Medicaid payments. I want to make the committee aware that anesthesiology is uniquely undercompensated by Medicare in a manner that is disproportionate to all other medical specialties. In 2007, the United States Government Accountability Office GAO report to this Ways and Means Committee of the House of Representatives examined Medicare payment rates. The reason for the study was concern that lower payment for anesthesia services could result in limited access to care. The study showed that anesthesia was paid at a rate of 33% of commercial. It also showed that in Medicare locations where there are concentrated Medicare beneficiaries, there was a decreased supply of anesthesiologists. That report was repeated in 2020, and the rate of anesthesia payment had now gone down to 28% of commercial rather than 33%. That same report also showed that Medicare payments to all other physicians were 74% of commercial compared to 28% for anesthesia. The graph that I sent you is an illustration of that point. The result of this analysis is that bringing the Medicaid payment rate in Connecticut to 100% of Medicare would still result in payments of 28% of commercial to anesthesia services compared to 74% for the aggregate of all physicians. However, this would certainly be an improvement over the current circumstance in which current Medicaid anesthesia rates in Connecticut are 20% of commercial. The disproportionate payment has several adverse consequences. Medicaid payments do not cover the cost of providing services, nor for that matter do Medicare in our specialty. Anesthesia practices rely on compensatory higher private payer and supplemental payments from hospitals. The disparity creates negative incentives for recruitment, and there's a real concern for access to care in communities most reliant on Medicaid. This is analogous to the comment in the GAO report showing access to care for Medicare beneficiaries. It's not in my testimony, but let me just raise this point. A lot has been discussed today about access to care. We're a hospital-based specialty. We don't bring in patients. You heard, for example, from an orthopedic surgeon and others who said they can't accept new Medicaid patients. We can't turn people away, but the underpayment of Medicaid services to anesthesia is well known within the medical community and within the specialty. It makes it harder to recruit, and it also makes it harder to pay people compensatory rates and secondarily results in underserving in those hospitals that serve these communities. I'm almost done. A great majority of anesthesiologists and anesthesia practices have coverage contracts that provide care to all patients. We do not select our patients, and we willingly provide care to all comers. As the committee considers this bill, I ask the unique circumstance of our specialty be considered and an effort be made to address the disparity that I outlined in this statement. Thank you very much.
Thank you, Doctor, and appreciate the unique information, unique circumstance of anesthesiology. Are there questions? Yeah, Representative Cohen.
Hello, thank you, Dr. Stone. Are there, when right now we're considering, we have to have, in my family, we have to have an anesthesiologist for my son who's going to be getting out his wisdom teeth, and that was the one coverage, the one cost that was not covered, and we're here on the state private insurance. So I'm wondering if it's like this in other areas outside of Medicare, Medicaid.
You bring up an interesting question. There's dental anesthesia in this state is separated from all other anesthesia care. I'm not an expert on this, but my understanding is that I, as a general anesthesiologist, cannot provide dental anesthesia in the dentist's office. I think that's the case. Some of you may know better than me. If someone needs a surgical procedure that requires anesthesia, anesthesia would always be covered. There are questions as to the reimbursement rates, but I think the example you give is in the dental sphere, which is different than the rest of medicine, especially in this state.
Okay, I'll keep asking around. Thanks.
Thank you, Representative. Other questions or comments from members of the committee? Seeing none, thank you for your testimony.
Thank you.
Next, we have Dr. Adam Sachs, followed by Dr. Kristen Winters. Dr. Sachs, are you with us?
Can you see and hear me?
I can hear you, but not. Now we can hear you. Yep.
Huh.
We cannot see you, but in the interest of time, I think we'll survive.
Okay, hold on. There we go.
Now
There
we
I
can
am.
see and hear you.
Thank you.
Incredible.
Amazing. Thank you. I appreciate it. Honorable co-chairs of the Human Services Committee, Senator Lesser, Representative Gilchrist, vice chairs, and ranking members. I am here today in support of SB 6885, an act concerning Medicaid payment rates. My name is Adam Sachs, and I am the Director of Obstetric Anesthesia at Hartford Hospital, an Associate Professor of Clinical Anesthesiology at UConn Medical Center, Secretary of the Connecticut State Society of Anesthesiologists, and an Executive Board Member at Integrated Anesthesia Associates. According to states reporting Medicaid reimbursement rates, Connecticut has not received a physician reimbursement increase since 2012. During this time period, 45 of the 50 states have seen an increase, highlighting Connecticut's underperformance nationally. This lack of funding leads to healthcare disparity, racial inequality, and racial injustice. Low reimbursement rates limit access to quality care and contribute to poor health outcomes for Medicaid beneficiaries, which, according to Connecticut's Department of Social Services report, are disproportionately racial minorities. Medicaid beneficiaries, often referred to as Connecticut's most vulnerable population, deserve the same level of quality care as everyone else in the state. Low Medicaid reimbursement rates put a strain on hospital systems and physicians who want to provide high quality care to these individuals, but are unable to do so because of financial constraints. This contributes to physician burnout, in addition to a decreased number and quality of physicians who relocate to other states who do not place the financial burden of caring for Medicaid patients on practitioners. This is especially true for anesthesiologists, who are responsible for maintaining the safety of patients during the perioperative period, providing acute and chronic pain management services, and taking care of critically ill patients in the ICU. Increasing Medicaid reimbursement rates for anesthesiologists will inevitably contribute to decreasing the opioid epidemic, increasing surgical safety, decreasing perioperative pain, and increasing the availability of care to critically ill patients, mothers delivering babies, and children who require life-saving procedures. SB 6885 appropriately addresses the low Medicaid rates, increases healthcare equity, and decreases racial disparity. Thank you for the opportunity to submit this testimony. I'm asking that you please support this bill. Thank you, everybody.
Thank you, Doctor. And your testimony was right in our 3-minute timeline, so particularly appreciate that. Representative Representative Cohen.
Thank you. Thank you, Dr. Sachs. You mentioned briefly the workforce issue. What is the status of your workforce for anesthesiologists?
I think nationally and in Connecticut, there is a shortage of anesthesia providers, unfortunately. And I think part of that is, related to our poor reimbursement for Medicaid. So, if we increase these rates, hopefully we can recruit people from out of state, and this will be more of a destination state for people that are providing anesthesia services in other parts of this country.
Okay, thank you.
Thank you, Representative. Other questions or comments from members of the committee? Seeing none, thank you for your testimony this afternoon. Next, we have Dr. Kristen Winters, followed by Dr. Daniel Fries, followed by Dr. Kourosh Param, followed by Ben Shaken, who is not a doctor. Dr. Winters, are you with us? Dr. Winters is not accepting the promotion. If you are testifying remotely, you are going to get a notification from our committee clerk that you're being promoted to a panelist. You have to accept that if you'd like to testify before us this afternoon. We'll give a couple more minutes, if not, but then we'll skip over her to Dr. Daniel Fries. No, Dr. Fries. Is Dr. Param with us?
Yes, I'm here.
Hello, Dr. Param.
Good afternoon. Is it okay if I start?
It sure is.
Great, thank you. Good afternoon, Senator Lesser, Representative Gilchrist, and other distinguished members of the Human Services Committee. My name is Kourosh Param. I'm a professor of surgery at University of Connecticut School of Medicine and an otolaryngologist practicing at UConn Health in Farmington. I'm the immediate past president of Connecticut ENT Society and the also immediate past president of the American Society of Geriatric Otolaryngology. I'm here to represent 800 physicians and physicians in training in dermatology, ophthalmology, otolaryngology, and urology in support of Medicaid rate increases. We want to thank you for this committee's hard work and their special attention to this issue and raising a flag on how critical this issue is to the people of Connecticut. As you know, Connecticut's Connecticut's Medicaid program serves approximately a quarter of its population. And the Medicaid recipients struggle to access care, including primary care and specialty care. The lack of access has had dire consequences. Unlike commercial insurance and Medicare, too few physicians and other healthcare providers in Connecticut accept Medicaid. The main reason, of course, is the poor reimbursement. And this applies to both primary care and specialty care, including the specialties that I identified. I work in the state facility, so access is not restricted to anybody. So about a quarter of my patients are Medicaid patients. And I get to witness daily the challenges that this patient population faces. First, there is an ENT within 10 to 15 minutes of the majority of our Connecticut's population. But in order for Medicaid to see Medicaid recipients to see an ENT, they oftentimes have to travel from all corners of the state to come to UConn Health for their care. That's sometimes an hour and a half drive. Second, there is often a significant delay in provision of care to this population, and in part because it takes time for them to identify which provider will accept their insurance, either for themselves or for their provider to direct the consult or referral to. So what does that translate into? Where oftentimes it translates into more advanced disease. A disease that we commonly take care of is throat cancer, and when it's more advanced, it becomes more difficult to treat, survival outcomes are compromised, and it becomes more expensive. Another example, I can give you a more common example, is where patients actually end up going to the emergency room for their care is recurrent tonsillitis, a simple but common issue that oftentimes is resolved by referral to an ENT for tonsillectomy. And third issue, which is same as what Dr. Sachs pointed out, is that there is significant disparity as a result of the low reimbursements. A large portion of Medicaid recipients belong to racial minorities. That means that a small pool of Medicaid providers also contributes to disparities in the healthcare. numerous studies have shown
Doctor?
that Medicaid. Oh, sure.
Yeah, your
Thank you.
time is expired. If you could summarize, please.
Of course. So in conclusion, we deeply appreciate the committee's work and attention to this matter. And we hope that the Medicaid reimbursements and mirror those of 2023 allowable medical rates before the end of 2024. Thank you for your attention.
Thank you so much for your testimony, Doctor. Are there any questions from members of the committee? Seeing none, thank you for being with us this afternoon.
Thank you.
We're going to go now back to number 32, Dr. Daniel Freese. Dr. Freese, are you with us?
Yes, I'm here, though my video doesn't appear to be. Okay, there we go. Sorry. I am currently on shift, so I apologize for the weird view, but wanted to take a couple minutes to give you some testimony from the emergency department standpoint. My name is Dr. Daniel Freese. I'm an attending emergency physician at Hartford Hospital. I'm also a resident of West Hartford and the legislative chair and past president of the Connecticut College of Emergency Physicians. It sounds like you've received a lot of testimony today regarding the disparities in care and poor access to care, if any access to care for the Medicaid population in our state. I wanted to reiterate a couple things from the ED standpoint. I provided some written testimony as well, which is slightly more thorough. But the two main issues are the inability to get on-call services to the emergency department, necessitating transfer to places like Hartford Hospital and some of the larger institutions, as most of the community sites are losing their on-call physicians. For example, if you show up with a broken leg or a potential stroke to an outside hospital, there may not be a neurologist to take care of you. There may not be an orthopedist to take care of you. Necessitates transfer, delays in care, and moving you out of your home environment or home community in order to get care. Then once you are seen in the emergency department, there's often no one to take care of you as an outpatient. If you have Medicaid, you're limited to very small amount of clinics in the state, usually resident run, or some community health centers, which have very limited services, particularly for specialty care. So even if we take care of you in the emergency department to the best of our ability, once you're discharged, it's very difficult to get follow-up care. And finally, fortunately, we have not seen ED or hospital closures in Connecticut recently, but across the country, despite the sentiment that you'll see in the news and the media often that hospitals are making all this money, hospitals are closing across the country, more so in the past few years, but it continues to happen now. And one of the main reasons cited is the low Medicaid rates and the cost associated with providing emergency care to the Medicaid population, as we're mandated by EMTALA to always take care of patients, which we desire to do. It's a privilege to do that, but it does put a strain on hospitals and emergency departments, particularly in the communities that are underserved the most, because they have the highest amount of Medicaid patients and reimbursement. I'm happy to answer any questions, but wanted to reiterate some of those points for you today. Thank you.
Thank you, Doctor, and appreciate you making time for us in the busy emergency room. Are there comments or questions from members of the committee? If not, thank you for what you do and for your testimony this afternoon. Next, we have Ben Shaken, followed by Ashley Van Meter. Good afternoon.
Good afternoon, Mr. Chair, members of the committee. Thank you for having me this afternoon. My name is Ben Shaken. I'm the Director of Government Relations at the Connecticut Community Nonprofit Alliance. We are the association that represents community nonprofits across Connecticut. I am here to testify on House Bill 6885. Again, thank you for raising this concept. Bill would increase Medicaid rates. You've heard a lot about it, and I'm here to ask that you include Medicaid rates for community nonprofit services. I have two thoughts. One is just to give some context for our services. We did a study, a cost study, with a representative sample of providers back in 2014, fiscal year 2015. And back then we found that Medicaid rates set by the state, as you might imagine, don't cover the cost of care. The top loss for the top 10 behavioral health procedures by volume was more than $27 million for approximately 250,000 service hours is what that study found. And since then, rates have only increased once, 2 years ago in 2021, by 4%, while demand for services has increased and the number of Medicaid recipients in the state has also increased. As you know, Medicaid also funds a variety of other community nonprofit services. That's just an example. Just wanted to sort of highlight some of the conversation that has happened today. First, to just associate myself with the remarks of Sarah Egan earlier today related to rates, and say that everything that she has said about the child system matches with the experience that we hear from providers, but to expand it to say that it also matches the experience that we hear from providers as it relates to systems that serve other populations, adults in need of mental health and substance use treatment, et cetera. And then just sort of the line of questioning that's happened over the last few minutes around whether to do a study or fund rates. I would agree it's a both and situation, and I just point out to the committee that the Medicaid line item in the state budget is projected to lapse $200 million this year, 163 million after it's been used to offset some deficits in other DSS line items, but that's a lapse that tracks with every year for the last number of years. So there's money in that line item that if the executive branch wished to increase Medicaid rates, they could do so without express legislative permission. They would obviously need to come to you with a state plan amendment. You would go through your approval process, but they have not. And so we think it's really important for you as a committee, as the legislature, to provide some pretty specific direction to them about your desire to increase rates for these services. You've obviously heard from a wide variety of disciplines that I don't represent today. It's a very big issue, much bigger than community nonprofits. I'm not here to tell you how to prioritize, because what I would say is prioritize community nonprofits. But just understand that the dollars, this is a very large line item that has a very large lapse and has for a number of years. And so we hope that you as a committee can provide some really specific direction for the state to get this ball rolling. So thank you.
What for the committee, and also particularly for the chairs, both of whom are new, why do we have a persistent lapse? You know,
it's a great question. I think there's a few reasons. One is that we have just come out, just meaning over the last 3 years or so, from 4 years, from a period of pretty sustained budget crises in the state when we did not increase these rates. And so you've heard the number 2007 thrown around a lot by folks today. It's a number that we use. It's the last time there was a small cost of living increase on the rates and contracts that the state pays for services. A lot has happened since then. It's also happens to be the year before the economy collapsed. But you know, the ACA passed since then. The Medicaid expansion has happened and has expanded further, and so the Medicaid system has grown significantly since that time period, and we haven't caught up. We don't do regular rate increases across the Medicaid system. There's an administrative process where things are occasionally reviewed, but none of the, or very few of the rates that my members work with have had that review. And in times when there have been increases in either broadly, as there were in 2021 for clinic-based behavioral health services, or at certain times acutely, they're to address like an urgent crisis in need. They're not because, you know, for example, earlier this morning, Sarah mentioned the ICAPS program that recently received a rate increase, and it's because providers said, look, we're going to close, like we can't do this anymore, and this program is essential. And so they received a rate increase, but it happened outside of the sort of normal administrative review process. So there are states that require the legislature take a systematic look at Medicaid rates and whether they meet the cost of service. We are not one of them. And so you only look at this when you want to as a legislature, which isn't to say you don't look at it, but it means you react to advocates who ask for changes rather than having a more systematic approach.
Okay, I hear the need, your desire or expressed need for rate increases, and I appreciate that. I guess I have just more of a basic budgetary question, which is, you know, if we're being told that the Medicaid program is going to cost X and consistently it's costing Y, and it's yielding these large, you know, massive lapses, why are we not getting accurate? Why are we not budgeting correctly? you know, I mean, I understand you want us to raise rates, but we're obviously appropriating more money than we need. And I'm trying to figure out why.
It's a good question. I don't know the answer to it. I'm not sure that I've seen a full explanation in particular as we've emerged from the pandemic as to the lapse. I think there's pieces that have been talked about, one being the effect of the pandemic on how folks access medical care, or how they didn't. The other one being there's been this influx of federal dollars that have increased the state's matching, federal match for Medicaid in a variety of ways through some of the federal pandemic relief legislation. And the state has used those dollars primarily to offset the state costs in the Medicaid program. And so while those dollars are going away, maybe we will see the lapse also go away, but there hasn't ever been, as far as I can see and what's been presented to you and therefore as public, a really comprehensive explanation for why the legislature and the governor are appropriating a set amount of dollars for Medicaid and why it's consistently lapsing, 7 or 8, 10% of what the appropriation has been.
Okay. Yeah, I know on the private payer side, we did see people accessing less healthcare at the beginning part of the pandemic, but then last year we had a huge increase in demand where people caught up, and now every insurance plan is technically underwater for 1 year because utilization soared after people delaying their procedures. But I would think that would likely, if it were just a question of consumer behavior, we would see something similar on the Medicaid side, and obviously that's not the experience at all. So that's why it's an interesting question.
Right, and there's been this question of whether we have access the way we should have it in Connecticut, and it's also, I think, a pretty difficult question for me sitting on the outside as an advocate to get to the bottom of. The state is required to submit a report to the federal government certifying they're in compliance with the federal access statutes. And I was feverishly trying to find what I wrote about it whenever it was. I can't remember when it was, sometime in the last 8 years, which is as long as I've been doing it. But interestingly, they found it in that report they're asked to compare what we do to our surrounding states, one of the things the feds ask for. And they found that they couldn't, at least in the clinical based behavioral health side, make that comparison. Are our rates hurting access compared to New York or Massachusetts or Rhode Island, because they pay so differently than we do. So I can't sit here today with any data saying, yes, the rates are adequate to ensure access, or no, they're not. All I can tell you is our members, the nonprofits that are providing these services on the ground, report pretty routinely that their clients have trouble accessing services and are routinely sort of facing waiting lists and other issues when they're trying to get into care.
Thank you. Other questions from members of the committee? Seeing none, thank you.
Thank you.
Next, we have Ashley Van Meter, followed by Dr. Thomas Bladdock, followed by Anna Dorgazi.
Hi there, my name is Ashley Van Meter. I'm with the Association for Accessible Medicines, the Generic and Biosimilar Trade Association. I'm here specifically to talk about the Affordability Board Bill 1202. One of the, I think, major themes that I think we wanted to highlight is we've continuously worked with the state, with former Comptroller Lembo, also former Insurance Chair Scanlon, to put in place some of the prior laws on transparency in Connecticut. And we've worked in other states to develop the Affordability Board, specifically Maryland, which was the first, and many that followed. I specifically worked with them. And we just noticed some of the things in the bill, I think, might lead to a capturing of data that won't necessarily be useful to the state to determine what is actually being spent on the most expensive drugs, or drugs that are increasing costs at inappropriate rates. One of the things that we've seen in some of the other states, and why they're changing their affordability boards now, they did certain triggers that are responsible for pulling in the kind of data and drugs that will be reviewed. And unfortunately, some of the triggers were so broad that they started pulling in, for example, drugs that the state does spend a lot of money on, but they're actually very cheap, but many people take it. For example, generic Lipitor, it is cents on the dollar for people to take it. The average copay for it is under $5, but so many people take the generic versions that the state tends to spend a lot of money on it. And so states were pulling in data about that drug, but it wasn't something that was driving costs. Also, I think it's important. So there needs to be a definition to deal with the volume, but also looking at maybe specialty drugs that only a handful of people are taking, but cost the state a lot of money. And so one of the things that we would suggest is increasing the WAC floor, for example, to $100. It currently, for transparency, in Connecticut is at $40. Also, making sure that the increases are not based on percentages alone. I think also importantly to break out so that you are able to look at generic and brands and that they're treated separately with different triggers so that you're getting accurate data for both. So you're seeing if, for example, a brand is increasing in cost, what is happening in the generic market? Is it appropriately genericized with enough competition so that it's driving down costs? And so that generics are not being disadvantaged with, for example, formularies or things like that, so that the state does save money and folks are getting the medicine that they need. And so we'd be happy to work with the committee and the sponsor to talk with you about what we've learned in all these other states to make sure you're getting the appropriate data. And I should say that last year alone, generics and biosimilars did save Connecticut $4.3 billion. And so that is, we want folks to have access to affordable medicines that they need and would be happy to do any work that is needed with the committee.
Thank you, Ashley, for your testimony. I will note that I think you're the first person all day to testify in person on this bill, which is remarkable. But I think, speaking for the leadership of this committee, I think we would welcome the opportunity to work with the generic industry to better understand your concerns and how to best tailor this bill.
Thank you so much.
Are there questions or comments from members of the committee? Just one other one question for you. Did you submit written testimony?
I haven't. We've submitted our suggestions, but I'm happy to put something on the record and maybe some suggestions on how we would change the bill or even data that we've found in other states, if that's useful to you.
That would be great. Thank you very much.
Uh-huh.
Other questions or comments from members of the committee? Seeing none, thank you very much. Next up, we have Dr. Thomas Bladek, followed by Anna Doragazi, followed by Ivelisse Correa. Okay, just a reminder, if you want to testify online, you have to accept the promotion to a panelist or we cannot hear you. So we will go on to Anna Doragazi.
Hi.
Hello.
Good afternoon, Senator Lesser, Representative Gilchrist, ranking members and members of the Human Services Committee. My name is Anna Doragazi. I'm one of the policy directors at AARP Connecticut. And thank you for the opportunity to be here today to share our support for SB 1202, an act concerning prescription drug affordability. Prescription medication doesn't work if you can't afford to take it. And SB 1202 includes 3 distinct proposals that would improve transparency and lower costs for consumers. I'm going to focus my remarks on 2 of the proposals that are contained in the bill, but our written testimony that we've submitted addresses our support for all 3. First, SB 1202 includes a proposal related to reference-based pricing, which we strongly support. Millions of older adults are soon going to have access to lower prescription drug prices thanks to provisions in the Inflation Reduction Act of 2022, federal legislation that will require Medicare to start negotiating prices. Negotiations are going to begin this year. There was actually a big release from CMS yesterday about some of the parameters for those negotiations. And the new program will begin to provide negotiated prices for selected Medicare Part D drugs in 2026. As many as 60 drugs for both Part B and Part D could be selected and negotiated before 2029. Sections 1 through 3 of 1202 would allow Connecticut residents who are not yet Medicare eligible to take advantage of the Medicare negotiated price or maximum fair price for certain high-cost drugs. It would accomplish this by using that maximum fair price set at the federal level to establish an upper limit on what any state entity, health benefit plan, or participating ERISA plan can pay for the referenced drug. We also support Section 4 of the bill, which would establish a prescription drug payment evaluation committee to recommend upper payment limits on drugs to the Office of Health Strategy. This idea is similar to healthcare rate setting and state regulation of public utilities, where you have a group of appointed individuals setting limits on what purchasers may pay for certain goods and services after reviewing relevant price information. We do have 3 suggestions for how to strengthen this proposal. 1, provide the Prescription Drug Payment Evaluation Committee full authority to implement and not just recommend upper payment limits. Our written testimony has sample language taken from Colorado statute that we think would be good at doing this. Second, we would recommend establishing a price increase threshold that would trigger an affordability board by the Payment Evaluation Committee. And third, we recommend adding conflict of interest guidelines for committee membership. This is really critical to ensure that members are primarily concerned with making prescription drugs more affordable to consumers and not with protecting the interests of their employers. We really appreciate that the committee is willing to take this on. We'll note that a lot of the language in this bill is almost identical to SB 10, which you heard a week ago. And thank you for the chance to come and share our support for this version of the bill.
Thank you, Anna, for your testimony. We, as I think you've noticed, have not had a ton of people speaking before us about this proposal, but we did get some written testimony, and some of the written testimony from industry trade groups, it really, more than anything else, it really focused on legal arguments why we can't do this. And I was wondering if you had an opportunity to read the pharma testimony, which made a variety of legal arguments. I don't know if that's something that your team at AARP has had a chance to look at and respond to.
Yeah, I didn't see their testimony today for 1202. I suspect it's probably similar since the language of 1202 is similar to SB 10, and I did read just about all the testimony for that one. But I think, assuming it's some of the similar arguments, I would say that the model and the sections 1 to 3 of 1202 seem to be modeled on a model bill from the National Academy of State Health Policy. And that model legislation was really carefully crafted to avoid violating patent protections because it's explicitly not price setting. It sets limits on what purchasers can pay, which leaves manufacturers free to set the prices for their product. So it's a subtle difference, but it regulates something that it's able to regulate rather than engaging in price setting. I think because it's also clear that these provisions apply to purchases within the state, it should avoid some of the constitutional challenges that could come up related to the Commerce Clause.
Thank you. And I think that I read your written testimony, which goes into some detail with your recommendations, and certainly appreciate that. Are there questions or comments from members of the committee? Seeing none, I think you're off easy.
All right. Well, thank you all very much.
We're going to go now back to Dr. Thomas Bladek, followed by Ivelisse Correa, followed by Bruce Stovall, followed by TJ Clark.
Good afternoon, members of the committee. I appreciate your time, and I'll keep my comments brief. My name is Thomas Bladek. I'm a practicing anesthesiologist and chairman of the Department of Anesthesia at St. Vincent's Medical Center in Bridgeport, Connecticut. I'm also chair of the anesthesia department at Quinnipiac University's Netter School of Medicine. And in my administrative and business roles, I'm president of Integrated Anesthesia Associates, the Fairfield division. And I just wanted to say a few words in support of the increased Medicaid payment rules on behalf of the medical specialty that really has not seen and had a change in Medicaid reimbursement rates in over 20 years. IAA, Integrated Anesthesia Associates, is the largest physician-owned provider of anesthesia services in Connecticut. We have 175 anesthesiologists and over 200 CRNAs. And we've been a provider of quality and affordable healthcare services for patients across the state since the 1960s. We provide 24/7, 365 days per year anesthesia coverage and services in a number of the underserved communities where we're the provider of the anesthesia services in several of the largest hospitals. We are a hospital-based service provider. We're part of a team which provides the safety net for the poor and vulnerable who are unable to receive the care that they need in the outlying communities. And we've seen the costs of care rise considerably over the past 10 years. The Medicaid enrollment has reached over 1 million covered lives in our state of 3.6 million residents. However, the hospitals in these underserved areas have seen the state and governmental payer mix exceed 75% of their admissions. So to kind of put it in perspective, number-wise, very simply, we get reimbursed $100 per unit from the private insurers. We get reimbursed $22 per unit from CMS and Medicare, and we get reimbursed $14 per unit from Connecticut Medicaid. We can't cost shift our Medicaid and Medicare underpayments to the private insurers or to continue to ask for additional subsidies from the facilities which we staff. And I just wanted to make that distinction. RVUs, which were discussed in the leadoff comments this morning, are not the same as the unit rates in anesthesia. Anesthesia unit rates are much lower than RVU rates in other medical specialties. As a result of this, we've seen an exodus of a number of very talented staff from our state to states where there is higher reimbursement levels and more competitive wages. The wages have not only lured away our talented practitioners and clinicians, but our talented students from the area medical and nursing schools we've spent 4 years training. So in conclusion, I'd just like to say, I personally feel that further study is not warranted. Dollars saved could be more appropriately spent on funding clinical programs that will benefit our current state residents on Medicaid and hopefully curtail further MD and RN migration from the state. Thank you for your time.
Thank you for your testimony. Are there questions or comments for the doctor? Seeing none, thank you for being with us this afternoon.
Thank you.
Next, we have Ivelisse Correa, followed by Bruce Stovall, followed by TJ Clark.
Hello, can you hear me?
We can.
Okay, perfect. So I had this speech written this morning and then I decided to pretty much chuck it. You guys have heard a lot of statistics today. You guys have heard a lot of numbers and there were a lot of unanswered questions. So even though I am attending in my capacity as, the executive director of Good Trouble Advocacy and with BLM 860, I wanted to talk about my experience as a parent of a child with autism who did receive services through Husky. My son's 11 and he was diagnosed at the age of 3 with autism. I have met every barrier and me and his father found that it was more beneficial to our son to spend, I think I was spending about 40% of my check at the time when I was working in insurance pre-pandemic. And there was absolutely no wait list with private insurance, but with Husky, there was an 18-month wait list for occupational therapy services at CCMC. You would receive about 9 weeks of service and then you go back on the 18-month wait list. That's unfortunately what happens with families that, go through Husky. Around the time he was 4, when we wanted in-home ABA services, everything had a wait list. I'm probably still on quite a few of those wait lists. I should call and make sure that they've removed me from all of them. But we actually ended up finding service through a new provider through Facebook and had responded to a Facebook ad. Beacon Health Options was not able to assist us in any capacity. Husky as a whole does have poor coverage, they say, from the neck up. That means dental, oral, and mental health care is often minimal and insufficient. And we're leaving federal tax dollars on the table, and it's not doing anyone any good. We can do earlier interventions now rather than continuing to let these kids go through what they go through. My child was blessed to have parents that decided to spend a significant portion of their paychecks on his care rather than go through the state medical system. And I would hope that those who aren't as lucky are still able to access the quality of healthcare that my son was able to access simply because we were willing to pay cash and out of our pocket, or also go through private healthcare at a significant cost. Thank you. And I'm happy to answer any questions as well.
Thank you so much for your testimony. I think you're the only parent to be talking to us today. So I think it's really important to hear from folks with lived experience. Is Representative Hughes, you have your question?
Yeah, thank you, Mr. Chair, and thank you so much for your testimony. I hear a lot from parents that are so frustrated that they just go to private pay, bypass the whole insurance system altogether for behavioral and occupational, especially early intervention for their children. And unfortunately, we don't have good data on that, but it does speak to the the provider shortage and the provider Medicaid reimbursement rates, but other administrative rates, administrative barriers that I think are really becoming terrible barriers to access for these young people. And I just appreciate your experience, and I wanted to ask how your son is doing now.
He's doing a lot better. So it's taken a lot of work. He was actually in crisis during the pandemic. It was very difficult because there was also the lack of in-person care at the time. We were able to get around that, and he's great. I do hope that we continue to pay out of pocket for his health care. So despite the fact that, we do qualify for Husky. And I want everyone to have the same care and see the same progress that I've seen with my own son in their homes. So he's a fantastic kid. I know my teenager sometimes comes to the Capitol if I'm there. My 14-year-old absolutely loves his brother. And if you ever met him, he's a fantastic kid. So
that's great to hear. And is he in school?
Yes, he is in the 6th grade.
And is he getting any early intervention services in school-based services?
Yes. So those are limited. He was part of Birth to 3 as well. So we got him enrolled at about 18 months. He's now in a mainstream classroom. So he's regular education with some supports. He does have one-on-one para in a regular classroom. So we continue to work with him, and out-of-home services coupled with in-school services have been much more beneficial than 30 minutes a week of OT or things like that in school. But not to say that we don't need those services in school. We definitely do, but together, because a school-based environment is much more different than home.
Great. Thank you so much for your testimony.
Thank you.
Thank you, Representative. Other questions or comments from members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Next, we have Bruce Stovall, followed by TJ Clark, followed by Thomas Burr, followed by Dr. Michael Crane.
Okay, thank you. Good afternoon, esteemed members of the Human Services Committee. My name is Bruce Stovall. I represent Oak Hill. We are established in 1893. We're the largest private provider of disability services in Connecticut. We provide a wide continuum of programs and services. We operate 65 group homes, an accredited special education school, several camps, an assistive technology center, as well as a number of specialized programs. We employ over 1,700 individuals and operate in 50 plus towns across Connecticut. I'm here to testify in favor of HB 6885. I'm going to go right to kind of our numbers here, where again, the situation is dire across the nonprofit field for attracting and retaining employees. Our DSPs, our direct service professionals, we have over 800 slots across our system. Approximately 150 are currently vacant. And again, that's curtailed our services, curtailed access to people on the waiting list. We currently have, we have temporarily vacated 3 of our homes. And due to our staffing shortage, we currently have 37 empty beds across our system that could certainly address the waiting list in a positive way. Again, our inability to pay a competitive wage is at the core of this issue. You've heard it all afternoon. We compete against the Walmarts and the restaurants. And again, it's a profoundly more responsible position to take care of your loved ones and human beings as opposed to the other options that frankly pay just as much. So again, we're all for, I know we have sympathetic ears here and, you know, based on other past hearings, et cetera. So I do want to just come out publicly in support of this and getting the nonprofit sector as a key partner to the state back on its feet and back with the ability to kind of be more accessible and meet the needs of all these individuals needing services. And I'm done. I know it's been a long day. I thank you. Happy to take any questions.
Thank you for your testimony. Are there questions from members of the committee? Seeing none, thank you for your testimony this afternoon. Next, we have TJ Clark, followed by Thomas Burr, followed by Dr. Michael Crane. Mr. Clark? Oh, you're muted, TJ.
I'm sorry about that. Good afternoon, everyone.
Good afternoon.
Thank you for allowing me the opportunity to speak. To Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the Human Services Committee. My name is TJ Clark, and I'm the Executive Director of the Connecticut Oral Health Initiative, located in Hartford, Connecticut. Our mission is to strengthen and safeguard access to quality, affordable oral health services for all Connecticut residents, and we desire that all Connecticut residents will have equal opportunity to obtain the services needed to maintain good oral health. COHI is the only statewide organization that solely advocates for equitable oral health service policies. We are the only statewide advocacy organization as well that addresses these needs for all Connecticut residents. Today, I am providing testimony for HB 6885, and that concerning Medicaid payment rates. Every child deserves a chance to be healthy and to reach their full potential in life, but many children have health problems and make it difficult for them to learn and succeed. We want all young people in Connecticut to be healthy and thriving. School-based health centers play a vital role in helping young people in their medical, mental health, and oral health concerns. Healthy kids make better learners. We are urging the Human Services Committee to pass this bill and with establishing Medicaid reimbursement with respect to dental cleanings. With the passage of this bill, it will allow school-based health center sites to continue to offer support for young people and move closer to sustainability. This bill will allow school-based health center sites to offer means of support for every young person in school as they thrive, that this is critical for their future. Thank you for supporting the school-based health centers and ensuring that these 3 critical health services, medical, mental health, and oral health, are included in the care model. Maintaining good oral health is vital to overall health. Unfortunately, oral health does not receive the same attention as other healthcare services. Studies have shown that poor oral health has been shown to cause low self-esteem in mental health services. In closing, We urge you again to pass this bill. We are in support of this bill, and Connecticut must meet its obligations to improve oral health care for all its residents. Please consider passing this bill, and for any questions, please don't hesitate to reach out to me. Thank you very much.
Thank you so much for your testimony. It's good to see you. I see Representative Cook has her hand up.
Thank you, Mr. Chairman. And it's great to see you, TJ. Thank you so much. I love to see you in this role and your dedication to everything that is all things oral health, especially the children. So I just wanted to just give you a shout out. No question specifically, but just wanted to thank you for your dedication and all the great work that you do.
Thank you, Representative Cook. I appreciate that.
All right. Any other questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Look forward to working with you.
Thank you, Senator.
Next, we have Thomas Burr, followed by Dr. Michael Crane, followed by Dr. Kara Benedictus.
All right, good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Thomas Burr. I'm the Public Policy and Affiliate Relations Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today in support of SB 1205, an act concerning Medicaid reimbursements for peer recovery support services. NAMI is dedicated to building better lives for those with lived experience with mental health conditions and their families. As the country's largest grassroots mental health organization, we know that getting access to treatment in a timely fashion is key to recovery from a mental health condition, and that peers can be a huge and positive addition to any treatment team or path to recovery. Another respected mental health organization, Mental Health America, states, quote, peer support is an evidence-based practice for the treatment of mental illness. Both quantitative and qualitative evidence indicates that peer support lowers the overall cost of mental health services by reducing rehospitalization rates and days spent in inpatient services, increasing the use of outpatient services. SAMHSA, the Federal Substance Abuse and Mental Health Services Administration, relates the following regarding peers, quote, peer workers offer encouragement, practical assistance, guidance, and understanding to support recovery. Peer support workers walk alongside people in recovery, offering individualized supports and demonstrating that recovery is possible. They share their own lived experience of moving from hopelessness to hope. They share tools that can complement or replace clinical supports by providing strategies for self-empowerment and achieving a self-determined life. They support people in recovery to connect with their own inner strength, motivation, and desire to move forward in life, even when experiencing challenges. I would like to highlight the preference of the Keep the Promise Coalition, who you heard from earlier, which would prefer that the language in this bill be changed to align with the language in SB 976, which would require DPH to handle certifications. Frankly, the ability of peers to be paid for their time is long overdue here in Connecticut. In our opinion, this bill will make it possible for that to finally happen on a widespread basis. I have heard some of the concerns from others, but please don't let the perfect be the enemy of the good. And in this time of mental health crises, let's get this done this session. We can always fine tune this in future sessions, as certainly the mental health advocacy community is not shy about giving the legislature guidance based on the benefits of its lived experience. Therefore, in summary, NAMI Connecticut, we support SB 1205. Thank you for your time and attention. I'll be happy to answer any questions you might have.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next, we have Dr. Crane, followed by Dr. Benedictus, followed by Greg Allard, followed by Olivia Montes, followed by Catherine Riley. And then we're done.
Can you hear me okay?
Yes, we can, Dr. Crane. Good to see you.
Very good. Nice to see you too. Senator Lesser, Representative Gilchrist, Senator Seminara, Representative Case, and members of the committee. My name is Dr. Michael Crane. I'm a radiologist and have worked for the past 35 years in a private radiology group with 12 other radiologists. Our radiology group owns Guilford Radiology, recently purchased Madison Radiology, and we provide radiology services for Middlesex Hospital. Today, I'm representing the Radiological Society of Connecticut in strong support of House Bill 6885, an act concerning Medicaid payment rates. We appreciate the committee raising this bill for a public hearing today. This bill will eliminate in 5 years the disparities in reimbursement between Title XIX, Medicaid, and Medicare. Matching our Connecticut Medicaid rates to the national Medicare rates will make a statement to all that Connecticut puts equity at a top priority, irrespective of one's socioeconomic status. The sooner we do this, the better. The very low fee schedule for Medicaid patients not only promotes a two-tiered system, but it also hurts the small private practice radiology offices in Connecticut, particularly in underserved parts of our state. In 2015, the Department of Social Services made severe cuts, about 42%, in reimbursement for procedures involving MRI, CT, ultrasound, X-rays, and mammography that occur in the physician's offices. What happened as a result? Access to these important imaging services was reduced. Some patients had to scramble and find another outpatient facility or went to the hospital for imaging procedures, which ended up costing the state far more. If the current rates for Medicaid remain unchanged, patients will continue to have fewer non-hospital facilities accepting their insurance, even for routine outpatient and screening exams, creating another barrier to those seeking care. House Bill 6885 will begin the process of rectifying the fee inequities. We hope that you will pass this bill along with the added funds to implement it in the budget for fiscal years 2024 and 2025. Thank you.
Thank you, Dr. Crane. Are there questions or comments from members of the committee? If not, it's good to see you this afternoon.
Thank you.
Next up, we have Dr. Kara DeBenedictis.
Hi, can you hear me?
Yes, we can.
Hi. Good afternoon to Honorable Co-Chairs Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Caroline DeBenedictis, and I'm a board-certified ophthalmologist, and I specialize in providing pediatric eye care to the people of Connecticut. Thank you for allowing me to come in today and speak with you, and I'm testifying on behalf of the Connecticut Society of Eye Physicians as an executive committee member about Bill 6855. With this bill, I'm very grateful to the committee for placing this in the spotlight on this critical issue. I'm fully in support of increasing Medicaid rates, and I'm hopeful that these changes can occur as soon as possible, as opposed to over a few years' time. I have previously submitted testimony and would like to speak candidly about my experience providing eye care to the children who have Medicaid in Connecticut. My area of expertise is pediatric eye disease, pediatric eye surgery, and adult strabismus surgery, where I straighten eyes that are misaligned. And my story is far from unique, as this is occurring for doctors across the whole state. I work in private practice, and one of my offices is in Waterbury, where there's a disproportionate number of Medicaid children that I see. I am the only pediatric eye specialist that takes Medicaid in that area. If I can't see them, many of those children don't get seen at all, or there is a huge delay in care that can cause significant problems for them later in life. I was forced recently to make the difficult decision to limit the number of Husky medical pediatric patients that I'm seeing in my practice. This is what drove me to get involved and led to me speaking to you today. The problem is that I don't want to stop seeing these Medicaid patients. I want to keep seeing them. They're my kids that need my help. And the type of medical problems that I see really are not seen by most other eye care professionals. The low reimbursement rates for Medicaid, though, it's just not sustainable for me in private practice, and it's not viable as a financial model. It's a significant healthcare crisis happening right now. Without doctors in private practice to keep their doors open seeing these Medicaid patients, it's going to have a huge impact on patients, their families, and the state long term. If they haven't already, most doctors are going to either stop taking Medicaid altogether or drastically reduce their numbers, the same as I've been forced to do most recently. And I understand the budgetary pressures that you are under are very out of my realm of expertise. And so I know this is a very difficult ask, but I think the patients need help now. I see it every single day. I'm here on behalf of other doctors, but also of the patients. And the patients don't get up here and testify on their own behalf. And they need help. They need our help to get medical care, quality and available medical care. And I think that waiting a few years, I predict disaster. If the Medicaid rates were increased to at least the Medicare rates, I'd be able to see those patients now. I would just open the floodgates and let them all in, and I'm ready to do so. I've dedicated my life to helping children, and I want to continue to do so, and I'm asking you to help me do that. We have a really unique opportunity in ophthalmology and pediatric ophthalmology to not only treat eye disease, but prevent vision loss and vision disabilities. And those things cause lifelong problems. And I think we need to invest in our future by preventing these poor outcomes and decrease the burden of preventable medical disease. And so I ask you to help us and help provide care to our most vulnerable populations. Thank you. And I'm open for questions.
Yes, thank you, doctor. And I appreciate, one of my closest friends is a pediatric ophthalmologist, so I been lobbied on behalf of your specialty for a long time.
Thank you.
Just had a sort of a really dumb question. We talked many hours ago with the state's Medicaid director, and he pointed out some difficulty in tying things to Medicare rates because not all covered services have Medicare equivalents. Does pediatric ophthalmology, is it just that you have the same rates that adult ophthalmology receives, or how does it work? Because I imagine there are not too many pediatric patients on Medicare.
No, they are on Medicaid. They're on Husky Medicaid insurance, and that's a separate set of reimbursement rates. So the Medicare reimbursement rates are significantly higher than Medicaid. I get approximately $30 for many visits of patients that I'm seeing. The calculations that I've done, I would have to see over 90 patients in one day to kind of make it possible and sustainable. I already feel like I spend too little time with patients and patients wait too long. And, it's just not viable. It's not sustainable. It's not good for our kids.
Yeah, I'm sorry, and I articulated my question badly. I know the difference between Medicare and Medicaid. I guess what I'm asking is, when you are funded by Medicaid, are you right now the reimbursement rate that you get is tied to, at least in theory, is tied to some sort of Medicare rate? When you access that, are ophthalmologists paid the same for service regardless if it's a pediatric or an adult procedure?
Right. So it's based on the insurance. It's not based on whether it's pediatric or adult. But many of the services that I provide and the surgeries that I provide are not something you necessarily would do in an adult. But when we are reimbursed for adult surgery, such as strabismus, it's reimbursed at the Medicare rate, and it's separate.
Okay. So my question was, so if we're bringing Medicaid rates up to match Medicare rates, you're going to be able to fully bill for. Obviously, you may have issues with whether or not Medicare rates are sufficient, but you're going to be able to bill for all of the services that you provide.
Yes.
Okay. Thank you. Are there questions or comments from members of the committee? If not, thank you for your testimony.
Thank you.
All right. Next, we have Gregory Allard, followed by Olivia Montes.
Good afternoon, Senator Lesser, Representative Gilchrist, and other distinguished members of the Human Services Committee. My name is Greg Allard, and I am the president of the Association of Connecticut Ambulance Providers and the vice president of American Ambulance of Norwich, Connecticut. I did submit written testimony today, and it is in support of Section 3 of the House Bill 6885, the Act concerning Medicaid payment rates. And I do want to get to one particular point in my testimony. It says that our association, amongst many other EMS organizations, some of which you heard today, are proposing at a minimum the Medicaid increase of 90% of the Medicare rates across all billable codes for all ambulance services, and to meet 100% of the Medicare mileage reimbursement. In total, if the state were to spend $7.69 million to increase these rates, Connecticut would leverage federal reimbursement of another $15.26 million for a total of $22.95 million investment in EMS providers. Now, that data comes directly from the Department of Social Services. Our lobbying efforts were able to use FOIA and get the actual data numbers from the department for 2022, and we just applied the difference in rates to what was done last year across the EMS network or EMS systems. And those are the numbers that we were able to come up with. The majority of our patients are Medicare Part D, which is a 90% reimbursement by CMS. So, a significant number of that increase is federal reimbursement and not on the state. So if you were to determine that you couldn't afford to pay us the 7.69 million, we could extrapolate those numbers out for you and help you determine what those numbers are. But this is what we think that ask is. We also want to point out the unwinding project that's currently going on within the department. So they're looking to remove people from the Medicaid system, which means that anything that we're projecting out now will in all actuality be actually lower because of the unwinding program. So that's really what I wanted to make a point of. I know you heard from a number of other EMS speakers today, and they spoke very well on the particular topic. So I'll end my testimony there, and I'll be happy to answer any questions. Thank you.
Thank you, and thank you for your brevity. Are there questions from members of the committee? Thank you for your testimony.
Thank you.
Next, we have Olivia Montes, followed by Catherine Riley. No Olivia. Catherine, are you there? Catherine, I think you're muted.
Okay. Can you hear me now?
Yes, we can.
Okay. Good afternoon. Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. Thank you very much for here. Hold on one second, see if I can get this technology to work. It does. Okay. My name is Kathy Riley. I'm the legislative liaison from Gaylord Hospital. I wanted to comment on House Bill 6885. And as I said, I am from Gaylord, which is a 137-bed freestanding nonprofit long-term acute care hospital. And we care for hospital patients who need a longer stay than is expected in a short-term care hospital. Our patients are the sickest of the sick, often still on telemetry, on a ventilator, in need of IV medication or blood products, as well as intensive rehabilitation due to their complex medical issues. And they are under the daily care of a physician. We are respectfully asking that you consider the request for an increase in our daily inpatient Medicaid rate for the hospital, not needing a study, at least for LTACs. We have the data that will support our request for a rate increase. Currently, our daily Medicaid rate is about $700 a day less than the average cost of care for a patient at Gaylord. So it limits our ability to accept some Medicaid patients from our acute care partners. We did receive a 4% rate increase in 2021, and that was the first rate increase in almost 20 years. We are really looking for some parity in the healthcare payment system under Medicaid, as are so many other providers. Facilities that care for patients who don't need the care and services that our patients need are paid significantly higher on a daily basis. On average, for instance, an intensive rehab facility has a Medicaid rate of about $1,483 a day. And that's compared to the $950.89 rate for Gaylord. So we're asking for a $500 a day increase. It won't cover the whole cost of care, but it will allow us to accept more Medicaid patients. This will also help patients who sit in short-term acute care hospitals unable to go to a facility that can care for them and help them recover and not need to be in that hospital setting. So often we hear from our patients, they'll say to us, XYZ hospital saved my life and Gaylord gave me my life back. I mean, this was proven over and over time again during the pandemic. When patients can't go to one of the 2 long-term care hospitals in the state, they might be referred to an out-of-state hospital, the cost of which is significantly higher, not only for the state, but for the patient and their family. It can really negatively affect the patient's recovery. Or on the other extreme, the patient might go to a skilled nursing facility that really can't provide the care and treatment needed, and the patient winds up right back in the hospital. We appreciate the request, your consideration of our request. Our written testimony provides you details on the issues I raised today. And if you have any questions or need additional information, thank you. Just please ask. Thank you ever so much for your time and attention and your dedication to this very long day of testimony.
Oh, this is pretty short by public hearing standards, but thank you for your testimony, Kathy. And I see that Representative Cook has her hand up.
Yes.
Thank you, Mr. Chairman. Kathy, thank you for being here. And first, I want to thank you and your great staff at Gaylord for the amazing work that you all do. I encourage anyone that is listening, if they have never been to your facility or known anybody that's been in your facility and received care from your incredible staff, please take a tour. There's just no words. My mother-in-law was there for quite a while, and the amount of work that you all did with her was just fabulous and beyond what we could have comprehended, which takes me to my question. So obviously you're asking for $500 more on top of the $700 rate. And the amount of residents that you can care for or patients that you can care for, how many on a full capacity load?
We have the capacity of about 122 patients a day. We discharge about 1,500 patients a year. And right now, our Medicaid population has to be limited to 10% or less. I can remember a few years ago when we had 35, 40% Medicaid, and it just wasn't a sustainable model. It took us a good year and a half or two to get ourselves back in a positive operating mode.
And so in theory, you're having to turn that population away because of the reimbursement or lack thereof?
Yes. So our rate is $950 a day. We're willing to do $1,400, even though it costs us $1,700, because we are a nonprofit. We want to do our share for this community. I've been a nurse for over 50 years. So for me to say no to a patient, and in my previous roles at Gaylord, I was the director of admissions as well as care management. It's heartbreaking.
Yeah, I mean, I know the depth of the patients that you all serve, and to have to turn those patients away.
Or send them over a bridge to New Jersey. That's crazy.
It is, and I think that we need to be better than that. Is there another way, short of the reimbursement increase, is there another way that we could assist in helping the situation as far as the gaps and what you're receiving as far as to what you intake?
I think the reimbursement is the key to it right now. I think, there's a lot of services, as you heard from so many providers, that need, a change in their Medicaid rate. We then have a problem sometimes in moving the patient out of Gaylord. I mean, I've done care management for over 30 years. So I've been in the acute care setting and had, the experiences where I had nowhere to put my patients. And occasionally we even run into that.
Thank you. And thank you so much for your information, and thanks for your help. Thank you, Mr. Chairman.
Thank you very much.
Thank you, Kathy. Thank you, Representative Cook. Any other questions from members of the committee? If not, thank you for your testimony.
Okay, thank you.
At this point, at 4:59 p.m., we are now done with our list of folks scheduled to testify. We will be back here tomorrow at 10 for a joint public hearing followed by committee meeting with appropriations, and that will take place in room 1E and on Zoom. And with that, I would like to adjourn the